about sport, we think about hockey or soccer, that when we want to win a game, we need to stop the opposition scoring goals. We need to score goals ourselves. When we're thinking a lot about the work that we do in patient safety, it's about incident analysis, investigations, risk management, those sorts of things. And can we think about that in terms of defence and stopping bad things occurring? But it's not actually going to win us the game and improve our healthcare system. We need the offence as well. There are some critical things, interventions that we know works. We've got really good evidence around improving safety culture, having high-functioning, resilient teams. So Peter talked about team steps and CRM, structured handovers, communications, rapid response teams, co-design with consumers, IT systems with decision supports. So these are the interventions that have got quite good evidence around them. And I think probably from a clinical governance perspective, we're probably, most of the organisations that I work with, probably spending a little bit too much time on managing incidents retrospectively, undertaking investigations retrospectively, rather than doing these things that we know works. So the three questions to finish off for me are, how do we bring the patient voice to learning from adverse events? Are we taking a strategic systems-based learning approach? And are we getting the balance right between retrospectively undertaking investigations and implementing what we know works? Thank you.
Thank you so much, Dr. Hibbert, Dr. Jeffrey, and Dr. Lashman. You know, the overall aspects of quality, safety, I think this is something which is understood by all of us. You know, if we ask after the end of these sessions, we ask the audience, all of us sitting over here, do we know about it? Most of us will answer, yes, we know about it all. If we ask the audience again, because most of us sitting over here, they are senior leaders, they are quality professionals. And when you ask them, do we want to do it? We want to act upon it. They all say, yes, we want to do it. Now the question is to act upon it. And this is a time to act. And when the time to act comes, these are obstacles, and these are the challenges. And that's exactly the same three gentlemen were there as experts yesterday on the leadership pre-workshop that we had at Venkateshwar, talking about obstacles and the challenges which come in implementation of that. And gentlemen, thank you so much for giving the solutions. I think each one of us sitting in this room, whether a large organization or a small organization, we all want to do it. We all know that it has to be done. Ultimately, what was said that we embrace the future for the vision of quality and safety, I think we need to move forward. And that's where I think the advice that has come up today. Thank you so much for bringing out all the relevant points, which can be probably implemented in all the organizations at various stages of evolution to make the question where we started, 2030, are we looking at that as the time when we are able to achieve the safety? I think 2030 and beyond, lots going to happen with the support like that and the advice like that. Thank you so much. And thank you for the wonderful audience.
Thank you very much. Thank you very much. May I request you to kindly gather for a group photograph, customary at the Cahocon 2025.
Up next, we delve into the creative intersection of healthcare and design with our session 2, Design Thinking in Transforming Healthcare. The session will be moderated by Dr. Abha Mahendri Datta. Dr. Abha Mahendri Datta. I'm saying that wrong, I think. Faculty and Improvement Advisor, Institute for Healthcare Improvement. Our second moderator for the session is Dr. Anuradha Pichumani, Executive Director, Sri Renga Hospital, Director, Narbhavi Multispecialty Hospital, India, and board member of ISQA.
The esteemed faculty for today include Dr. Harish Chilani, Distinguished Scientist, Society of Applied Studies, New Delhi, WHO, Consultant for Implementation Research, former Head of Department Pediatrics at the VMMC and Safdarjung Hospital, New Delhi, India. Request you to kindly come on stage, Dr. Chilani. Request Professor Dr. Arun K. Singh, Advisor to the Governor of West Bengal, former Head of Department Neonatology at the All India Institute of Medical Sciences, Jodhpur, and the former National Advisor, Rashtriya Bal Swasth Karyagram, Ministry of Health and Family Welfare, India. Also request Dr. Nuzad Aziz, Senior Obstetric Consultant and Lead Consultant Obstetric Emergency Department at the Fernandez Hospital, Hyderabad, India, to join us. And Mr. Pritpal Singh, former Director, Projects Max Healthcare, author and Certified Independent Director and ESG Specialist. Ladies and gentlemen, a big round of applause. Esteemed chairpersons, you have 40 minutes for this session. Thank you.
Thank you. So good morning to all of you. I am Dr. Anuradha Pichmani, OBGYN consultant from Tamil Nadu and Chair of Quality Professional Wing of Cahocon. So it's my pleasure to facilitate today's discussion on why space matters, specifically in healthcare and specifically to maternal and childcare health. So space is not just a physical structure because it plays a crucial role in shaping care experiences, influencing health outcomes, and ensuring dignity, comfort, and accessibility for both patients and the healthcare providers. So as a clinician, I always see firsthand how design is very important in healthcare settings, and it influences the quality of care and again operational efficiency because it helps you to streamline workflows within the organization. And today we have a distinguished panel who will be able to share insights from research, policy, and practice on the role of space in improving healthcare delivery. So to begin this session, I invite Dr. Abha Mahendratatta, Faculty and Improvement Advisor at the Institute of Healthcare Improvement, to first set the stage on why space is a critical factor in healthcare delivery, specifically for mothers and newborns. She'll be providing insights on the Delivering More project. It is a IHI and mass design which have worked across multiple countries to understand how the design and function of space influence the care and health outcomes. Over to you.
Could I have my slides put up, please? Yeah, thank you. Good morning, everyone. I will be presenting on behalf of my colleague, Dr. Minara Chaudhary, who was not able to come. So this is a project that was started in 2021. It is a collaboration between Institute for Healthcare Improvement, which is a Boston-based organization working in more than 50 countries worldwide, and Mass Design, which is a non-for-profit Boston-based architectural firm, which is looking into research and advocating for architecture that promotes justice and human dignity. So I want to start to pause and have you reflect on this slide and really make the case for space and why space matters. Spaces are never neutral. They either help or they hurt. And that's why it's important that we think thoughtfully about them. They don't necessarily need to be extravagant, but they definitely need to be thoughtfully designed, keeping the person for whom they're catering for at the center of care. And in the hospital setting, that is the patient we are referring to. Quality care requires quality spaces for sure. The design of facilities shapes where the families in the first place come to seek care in that facility, and it directly impacts the demand for care. We do know how the services are organized within that space. The layout of those services actually impact whether the patient is able to access the right care at the right time. And we also know, and I'll show an example in my next slide, how design of spaces actually can be an enabler or a disabler to evidence-based clinical practice, which then directly impacts patient outcomes as well as patient experiences. So taking the example of kangaroo mother care, and we will be talking more about this with our distinguished panel, we do know that it's an evidence-based practice. There's immense amount of literature available that if kangaroo mother care is provided early, it will have a positive impact on survival, on child outcomes. But we do know that it's not a common practice. I believe a lot of you have maternal and child health units in your hospital, and kangaroo mother care is usually not the norm, at least not in India for now. And one of the main reasons is that our spaces are designed largely for efficiency, largely keeping the provider and the needs and the comfort of the provider in mind. But if we look and design spaces which makes it easy for the mother, if she has to give kangaroo mother care in that unit for about 18 to 20 hours, is the space designed in a comfortable manner to take care of her needs? For her to have food if she needs, for other family members to come in and share that responsibility with her? Does she have privacy to be able to, in a dignified manner, actually provide that care for her baby? So very important that if you do not have the right space, we definitely will not be able to provide the right evidence-based care, the right care at the right time. And also, I want to mention that, as I mentioned earlier, spaces are often designed for efficiency. But when you're looking into the maternal and newborn health space, they really need to be designed to honor the new birth that's coming and honor cultural practices and local materials that can be used. So I want to give you a provocation. So across multiple contexts, this is what we see. And many of you would also say that we have short-term approaches to infrastructure improvement, which results in patchwork building layouts, sometimes contradicting ideal care flows and experiences. Healthcare spaces are often designed without really engaging the stakeholders for whom they are being created and not necessarily keeping in mind the local culture of that place. And facility administrators and providers are often doing their best to provide care in spite of the space they have, which in turn puts increasing pressure on already overburdened staff. So a second provocation is that if you remove all those limitations, and if you could put your imagination and creativity and imagine a world where there is actually a commitment for long-term investment in physical space, which is bundled with other comprehensive initiatives to ensure quality, where there is human-centered design, where the people for whom these spaces are being designed are being engaged, and their input in an iterative manner is informing the space design, keeping in mind the local culture and climatic context. And these spaces are amplified and supported so that healthcare providers can deliver care with adequate motivation. So in parallel, as we go through this provocation and aim for this vision, the Delivering More project has been distilling its learnings, and it has created a number of global products which are freely available on our website. And if you come to the iChild Lounge, one level below, you will be able to see some of these products which are there. And we would really encourage all of you to go through it and see if you find things that resonate with you. So we have distilled our processes and learnings into a human-designed toolkit for improving maternal and newborn care spaces. This includes a facility design guide, which gives an overview of the design principles that have been used. It includes an engagement toolkit, which shows how the different steps of design take place when infrastructure is being designed, and which are the stakeholders that need to be engaged and involved at different points when decisions are being made for iterative feedback. There is also an assessment tool, because many of you may have existing spaces that may need to be redesigned. And this is more for structural engineers to look at what the existing infrastructure is and what can be done to make it more suitable for the care that needs to be given. And an overview guide, which contains the key design principles. So I want to end with this slide. To create meaningful and transformative change, we really must champion longer-term investment in the built environment. Together, we can all deliver more. So thank you very much.
Thank you, Dr. Abba, for the wonderful insights. And it's really nice to see all these tools which have been put out now, because I've been part of building hospitals, and we have not had any structured tool so far. And this will be very useful for others. Thank you. And to move on to the panel discussion, I'd like to hear from each of our panelists. on the fundamental question, why is space important in healthcare and how it can enhance the care for the mothers and newborn. So each of them bring their own unique perspectives, and I encourage all of you to have your own reflections on their experiences and other systemic implications. So I'll start with Dr. Nuzat. I have visited your hospital, your renowned hospital, Fernandez Hospital at Hyderabad, which has been established as a center for quality for mothers under Dr. Evita Fernandez. And I would like to know from your experience of designing labor and delivery spaces at the several branches of Fernandez Hospital, what elements of space you consider absolutely non-negotiable during labor and delivery? And also beyond functionality, how can space be designed to bring joy to patients, families, and especially to healthcare providers, because everything happens in very intense settings. Over to you, ma'am.
Thank you. Thank you, Dr. Abba and Dr. Anu for inviting us, for making us a part of this conference. And I'm absolutely delighted to be a part of it. I also loved your sentence that not involving the people that they serve. So obstetricians as well as women, I think, and I'm representing both of them. So Fernandez Hospital does about 10,000 births annually, but we have evolved over a period of time. It's a 75 years organization. And in 2010, we felt that we had to change it completely, the way we were working, the way we were providing care and the spaces. So we really turned it around. So let me go to the aspect that obstetrics is not a pathological process for more than 80% of the women that we see. It's a physiological process. And this physiological process is also a transformational one, both for the mother and the baby and for their families. So we have a huge amount of emotional, psychological environment and effect onto this. The second aspect of this physiological process is it is mostly mediated by oxytocin, which is a hormone, which can have a huge number of effects from any kind of an stimuli that comes into that woman who's birthing. So with this little background, the first non-negotiable that I would put it up today, I mean, not maybe 10 years ago, would be privacy. This aspect that we somehow always thought that we wouldn't have space to provide rooms for them, and let's put curtains in between, let's put beds one after the other. Actually, we do a huge amount of damage by putting, missing this little concept out of. So today our rooms are much better, and our rooms provide a complete privacy for them. We also have an additional curtain moving in so that when the door opens, the woman will still be, have a curtain, and we have to ask, can I come inside after that? So this was a non-negotiable that we had. The second one aspect would be space. We would always say that there is no space for the attender to come in. There is no space for other people to come in. Why we always create good enough space for ourselves. This space is not only for her to move around, to sit on her table, but it should also include a bathroom, because many women feel very uncomfortable to go to the common bathroom, which is there. And we felt that we made errors. In our first unit, we did not have bathrooms attached to it. In the second unit, we really tried hard, but the architect said, we couldn't. In the third one, we said that this is a non-negotiable. We have to have a bathroom as part of the labor and delivery room that we were creating. The third aspect was comfort. And this includes not only having a birth attender, but also what is the surroundings like, whether it's a home-like environment that I'm going to create, whether it is her senses that I'm stimulating, the noise levels in that room, or the smell levels, or what she sees, or the number of people. And the most important is that the light, sometimes they have a light for suturing, which should come only if there is a need to after birth. So these are very important aspects that should be taken into consideration for designing a space for labor and delivery, and not undermining the role of safety or a safety environment. And as Dr. Peter said, it should be in the genome of the healthcare providers that we should be able to do a crash cesarean section in 15 minutes and take that baby out if the need be. So I feel that these three important things that I have put it up prior to laying every other aspect that we would have as part of safety and functioning should be the most important aspect of a birthing room.
Thank you.
And I hope others will add into what I said.
It's on. Thank you so much, Dr. Nuzhat. Thank you for really reiterating that delivery is a physiological process and space needs to be designed such that it's comfortable for the mother for whom that care is being done. The bathroom needs to be accessible. She needs to be able to access a birth companion, and there needs to be space to move around. And most importantly, there needs to be privacy. So thank you for sharing that. So building on that, I want to ask Dr. Arun Singh. Sir, you have been a national advisor to the Ministry of Health and Family Welfare and several state governments. Currently, you're advising the government of West Bengal. And you have been promoting for nearly a decade on how we can keep pregnancy, birth, and childcare physiologically natural. Having said that, we have increasingly seen in maternal and child health spaces that the physiological and emotional needs of women and newborns are not met. We have seen, unlike what we're seeing in Fernandez Hospital and a lot of other places, that the natural process has been fragmented and we have separate spaces for antenatal, for delivery, for postnatal. So how can thoughtful design of space support the natural physiological processes so that we can increase natural birth, decrease unnecessary C-sections, and have more successful early breastfeeding rates?
Thank you very much. I think the first thing to appreciate is that the birth of a child is not a physical phenomenon at all. It is a dream of a mother that my child will cognitively do much better than me. And that dream gets shattered even if there is a normal delivery, but the child has some problem, both short-term and long-term. Imagine the entire 9 months or 40 weeks she has spent waiting for that D-Day in which a new individual will come to the planet. And when I said it's not a physical phenomenon, you have to appreciate that the baby who is going to be born with 100 billion wires, which we call neurons, and they are going to get connected the moment the child is coming out on this planet. Now, for this 9 months hard work and for this whole society, the investment is actually in the fetal and the newborn life, because that shapes the entire society and the community. Now try to think about that this entire examination, this entire dream coming true is in that labor room. And if that has not been designed properly, you have messed up. Just because a newborn cries and we all laugh, that's not enough. What you cannot see is how these 100 billion neurons of both the mother and the newborn are getting formed. So let me now get to the fundamentals of it. We had a design back in 19th century in the government sector where we said home delivery is not good, please come to the institution. And these institutions were designed as moving stages of labor. So for each stage of labor, you had one room and then you needed to be shifted. I would ask ladies and gentlemen to think about that. I have come to the hospital and I'm told that I have to change my room after a certain period of time. This is going to bring a lot of stress both to them. So the labor rooms were chaotic. We blamed the doctors, we blamed the nurses. What we didn't think of, that the whole design was meant for a failure. So we just heard that labor is not a phenomenon which is entirely limited to the mother's womb. A labor is a phenomenon where the mother's brain works. You just said oxytocin is going to come from the brain. And that brain is controlled by the ambience, the hypothalamus. Right now we are sitting in this hall. How we are feeling depends upon how this hall has been constructed. So if you design such a labor, what are your goals? Your first goal is that the mother should be able to deliver normally. Your second goal is that the child should cry immediately, should have normal transition. Your third goal is he should continue to have breastfeeding. And your last goal is the bonding of the mother and the child is successful. All these goals can only be achieved if you do not come into the way between the mother and the child. Nature had designed it that way. All the animals, all the mammals should deliver. No one shouts at them, please push. No one pulls out the baby. And so when these basic phenomena were done, when we said if the mother doesn't relax, I can't call it a normal delivery. If she requires music, if she requires light, if she requires a birth companion, can we design a room which is giving that privacy, which is giving this? This was a fundamental right of both the mother and the baby. What was the outcome? More C-sections. And after the C-section, we were removing the mother and the child. We said, this is mother corner and this is baby corner. Mother is going to be looked after the obstetrician. The baby is going to look after the neonatologist. For 9 months, they stayed together and suddenly we come. So the whole design has to be there. Let us think that the baby is not a baby. It is a potential. It could be a Nobel laureate. It could be a scientist. It could be a painter. Those 100 billion neurons have to be valued and respected. And just because it's a small baby whom anyone can carry on, that is not the proper way to respect your future generation. So for breastfeeding, even cows will not deliver will not give you milk if you take away privacy. So when you design it in this way, states after states, you just heard the example of Fernandez, there will be more normal deliveries, and more normal deliveries means better cognition because that is epigenetics. So I end up with it saying, this is a wonderful session. For the first time, I'm sitting in a hall where we are not discussing that delivery is only to be managed by the doctor and the nurses. Delivery is to be managed by the architect, and we change our questions. It is, how does a baby want? How does a mother want? They will dictate how the delivery would take place. Their cognition will be our ultimate answer. How we are going to keep them, even if they don't cry, can we keep the cord intact? How did nature want? What is Dr. Singh asking is not important. How did nature design a Homo sapien to be? Let us ask those fundamental questions to the basic nature and then appreciate the journey. So I think the 60 minutes of contact after delivery between the mother and the child shapes the whole thing. The whole wiring of the mother and the baby gets connected there. And what we did without realizing, separating them and giving them the first stress. So I think it's time to think. This is the most fundamental. You may have less money, but if your fundamentals are correct, it will give a better outcome in every term. Thank you.
Thank you, sir, for making us understand that designing spaces improves the process of delivery also, delivery of care. It's very nice. And moving on the same lines, I move on to Dr. Chelani. So you were part of the landmark study from WHO multi-country trial on the immediate kangaroo mother care, which we call as IKMC. And it was recently published in the New England Journal of Medicine. Implementing this in a busy public hospital like Safdarjung Hospital must have required not just clinical shifts, but spatial transformation too. So what was your experience in redesigning the space to make IKMC possible? And how is this a powerful evidence beginning to influence the national policy and design of MNCH units in India?
Thanks. Dr. Arun, you made my job easier. Now, globally, if you see the neonatal units are that once the baby is born and the baby is sick, baby is kept inside the newborn unit and the mother is either discharged or mother is in the postnatal ward, and she comes intermittently to provide the evidence-based interventions, which we talked of, that early exclusive breast milk feeding, kangaroo mother care. Now the question is, if you want a good coverage and quality, we say exclusive breast milk feeding, we say that baby to be given kangaroo mother care for more than 18 to 20 hours. Now, when you are separating them, how it is possible? It is a paradox that which we have set in globally this. So what we did, the study in 5 countries, where we brought the mother from the postnatal ward to stay next to the baby inside the NICU. Now, what this happened when we talk about the nurturing care, nutrition, safety, the good health, all these are possible only when you keep the mother and baby together. And we have now made a unit at Safdarjung Hospital, which you mentioned is the busiest hospital. Imagine 80 to 100 deliveries per day, where we have got mom and the baby together 24/7. And not only the small baby, every sick baby is with the mother. And mother is a great nurse. You know, we always say that it should be respectful care. How this respectful care will be possible unless we bring them together? So this is the time we have to redesign our units. And fortunately, the World Health Organization, based on this research, have come out with the new guidelines in November 2022 that all now units have to be redesigned, where you bring the mother's bed inside the NICU. That's number one. Second is, because this trial was done at a tertiary care level, we are also now doing the implementation research at a district level. Is it possible to do that? Yes, it is possible. And now, based on this, Government of India has adopted in our own national guidelines, so that these new guidelines, where mom and baby to be together, not only for the stable babies, remember, for each and every sick baby, so that you are able to provide the best nurturing care which we are asking, which Dr. Arun talked about, the best care where our neurons work, where the proper oxytocin reflex works. And that's the thing which we are hoping it. So now this is very much as a part of this. But yes, we did have the challenges. For this, I think we need to collaborate with our obstetric colleagues, nursing staff. Till now, we have been working in silos actually. So now this is a kind of a couplet care which we have seen, where the obstetricians come inside and talk about the mother and the baby, and the newborn people, they talk about the mother, so that to provide the quality of care.
Thank you so much, sir. And thank you for showcasing that how even in the public sector in India, this is possible and how that's informing, in fact, the national policy.
In fact, I am happy Dr. Sanjeev is here, and this has been not only included in the public hospital, but private hospitals have also taken a lead in this. And we have got an excellent example at the Amrita Institute of Medical Sciences.
Thank you for sharing that, sir. So moving to Mr. Pritipal, sir, as a former director of projects at Max Healthcare, you have led the planning of very large-scale hospital infrastructure. Given the rising cost of land in cities like Delhi and the need for high return on investment for private hospitals, how can hospitals design space intelligently to both enhance the patient experience, especially for mothers and newborns, and still at the same time ensure value for money?
Thank you, Dr. Abha. Please allow me to use the example of zero separation model. so that, audience is able to relate to what I convey, in a better way. Now, hospital planning, and particularly this zero space model, has three very critical elements about hospital design: functional flow, adjacency of spaces, and right sizing. Now, this right sizing is related to area per bed, and that is where your point comes when land availability is reducing and project cost is rising. But having said that, what I want to convey here is that this model is not about saving in area, which are very marginal. However, this model provides substantial improvement in patient care and clinical outcomes. And when I say substantial improvements, these improvements have come because of better infection control measures. And I will give an example for that. In a traditional hospital design, the mothers are kept in postnatal wards and newborns remain in the neonatal ICU, which we call as an ICU. And most of the time, these two units need not even be on the same floor. So what happens? These mothers have to frequently visit their newborns to feed, and they have to travel, distance from the outside area, and then, they visit NICUs frequently during the day to feed their babies. Now, what happens? These frequent movements could bring infection, along with these mothers, who visit their babies, and also it compromises the positive pressure, which is required for sterility, as well as, temperature control. And am I right in my assumption, doctor? If I say a mother travels about 10 times a day to visit her baby in the NICU?
If we say 2 to 3 hours or 2 to 4 hours every two, but it's usually, if we calculate for 24 hours, it comes something like 12, but
So,
maybe 6 times she will, may not come 6 times also. Very difficult for them also to move across and then come.
So 12 visits make the situation even worse, because imagine a 10-bedded NICU. So there 10 mothers will be coming and going from NICU more than 100 times a day within 24 hours. Now imagine what happens to maintaining the positive pressure, the sterility. And if these mothers and babies, which in this model have been kept together, then sterility as well as operation efficiencies can be far better managed. And that is why we have this tremendous improvement in patient outcome. Thank you.
Thank you so much, sir. Thank you so much for defining and in fact highlighting the problem of mothers who have just delivered, for them to travel so many times and sometimes even at different floors. We want to open it up for questions. Maybe we can take 1 or maximum 2 questions. I just want to ask the organizer how much time we have, and then we would conclude. We have 2 minutes. Okay. So are there any questions from the audience? Anybody more curious to learn about this? Anything for any of the panelists? Any reflections if there are no questions? Yes, sir. Can we have a mic in the front over here? Yes, sir.
So thank you very much. I think this was really interesting. See, well, what is stopping us from doing it? So, you gave some examples. Does the infrastructure allow us? What is stopping us from doing something which is as important as you mentioned?
Thank you, sir. So, yes, Dr. Arun, please, sir.
So what stops us is our own self. The space has to be created in the brain. At AIMS, when I tried to say that even if there is an illiterate mother, even if the baby is on a ventilator, the bed of the mother will be next to the child. My entire medical team, neonatologists, were against this. This will add more infection. I was looking at cognition. And ladies and gentlemen, you'll be surprised. If the mother is next to the baby, not only the baby recovers faster, the cognition is better when we started measuring the head circumference. And I'll end up with one thing, which is a very practical science. What were the mothers doing? Whenever a doctor would come to the baby, the mother would say, "Mera bachcha abhi so raha hai." If it is not very necessary, Can you feed him a bit later? Can you give him an injection sometime later? Abhi wo kachi neend mein hai. And the science is that is an REM sleep, which nature has made for 18 hours. So 18 hours, the neurons are getting connected. And if you destroy this, you are destroying the future of this country. So I think the space has to be created here. And as Dr. Chelani said, the obstetrician and the neonatologist must promise for no reason we will separate the mother and the child, right from the labor room to the ICU. Unless and until we promise this, all this talk is not going to make sense. So the problem is here, sir. Once this is addressed, we can find space, we can find solutions.
Thank you so much, sir. I can't conclude better than this. So as we close, I just want to take a moment to reflect on what we have heard today. Space really is ma'am, do you want to say something? Yeah, please go ahead.
I'm Dr. Shweta. I come from Apollo Ayurveda. I'm an Ayurveda gynecologist, specialized in gynecology in Ayurveda. So I'm really happy to see the concept that you discussed today. Because in Ayurveda, we have a concept of Sutikagara, which means the place where the mother moves in when she's nearing her delivery, and she stays there in that specific designed place where she gives birth, along with the attenders and along with a set of drugs and herbs and medicines, which can take care of infection control, can take care of the mother's requirements, which is more or less like what is discussed now. So I think we are moving towards what is there in our classicals, which was described previously, focusing on mother and the child. So really happy to hear this, that we are moving there.
Thank you so much, ma'am. Thank you for sharing your reflections. We are actually out of time, so I apologize because I believe the Chief Minister is here. So as we close,
Dr. Abha, can I add in?
yes.
No, if you go back 200 years or 300 years, that was the process, doctor. I mean, it was all the same. I think we came in to make it hospital-centric, to make it doctor-centric, to make it nurse-centric, convenience-centric, and that's how the birthing process has become. And so we just need to think about it. And I think creating space in the brain, many people are not aware. And I feel this is also a need that we need to keep talking about it. And all of the healthcare, people who design, you should design it that way and give, because that is a great help when you do that. Thank you so much.
Thank you so much, ma'am. Thank you. Thank you for sharing that. A big round of applause for all the panelists. Thank you. I really want to share my sincere gratitude to all our panelists for really showcasing how space is an important enabler of quality care. And I also want to thank the organizers, both CAHO and the Institute for Healthcare Improvement, for providing us a platform to discuss this important issue. So thank you very much. Please give a big round of applause to all our panelists. A little louder so that we have the energy up. Thank you. Thank you very much.
Thank you very much, chairpersons. Thank you very much, faculties. May I request you to kindly congregate for a group photograph towards the left of the stage. As we prepare for the inaugural ceremony, sorry. We'll be taking a moment's break while we ensure that security arrangements are verified for Chief Minister, ma'am. I know. Bouquet उस side पे है. हाँ. Call the bouquet. Call for the bouquet quickly. मुझे check करना आपको बस कर दीजिए. हाँ, जो नियम है वो आपका A very good morning, ladies and gentlemen. As we prepare for the inaugural ceremony, I'd like to welcome on stage the following dignitaries: Honorable Chief Minister of Delhi, Srimati Rekha Gupta. I'd like to invite our Honorable Chairperson of Cahocon 2025, Dr. Anupam Sibal, our Co-Chairperson, Dr. Upasana Arora, Secretary General of CAHO, Dr. Lalu Joseph, Organizing Secretary, Dr. Sanjeev Singh, President of CAHO, Dr. Vijay Agarwal, I request all of you to be seated, and I request our dignitaries on the dais invite also Dr. Yashpal Bhatia and our guest of honor for today, Dr. Ezekiel Garcia, President ISQA. Ladies and gentlemen, a big round of applause for our guest of honor, as well as the chief guest for today, Honorable Chief Minister, Srimati Rekha Gupta ji. Thank you very much, ladies and gentlemen. As we enter Cahocon 2025, we are privileged to be graced with the presence of Honorable Chief Minister Srimati Rekha Gupta ji. As we move into the inaugural ceremony, I'd like to invite Dr. Anupam Sibal and all the dignitaries on the dais, as well as Srimati Rekha Gupta, to kindly go ahead to the left where our Cahocon 2025 logo is there for the lamp lighting ceremony, which is an auspicious beginning to Cahocon 2025. May I please request all of you to keep the claps and the applause going till the lamps are lit. Thank you very much, ladies and gentlemen. Huh?
समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा. गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि.
Thank you very much. And for the welcome address, may I please welcome the chairperson of Cahocon 2025 for the organizing committee, Dr. Anupam Sibal, to kindly come and say a few words.
Namaste. The Honorable Chief Minister of Delhi, Srimati Rekha Gupta ji, Dr. Vijay Agarwal, Dr. Upasana Arora, Dr. Lalu, Dr. Sanjeev, Dr. Bhatia, Dr. Pavan, President of ISQA, very good morning. It's a privilege to extend a very warm welcome to our Honorable Chief Minister, Srimati Rekha Gupta ji. Rekha ji has been in public life from her very early college days and was president of the Delhi University Students' Union in 1996. She served as the councillor representing North Pritampura. She's been mayor of the South Delhi Municipal Corporation. In recent years, the Honorable Prime Minister has been highlighting Nari Shakti. In May 2022, the Honorable Prime Minister said, "The progress of humanity is incomplete without the empowerment of women." And when At the success of Chandrayaan, the Honorable Prime Minister in August 23 applauded the team, and I quote, "When the daughters of a country become so ambitious, who can stop the nation from becoming developed? When the capability of women power is added, the impossible becomes possible." And in January 24, the Honorable Prime Minister highlighted, we have shifted focus from women-centric to women-led development. And who better than Srimati Rekha ji to guide us? The Honorable Prime Minister expressed confidence in Rekha ji's ability to lead and develop Delhi. As he now says, we have a double-engine government. Rekha ji will make Delhi a capital worthy of being the capital of a developed country. We are privileged to have you as our Chief Minister, Rekha ji. Thank you so much for finding time for us. Caho was established in 2013. Cahocon came into existence in 2015. In 2005, the accreditation journey started when Apollo Delhi became the first internationally accredited hospital by a joint commission. It was the first in India and the sixth in Asia at that time. We now have 61 JCI accredited hospitals. A year later, NABH came into existence. We now have more than 1,500 accredited hospitals, more than 2,800 entry-level hospitals, and more than 1,100 small hospitals that are accredited. At Cahocon, we today have more than 1,500 delegates with 100 speakers from 15 countries. And the idea is to create an immersive experience so that there's something to learn and something to teach for everyone. For the GAPIO conference that was organized a few years ago, the Honorable Prime Minister had sent a message, and I end with that. Sarve bhavantu sukhina, sarve santu niramaya. Our worldview is anchored in our ethos of may everyone be at peace and may no one suffer from illness. And in that spirit, a very warm welcome to everyone at Cahocon. Thank you very much.
Thank you very much, Dr. Sibal, for those inspiring words. Before we move ahead, along with the welcome address is the traditional welcome. And may I request Dr. Anupam Sibal, Organizing Chairperson of Cahocon 2025, and Dr. Vijay Agarwal, President Caho, to kindly felicitate ma'am with a bouquet of flowers. So, are we done? There's another one. Dr. Sibal. Big round of applause, please. May I request Dr. Upasana Arora as well as to felicitate ma'am. Thank you very much, ma'am. Thank you very much. I think for Honorable Chief Minister, ma'am, to understand deeper about CAHO, I'd like to invite Dr. Vijay Agarwal to speak on CAHO and its journey over the last decade plus. Dr. Vijay Agarwal, President CAHO. Sir, please.
Good morning, most respected or Honorable Chief Minister of Delhi, Sri Rekha Gupta ji, our guest of honor, Ezekiel, and all my friends, colleagues on the dais and off the dais. Guys, we are a very young organization which was created just in 2013 with an aim to provide safer patient care, strengthening quality, promoting accreditation, and sharing best practices. Our mission has become as an association of healthcare institutions, diagnostic centers, and individuals with the objective of participating in and pooling the resources for achieving the common goal of providing safer care, promoting patient safety. Our purpose is to work together for safer healthcare, and our vision is to be an admired global leader in the space of healthcare quality and patient safety. Our logo represents all our divisions. Madam, one of the most important change I would say that Caho could bring about was to bring about the concept of creating quality implementers, just like the accreditation bodies have an army of assessors. We have created an army of quality implementers who can be there in every institution. And over a period of time, we have trained more than 3,500 of these quality implementers who are now the ambassadors of patient safety across the country. These patient quality ambassadors have been also as a community, and we have been conducting many other programs with them and also with the other people. So over a period of time, we have designed, developed affordable and high quality programs, and more than 68 programs are still being running. We have done 12 master classes series, 32 continuing quality education series, with the result that we have trained more than 45,000 people across the country. We have certification programs, which are the fellowship programs. With ISQA, we are very proud to say that we have a joint kind of a fellowship program with ISQA. We do also a program on risk management and also on leadership with the Leads Global and CINS. We do also national certification program for infection control professionals. Nurturing quality as a discipline by bringing the national and international experts has been the main, I would say, reason for the growth of Caho. Caho is conducting an ISQA webinar. ISQA is, you know, the apex organization of quality in the world. So in ISQA, expert is giving a webinar on every first Tuesday at 5 p.m., which is being attended by people from more than 20-25 countries. And every first Tuesday has now become a monthly quality meeting for all institutions in our country. We do diagnostic webinars, student engagement webinars, general webinars, and over a period of time, we have conducted more than 300 webinars with more than 50,000 attendees. We develop resources to help institutions which are especially, I will say, the small and medium hospitals, whether it is in the area of consent form, how to promote telemedicine, fire safety audit, statutory compliance. And we also bring the voice of the leaders through Cahopod. We have a very important program to motivate hospitals to start reporting the errors in a confidential manner on our platform called Convert. I think the game changer has also been our understanding that we cannot do anything about reducing medical errors unless we reach out to everybody, every segment in the healthcare, and that is whether they are the doctors or nurses. But besides that, the engineers in the hospital, pharmacy, nursing, dietitians, rehab specialists, technology, and supply chain. The evidence of that was that yesterday, we had 22 workshops across the city of Delhi, and one workshop, just of a rehab workshop, had 300 people kind of present into that workshop, shows the kind of reach out. We are also reaching out to everybody through different committees, and the committees are including even International Advisory Committee. We have Professor Ravindran Jagasoti here, coming all the way from Malaysia. He is the chair of our International Advisory Committee. We have Collaborative Research Committee being led by Professor Satish Chandra. We have a Nursing Empowerment Committee by Elizabeth David. We have Media Committee by Harbinder Narula. We have Student Committee by Amita Marla. We have Technology Committee by Dr. Manish Kohli, and Sustainability Committee by Kirti D'Souza and Karan. And we have been designing and developing very high quality and affordable programs. We also have taken the mantle of raising the patient's voice and making them a partners in our healthcare. So we started with a Patients for Patient Safety initiative, which is now the Patients for Patient Safety Foundation, which is being chaired by Mr. Som Mittal and Madam Nadira Chaturvedi very, very efficiently. More than 10-15 lakhs of people are being approached for some of the other things every week. In fact, along with them, we have come out with a white paper on patient advisory councils. A lot of hospitals are now working to, we are also working on the area of research. A lot of publications have started already to come out through this. And we have started with a research journal on the issue of the patient safety. We organize today many annual events. I'll say Cahocon, where you are a part today, is our signature event. But technology and healthcare has been also. So this year in Bhubaneswar, we will be having our 10th annual conference. We have the Diagnosticon, the LabCon, which was earlier LabCon, is now called the Diagnosticon, will happen in Indore. And we have SECON, the student engagement platform. We also celebrate the World Patient Safety Day on the 17th of September. Our journey has been nothing else but collaboration, which is the theme of this conference. And we have the Centers for Quality Promotion. These are hospitals which are already accredited, but are also having people who are trained by the CAHO programs. And they are now the Centers for Quality Promotion. They reach out to the other small and medium hospitals to spread the wave of quality. We collaborate with medicals, other professional societies, with associations, institutions, academic institutions, industry. And we organize many competitions to again motivate and stimulate people to take part and become a part of the healthcare, promoting the healthcare. Promoting technology in healthcare has been one of the very important thing, as I said. So we showcase hospital innovations. We invite Pitch Fest for the startups, and we do a health tech directory to start connecting the startups with the end users. For connecting with the stakeholders, we bring out with a monthly digital magazine called The Spark. Every week, our issues come out on a Friday update. We come out with many books which have included the ones which are on reporting of the adverse events, on convert, on hand hygiene, and we have now come out with a safe anesthesia practical guide. We do a CAHO's recognition program is there of awarding lifetime achievement, quality champion, young quality achiever, best healthcare startup, many more. And there is a global impact, I will say, of all the activities that we are doing. Our membership count has been increasing. I will say, ladies and gentlemen, over a period of time, CAHO is not an organization. It has become a movement. Let's join this movement to promote patient safety. Thank you.
Thank you very much. And thank you very much, all of you, for joining Cahocon 2025, a moment in its truest spirit. May I now invite our very own Secretary General, Dr. Lalu Joseph, to speak to us about introducing the theme of the conference. Dr. Lalu Joseph.
Honorable Chief Minister, dignitaries on the dais, dear friends, welcome you all to Cahocon 2025. With immense pride and anticipation, I welcome you all to CAHO 2025, a milestone gathering that brings together healthcare professionals, thought leaders, innovators, and change makers from across the nation and beyond. This year's theme, Enhancing Quality Through Collaboration, Transforming Healthcare Together, reflects the essence of CAHO's mission and the urgent needs of today's healthcare landscape. It is not just a theme for the conference. It's a call to action for the entire healthcare community. We cannot do it in isolation. We have to collaborate. And that's the essence of this conference. We are at a defining moment in the evolution of healthcare. Rapid advancements in technology, growing patient expectations, environmental imperatives, and rising complexities in care delivery demand more than individual effort. They demand a collective effort, collective excellence. This theme emphasizes that quality in healthcare is no longer a solitary pursuit. It thrives in environments of collaboration, transparency, and shared purpose. Throughout Cahocon 2025, we will explore how strategic partnerships across disciplines, institutions, sectors can drive sustainable, patient-centered, and intelligent healthcare systems. whether it is through digital transformation, smart hospital designs, sustainable care, or innovative accreditation and quality improvement models. Each session has been thoroughly curated to highlight how collaboration can fuel impact. At its heart, Cahocon 2025 is about transforming healthcare together through dialogue, knowledge sharing, innovation, and united vision. As we gather to share best practices and celebrate collective progress, let us reflect on how we can carry the spirit of collaboration into our everyday work. I encourage you to engage, contribute, and be inspired in the coming days. Let this conference be more than an event, a springboard for continued partnership, shared leadership, and a healthcare where quality is a lived value across every touch point. Together, we can shape a more thoughtful, compassionate, and resilient healthcare future. We are in this journey together, and we will continue to be together. Jai Hind. Thank you all for coming.
Thank you very much, Dr. Lalu. I'd like to invite Dr. Upasana Arora to please come up on the dais, co-chairperson of Cahocon 2025 and a very old friend. Ma'am will speak to us about changing the landscape of healthcare in India. Ma'am, over to you.
Good morning, everyone. It's a pleasure to be here. And I'm really thankful to our chief guest, Rekha Gupta ji, that she came here and now she will understand how healthcare is helping people to take care, because quality is a new word to India. And I would like to say, because I am supposed to speak about landscape. So everybody knows that there was a system of family doctor who was treating for all your illnesses and everybody was happy. Then system become change and there were people started going to specialist like medicine, then surgery. Then again system were changed and super specialty came into the picture. And then urologist, neurologist, awareness becomes so that everybody wanted to go to only super specialist. Now there is a subspecialty in super specialty, pediatric neurologist and different things. Same time, if you see the culture of hospitals, there was only government driven hospitals or doctors who were running their nursing homes with their wives, 10 bedded, maximum 40 bedded. Then now it's a corporate culture. Lots of new hospitals are coming. And this time scenarios totally change. America and different countries are putting money to healthcare in form of private equity. And if you see the kind of care for the public also changed within 10 years, because before that, no government was going or taking any action for public health. There was only government hospitals were available for the poor persons, but no policy was there. But if you see the form of this Ayushman Bharat is a very, very new thing for India. Most and largest public policy for health insurance. And I think now everyone knows about it and everybody is taking advantage. Now, by the grace of God, Delhi is also getting that facility because now government is ready to put this scheme. Otherwise, government was not ready to take this. I think we should clap for that because everyone is. And if we talk about technology, there was a time doctor was writing prescription. And even my hospital, we started 35 years back. We were also giving test report in manually. But now things are changing a lot. Everything is digital. Now we are talking about digital hospitals. Everything is available online. Even telemedicine was okay, but not telepathology, telesurgery. If you could remember, I think 2 months back, some doctor of Rajiv Gandhi cancer surgeon, Dr. Rawat, he did surgery from Medanta to Rajiv Gandhi through this tele surgery, robotic surgery. So you can see how much hospitals are changing, healthcare is changing now. We are here, and if we talk about patient safety, this was a new word for India. And 2006, Dr. Girdhar Gyani is sitting here, who started quality journey of India. He started by the name of NABH, and now NABH is a very, very well-known name in India. Here, JCI people are sitting, and maybe other countries' accreditation people must be here. But in India, we started with NABH. Now everybody knows, even patients are very much aware about patient safety. And what is patient safety? Everybody thinks doctor is giving medicine and nurse is giving injection. What is patient safety in between? But there are many things which hospital administrators are doing and looking, and quality people are working. But I must say, quality should not only limited to room. Quality should be culture of a hospital. Everyone should know that we are supposed to follow checklist so that we should not harm to the patient in form of wrong side surgery or wrong medication and all. So in this way, right now, when we are in 2025, you can understand when this ABDM scheme will be fully implemented in this country. Like my hospital is a ABDM compliant, so we all can see our records anywhere. These things are revolutionary, and healthcare is changing a lot. AI has taken lots of place, and everyone is saying after AI, everything will be, manpower will be not required. But I am telling you, whatsoever will happen, nobody can take place of a doctor, and no one can replace human being. So there is a myth that after AI, what AI can do? AI can make reports, that is good for a radiologist. But other things, we need to have some professionals, our doctors. And doctor का जो touch होता है ना, जो कहता है मैं हूं ना, that is always very important for everyone. So now, not only Indian healthcare, all healthcares are changing, and we are going for new era of healthcare that is called digital health. And lots of new techniques are coming, like gene therapy, CAR-T therapy, bone bank and biobank, and all these things are taking place. And the best part is these things were always in different countries, foreign countries, Europe or America. But now India is not less than anyone. We are also having all facilities here. With these words, thank you so much. Once again, everyone, I am not talking like a formal thing that on the dais, I welcome everybody, because everyone is my friend. So it's definitely, I am welcoming everybody. But thank you so much for giving me this opportunity that I am here. And all those who are from different countries, welcome to India. Namaste Bharat. Jai Hind, Jai Bharat.
Thank you very much, Upasana ji. And before we move to the actual launch of the International Journal for Healthcare Quality, Patient-Centeredness and Safety, I'd like to invite our guest of honor, President of the International Society for Quality in Healthcare, the monitor of the monitors, the accreditor of the accreditors. Ladies and gentlemen, please put your hands together for Dr. Ezequiel Garcia Elorio. Sir.
Well, good morning, everyone. Namaste. And you're too generous, but this is not absolutely surprising from what I'm feeling in this conference. Thank you. I want you to give you 3 messages today, very short ones, and I will comply with my 2 minutes. The first one is thank you. On behalf of ISQA, immense thanks to the Indian nation and to Cahocon for hosting us. Thanks to Dr. Vijay, to Dr. Lalu, and the board and members of Cahocon. The second message is to tell you that ISQA is an organization of giving. And quoting Gandhi, the best way to find yourself is to lose yourself in the service of others. And the message just to share with you is that ISQA, it's a window to the world. It's a window where personally I had the honor to work with people that I admire, like Peter Lackman and Jeffrey Brownwave. People, I made new friends in esteemed colleagues like Shinu Shiro and Dr. BJ, and also learn from colleagues like Dr. Pichumani and Radha Pichumani, Peter Hibbert, ISQA members like from India like Bikir Rana, Dr. Anupal, Dr. Atul, Dr. Lalu, and also Cahocon members, and most important, the ISQA staff in Ireland. So join ISQA work to give and receive. It worked for me, and hopefully it can work for you. So I invite you to our room for a panel at room 10 at 2 p.m. for a roundtable. And finally, the third message is to keep moving forward. Yesterday, a politician asked me, what do you find unique about India? And what I said at that very moment is that I found what the few things I know already is that you do things your own way, respecting your culture and your values. But as the day went by, I found that another unique thing of India is Cahocon, because of its inclusiveness, reach, and ambition. Usually guests are kind with their hosts, but this is a heartfelt message. So finally, thanks again for your kind invitation and congratulations for your work. Let's carry on. We have a lot to do. Thank you.
Thank you very much, sir. And now the moment for which all of us have been waiting for. With a big round of applause, I'd like you to welcome Srimati Rekha Gupta ji, Honorable Chief Minister of Delhi, to kindly give her inaugural address. Thank you. Ma'am, over to you.
Thank you so much. I really thanks Caho, who has invited me over here, and I can meet the dignitaries who came from all over world, especially for the theme, patient security. I really thank all of you. Namaskar, Jai Hind, Jai Bharati. स्टेज पर मेरे साथ प्रेजेंट डॉक्टर यशपाल भाटिया, डॉक्टर अनुपम सिबल, डॉक्टर विजय अग्रवाल, डॉक्टर उपासना अरोड़ा, जिन्होंने मुझे आज यहाँ इनवाइट किया, स्पेशल थैंक्स टू हर, एंड डॉक्टर एजिक्वेल गार्सियर, डॉक्टर लालू जोसेफ, आप सभी एक कॉमन थीम के साथ पूरा कंट्री को एड्रेस कर रहे हैं, दैट इज पेशेंट सिक्योरिटी। आज का दिन बहुत इंपॉर्टेंट है। इट्स ए बर्थडे ऑफ हनुमान जी। जय हनुमान। I think our foreigner guest also know हनुमान जी। हनुमान जी वो पहले व्यक्ति हैं जब लक्ष्मण जी बेहोश हो गए और उनके लिए संजीवनी ढूंढने के लिए उस समय के डॉक्टर ने कहा कि भाई इनको बचाना है तो संजीवनी लेके आइए, तो वो गए और पूरा पहाड़ लेकर के आ गए टू सेव लक्ष्मण जी। तो आई थिंक वो भी मेडिकल फर्टर्निटी के बंदे रहे हैं जिन्होंने लक्ष्मण जी की जान बचाई। तो ऐसे दिन पर जब मेरा आप सबसे मिलना हो रहा है और एक बहुत ही अच्छे थीम के साथ, काहोकॉन एक ऐसा इवेंट जिसमें पूरे वर्ल्ड से अलग अलग इंस्टीट्यूशंस ने, एजेंसीज ने, हॉस्पिटल्स ने, रिसर्च सेंटर्स ने पार्टिसिपेट किया है फॉर ए वेरी इंपॉर्टेंट कॉज, हाउ टू बी मोर sensitive towards patient security and safety. बहुत सारे हादसे हमने सुने अलग अलग टाइम पे, और बहुत प्रेस्टिजियस हॉस्पिटल्स के जब राइट लेग का ऑपरेशन होना था और लेफ्ट लेग का ऑपरेशन कर दिया गया, जब लेफ्ट किडनी रिमूव होनी थी और राइट किडनी को रिमूव कर दिया गया, या बीमारी कुछ और थी, इलाज कुछ और दे दिया गया। कई बार पेशेंट को नहीं मालूम, डॉक्टर इज गॉड फॉर हिम, वो उसमें पूरा विश्वास रख के अस्पताल में, अपने हॉस्पिटल में पूरा बिलीव रखते हुए वहां जाते हैं, और उनका पूरा परिवार, उनका फैमिली अपने उस बिलव्ड फैमिली मेंबर को सौंप देता है आपके हाथों में, कि अब आपके हाथ में है कि आप मेरे पेशेंट को, मेरी मदर, मेरा फादर, मेरा बच्चा, मेरी वाइफ, मेरा हस्बैंड, आप इसकी जान बचाइए। पूरा विश्वास रखता है हमारे हेल्थ केयर सिस्टम पर। और एक बड़े अस्पताल में जाकर भी अगर इस तरह की गलतियां होती है तो कोई भी पेशेंट कैसे विश्वास करेगा हमारी इस पूरी मेडिकल कम्युनिटी पर, जब बड़ी बड़ी गलतियां हमारे हॉस्पिटल सिस्टम से हो जाती हैं और हम रिग्रेट करते हैं कि ये कैसे हुआ। वो आपके इंस्टीट्यूशन के लिए डिफेमेंट भी लाता है और पूरे स्वास्थ्य तंत्र से विश्वास भी खत्म होता है। कहीं ना कहीं ये इमेज जाती है कि हमारा ये मेडिकल प्रोफेशन भी कमर्शियलाइज हो गया है, और शायद हम अपनी अर्निंग के लिए कुछ भी करते हैं। और अगर हमें इस पूरे मिथ को खत्म करना है, इस पूरे मिथ को मिटा करके अपने लिए एक नई इमेज क्रिएट करनी है, तो मुझे लगता है कि आज का ये कहोकॉन इवेंट बहुत इंपॉर्टेंट है, जिसमें आप पेशेंट सेफ्टी की पूरा हर सेगमेंट को डिस्कस करने वाले हैं। कैसे उसको मैक्सिमम केयर मिले, कैसे पेशेंट्स के लिए हम लोग पूरा डिवोटी होके उसका ट्रीटमेंट करें, और जब वो हमारे इंस्टीट्यूशन से, हमारे हॉस्पिटल से जाए तो वो आपको थैंक्स बोलता हुआ जाए और 10 जगह पे ये कहे कि मेरा इलाज जहां हुआ वो सच में मेरे लिए भगवान थे और उन्होंने मेरा बहुत ध्यान रखा, और दे कन्वर्टेड इम्पॉसिबल इनटू पॉसिबल। दैट शुड बी द मैसेज फॉर द हॉस्पिटल। और हमारी संस्कृति जो इस भारत देश की है वो तो हमेशा से यही कहती है, वसुदेव कुटुंबकम, पूरा वर्ल्ड हमारे लिए फैमिली है, और कोई एक भी व्यक्ति बिना इलाज के, बिना ट्रीटमेंट के ना रहे, ये हम सबका मिशन होना चाहिए। ऑफ कोर्स ये आपका प्रोफेशन भी है, पर उसमें कहीं ना कहीं सेवा का टच जरूर देना पड़ेगा। डॉक्टर्स, हॉस्पिटल्स एक बहुत सेंसिटिव कम्युनिटी है। जब आपके पास कोई पेशेंट आता है तो वो पूरा समर्पित होता है आपके लिए, आपके चरणों में होता है, कोई हाथ जोड़ता है, किसी की आंखों में आंसू होते हैं, कोई चरणों में बैठ जाता है कि प्लीज सेव अवर लाइफ, हमारी जीवन की रक्षा कीजिए। और वो जो भगवान का रूप आपको देता है, उस समय हमारी रिस्पॉन्सिबिलिटी ईश्वर के समान आ जाती है, भगवान के लेवल पे ही हम खड़े हो जाते हैं। और जब हमने अपना ये विजन बदल लिया कि वो जो पेशेंट है वो हमारे लिए सिर्फ कस्टमर नहीं है, वो हमारे लिए सिर्फ कस्टमर नहीं है, वो एक ऐसा वे है आपके लिए जिसके माध्यम से आप ईश्वर तक अपनी वेलबींग पहुंचा सकते हो, आप अपने अच्छे काम उस पेशेंट के माध्यम से पहुंचा सकते हो। हम सबके लिए सोशल वर्क करने का इससे अच्छा कोई तरीका नहीं हो सकता। अपनी अपनी लाइफ में हम सब ने बहुत कमाया होगा, इतना कमाया होगा कि खर्चने की जगह भी नहीं होगी। पर अब क्या हम ये कर सकते हैं कि हम सब अपने हाथ जोड़ें, ज्वाइन हैंड करें और सोसाइटी के लिए, देश के लिए आगे आगे काम करें। भारत एक ऐसा देश बने जहां कम से कम इलाज की कमी के कारण कोई व्यक्ति मरे नहीं। वो कोविड का समय जो हम सब ने देखा, जहां हजारों लोग बिना इलाज के मर गए क्योंकि हमारा इंफ्रास्ट्रक्चर जो है वो कम पड़ गया। मुझे ध्यान है आधी आधी रात को हम लोग हॉस्पिटल्स में फोन करते थे, वेदर दैट इज प्राइवेट और पब्लिक, और रिक्वेस्ट करते थे कि देखिए एक पेशेंट आपकी दहलीज पे खड़ा है, आपके इमरजेंसी पे आया हुआ है, प्लीज उसे ले लीजिए। आज टाइम वो आ गया है, एक समय था उपासना जी जब हम लोगों को हॉस्पिटल्स में डिस्काउंट्स के लिए फोन करते थे, पर आज एडमिशंस के लिए फोन करना पड़ता है कि प्लीज इस पेशेंट के लिए आप एडमिशन ले लीजिए। हमारा इंफ्रास्ट्रक्चर हेल्थ केयर का बहुत कम है अभी। वी शुड इंक्रीज आवर हॉस्पिटल्स, आवर लैब्स, आवर ट्रीटमेंट सेंटर्स, और गवर्नमेंट उस दिशा में बहुत काम कर रही है। नरेंद्र मोदी जी ने आयुष्मान योजना पूरे देश में लागू की, और ये मैं समझती हूँ पूरे वर्ल्ड का सबसे बड़ा हेल्थ प्लान है जो भारत में लागू हुआ और हर भारतीय के लिए उपलब्ध है। आज अमेरिका जैसे बड़े बड़े देश भी अपने सीनियर सिटीजन्स का जो केयर शायद नहीं कर पाते होंगे, उस दिशा में भारत आगे बढ़ रहा है कि हमने 70 इयर्स अबव जितने भी लोग हैं उसकी जिम्मेवारी सरकार ले, उनका इलाज करे और उनको किसी भी चीज की चिंता ना हो, ये एंश्योर करना गवर्नमेंट ने अपने जिम्मे लिया। और 36,000 इंस्टीट्यूशन ऑल ओवर इंडिया, ऐसे हॉस्पिटल्स, ऐसे अलग अलग मेडिकल इंस्टीट्यूशंस को एनरोल किया गया जहां आयुष्मान भारत से रजिस्टर्ड पेशेंट आए तो उसका इलाज हो सके, दैट टू कैशलेस। कैशलेस पॉलिसी उनको दिया गया, और ये इंश्योरेंस नहीं है, ये एश्योरेंस है कि आपको इलाज मिलेगा और वो भारत में ही मिलेगा। और दिल्ली के लिए भी हमारा यही प्लान है कि आप सबकी मदद से मैं आज इस मंच के माध्यम से प्राइवेट सेक्टर के हॉस्पिटल्स को और मेडिकल फील्ड के लोगों को इनवाइट करती हूं कि यदि वो दिल्ली में काम करना चाहें तो हम पीपीपी पर मिल करके दिल्ली में एक अच्छा हेल्थ मॉड्यूल क्रिएट करें, जहां पे जगह हमारी होगी, बिल्डिंग भी कई जगह पे हम दे पाएंगे, और उसका पूरा ऑपरेशनल सिस्टम पब्लिक प्राइवेट व्यक्ति हैंडल करे, ताकि जिसे हमें सरकारी इलाज देना है, फ्री ऑफ कॉस्ट देना है, उसको हम वो भी दे पाए, और बाकी लोग जो पे करके इलाज लेना चाहें उनको भी पूरी फैसिलिटी मिले। किसी बेड के लिए, किसी ट्रीटमेंट के लिए, किसी सर्जरी के लिए किसी एक भी पेशेंट को वेट ना करनी पड़े, ऐसा पूरा दिल्ली का हेल्थ मॉड्यूल हम क्रिएट करना चाहते हैं। आप सब लोग इनवाइटेड हैं अपने नए सजेशंस के साथ। कहां आप दिल्ली गवर्नमेंट के साथ ज्वाइन हैंड करके हमें असिस्ट कर सकते हैं, किस मॉड्यूल को हम लागू कर सकते हैं जिसमें हर दिल्ली के नागरिक को हेल्थ केयर मिले। आज मोदी जी ने दिल्ली में आरोग्य मंदिर नाम से 1100 यूनिट्स, 1100 यूनिट्स, एक सॉर्ट ऑफ बिग डिस्पेंसरी जो कि बिल्कुल लो लेवल पे जाकर के कॉलोनी लेवल पर हेल्थ केयर देगी। और ये इमीडिएट हमें बनाना है, इमीडिएट करना है। फॉर दैट सेंट्रल गवर्नमेंट हैज गिवन अस 2400 करोड़ रुपीस कि हम दिल्ली में ये हेल्थ केयर सिस्टम शुरू करें। और दिल्ली में हेल्थ केयर के लिए हमने खुद भी 19,000 करोड़ रुपीस स्पेशली फॉर हेल्थ सेक्टर हमने रखे हैं, ताकि एक नया सिस्टम डेवलप हो सके, हर दिल्ली के निवासी को हम इलाज दे पाए और बहुत ही सुविधाजनक तरीके से, बहुत ही गुणवत्तापूर्वक तरीके से, ताकि कोई भी ऐसा लैप्स ना रहे जहां पेशेंट सिक्योरिटी का छोटा सा भी लीकेज हो। उस दिशा में आप सबकी मदद मिलेगी। हम सब लोग इकट्ठे मिलकर काम करेंगे और नए डॉक्टर, नई लैब, नए इंस्टीट्यूशंस हम दिल्ली के सेक्टर में डेवलप करें, पूरे देश में काम करें और मिल करके काम करें। जो मोदी जी का नारा है, सबका साथ, सबका विश्वास और आप सबका प्रयास, मिल करके करेंगे देश के लिए, दिल्ली के लिए और पूरे वर्ल्ड के लिए। आप सबको दिल की गहराई से बहुत बहुत बधाई देती हूं कि आपने एक अच्छे कॉज के लिए इनिशिएटिव लिया और इसी तरीके से आप लोग आगे भी हेल्थ केयर में काम करते रहेंगे और दुनिया को आगे बढ़ाने के लिए आप सबका पूरा सहयोग मिलेगा। थैंक यू सो मच।
धन्यवाद मुख्यमंत्री साहिबा। May I request Satish Kapoor, State President, Delhi, to kindly come up on stage and jointly with Dr. Vijay Agarwal and Dr. Anupam Sibal to kindly felicitate ma'am with the token of Cahocon 2025. Ladies and gentlemen, let the applause not stop. May I now request Dr. Sanjeev Singh, Organizing Secretary, Cahocon 2025, to come up for the vote of thanks, and after that, we'll have the national anthem.
Thank you all, and Honorable Chief Minister, it is with deep gratitude and immense respect that we thank you for gracing this particular occasion. Your participation today was not merely ceremonial, it was very powerful reaffirmation of your unwavering commitment to health, your passionate engagement. You have been always a dynamic leader, always driven by purpose, grounded in compassion, and always exuding warmth and optimism. And your ever smiling demeanor is which catches us with a lot of warmth. You were handpicked by our Honorable Prime Minister for this coveted post, and you have been a role model for women empowerment and empowerment in general. And you touched upon for all healthcare professionals to do seva. Thank you for recognizing the effort during COVID-19. और दिल की गहराई से हम भी आपको अभिनंदन करना चाहते हैं. Thank you for gracing the occasion. I would also like to thank our guest of honor, Mr. Dr. Ezekiel, who is the president of ISQA, for his sheer magnitude and the accomplishment which he has achieved and the role which he plays for all the quality movement across the globe. Thank you for bringing those professionalism and quality and patient safety to the patient who trust in the healthcare organization. Two beautiful souls, Dr. Vijay Agarwal and Dr. Lalu. We extend deepest gratitude. Their foresight, their dedication, their relentless pursuit for excellence. It lays a cornerstone for a transformative journey, and Lalu is wearing a diamond necklace which has been given by her husband on her birthday. So please recognize that too on this beautiful day. A heartfelt thank you for an extraordinary organizing committee, Dr. Anupam Sibal, our Madhuri Dikshit of the healthcare, Upasana Arora ji, Dr. YP Bhatia, and all other organizing members for their meticulous planning, seamless coordination, and their commitment to get this putting this whole program together. I'm so glad that today there will be no calls to call everybody for the Zoom call where nobody also comes. So thank you so much. Organizing this conference at this scale is no small feat. It is possible because of our powerful patrons who are there on the front row, with the brilliant speakers who has agreed to invest their time, for engaged delegates, all of you, you're brilliant, and for all the invested sponsors, and the event manager who has sort of managed this so very well. Last but not the least, a super duper Caho team. They are just superbly hardworking, fantastic team, and glad that they will not get any calls from Lalu from today onwards. So thank you so much, and elevate the platform for quality, patient safety, and the purpose, and let the collaborative spirit be alive. Thank you so much.
Thank you so much, Dr. Sanjeev Singh, ever so dynamic organizing secretary of Cahocon 2025. Ladies and gentlemen, may I please request you to rise for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Bharat Mata Ki! Thank you very much, Honorable Chief Minister. And with that, we conclude the inaugural. Please be seated and let's take a minute. I request the rest of the guests to kindly stay on stage. Guest of honor, Dr. Ezekiel, sir, kindly stay on stage. Dr. Anupam Sibal, once you're done with the escorting and saying goodbye to ma'am, kindly get back on stage. We have a series of exciting launches coming your way, ladies and gentlemen. So I think we can all afford to take a 5-minute stretch and get back, ladies and gentlemen. Once again, a big round of applause for Madam Chief Minister as she completes the inaugural ceremony and exits. Thank you very much. Guys. So you call them the same. I request Dr. Vijay Agarwal, Dr. Lalu Joseph, Dr. Upasna Arora, Dr. Ezekiel Garcia Elorio, as well as Dr. Anupam Sibal and Dr. Sanjeev Singh to kindly be on stage to continue with the launch of the CAHO initiatives. Thank you very much. I understand the excitement. We have a couple of minutes before we start the launch of the CAHO initiatives. I request Dr. Yashpal Bhatia also to come up on stage. Dr. Satish Kapoor, may we have you on stage? May I request our patrons?
Dr. Girdhar Gyani, Dr. Alexander Thomas, Air Marshal Dr. Pavan Kapoor, and Dr. Nagendra Swami, you're requested to please come on stage.
I repeat, Dr. Girdhar Gyani, Dr. Alexander Thomas, Air Marshal Dr. Pavan Kapoor, as well as Dr. Nagendra Swami, kindly come up on stage. Ladies and gentlemen, we begin the launch of CAHO initiatives. Elizabeth.
For the first launch that we're looking at, may I invite on stage Professor Satish Chandra, Dr. Pratish Ravindran, Dr. Chinmay Shah, and Dr. Ebinesh Anthony. This is for the International Journal of Healthcare Quality, Patient-Centeredness and Safety. The International Journal for Healthcare Quality, Patient-Centeredness and Safety will address a spectrum of opportunities and challenges related to healthcare quality, patient-centeredness, preferences, and advocacy both for the healthcare organizations and healthcare providers. Please put your hands together for the launch of this journal.
Ladies and gentlemen, please put your hands together for the launch of the International Journal for Healthcare Quality, Patient-Centeredness and Safety. And may I request the rest of you to kindly be seated. There are people behind you who cannot see.
We can do it with a big round of applause for them. Thank you.
Thank you. The IGHQPCS. Thank you very much. Our exceedingly efficient team. You can exit from center stage, sir. Next, we launch the Spark, the voice of CAHO. May I invite on stage Dr. Darshana Rathod, Dr. Anila Mathin, Dr. Jyoti Clara, Dr. Manish Kohli, Dr. Malati, Dr. Ranjit James, Dr. Ebinesh Anthony, and Dr. Sonali Rawat. The Spark is CAHO's latest endeavor to light the way towards excellence in healthcare quality and patient safety. True to its name, the Spark represents our unwavering commitment to inspiring and empowering every healthcare stakeholder with the tools, insights needed to ignite transformation. Ladies and gentlemen, this monthly dynamic publication is now available for everyone. Put your hands together as we get together for the inauguration, the launch of the CAHO initiative called the Spark. I can't hear adequate applause with 1,000 people in the room. Thank you very much.
Thank you very much. So next up, we'd like to invite on stage Dr. Deepak Saxena, Dr. Suvin Shetty, Dr. Apurva Kumar, Dr. Medha Vadva for the launch of Leading the Way, Transforming Healthcare Practices. This is a compendium of notable practices in healthcare compiled by CAHO and IIPH Gandhinagar. Please put your hands together for this dynamic team.
Ladies and gentlemen, this is a compendium of best healthcare practices unparalleled anywhere in the world. Please put your hands together for this. Which people? May I request all of these current people to please stay on stage. And now let me invite on stage, also in addition to all of you, kindly be on stage. This is, okay. Thank you very much. May I request the following to come back on stage, Dr. Darshana Rathod, Dr. Anila, Dr. Rajiv Singhal, Father George, Dr. Abhinesh, Dr. Sonali Rawat, Dr. Malti, Dr. Ranjit James, Dr. Kohli, Dr. Jyoti Clara, Dr. Sonali Rawat to please come on stage for the launch of the souvenir of Cahocon 2025. Dr. Rajiv Sehgal, please.
That calls for a loud applause, please. Thank you very much. May we now have on stage Dr. J. Balavenkateshwar Subramaniam, Dr. Lalu Joseph, and Dr. Vasundhara Atre for the launch of the Essentials of Safe Anesthesia. This is a practical guide for day-to-day practice that's going to help all anesthetists across the country and the world to get best practices on ground. Request Dr. Balavenkata Subramaniam, Dr. Lalu Joseph, and Dr. Vasundhara Atre. A loud applause for them, please.
Thank you very much. We now move into the launch of the new initiative of the NABCB third-party fire audit accreditation certificate of LGS Assurance Private Limited, a recognized partner of CAHO as a Type A inspection body for conducting fire and life safety third-party audits. May I please welcome on stage Mr. Ajay Sharma, Joint Director, NABCB and Quality Council of India, as well as Ms. Kirti D'Souza, our own in-house specialist on ESG. Ladies and gentlemen, this deserves a big round of applause. We now move on to the Centers for Quality Promotion.
The first center, and we want to call on stage Dr. Nareen Sehgal, MD, Sehgal Neo Hospital, Ms. Abha Saxena, Mr. Pradeep Bansal, Mr. Dharamveer Bhalla, Mr. Suresh Kumar, Mrs. Kalpana Sharma, Mrs. Monica Verma, Ms. Joyce Claudius, Ms. Raji M.R., Ms. Jyotsna, Mr. Kuldeep Sharma, and Ms. Kushbu Malhotra. Sehgal Neo Hospital has been a trusted healthcare provider in West Delhi for over 30 years. Established in 1991 with the vision of offering affordable and superior healthcare to all. SNH has evolved into a multi-speciality 100-bedded hospital with state-of-the-art technology, 4 modular operation theaters, advanced ICUs, luxurious delivery rooms, and a trauma center. SNH has been delivering unmatched care to over 3 lakh patients, ensuring excellent clinical outcomes and personalized service under the leadership of Dr. Nareen Sehgal. Please put your hands together for this wonderful team, Sehgal Neo Hospital, New Delhi.
Noteworthy that Dr. Nareen Sehgal is also fulfilling the responsibilities of the treasurer of CAHO. And we don't have him on stage. Ladies and gentlemen, we'll come back again for Dr. Sehgal. CK Birla Hospital, Center for Quality Promotion, requests to join Mr. Somrata Roy, Ms. Debosmita Malik Chakravarti, Ms. Haranibedita Mohanta, Ms. Juma Basu, Ms. Monami Don, Mr. Pritam Kumar Saha, Ms. Rakhi Mukherjee, Santosh Shankar, Soma Bakshi, Dr. Sudeep Roy, Ms. Sujata Saha Roy, Ms. Vijay Lakshmi Achutan Nair. CK Birla Hospital, CMRI, Kolkata, West Bengal, established in 1969 as East India's first private multi-specialty hospital with 440 beds, including 126 critical care beds, 11 advanced operation theaters. It is NABH and NABL accredited, NABH Nursing Excellence certified, and proudly houses Eastern India's first QAI accredited advanced stroke care center, along with Infuse certification from the Infuse Nurses Society, India. Ladies and gentlemen, please put your hand together for CMRI, Kolkata, West Bengal.
Next up, we have Trichy SRM Medical College Hospital and Research Center, Tamil Nadu. Can we invite on stage Dr. A.D. Edikondalu, Medical Superintendent, Mr. Rufus Shakeen, and Mr. Tamil Selvan K. Trichy SRM Medical Hospital, College, Hospital and Research Center is a leading institution in healthcare and medical education, efficiently managed by its visionary chairman, Dr. R. Shivakumar, and dynamic co-chairman, Mr. Niranjan. Under their exemplary leadership, the institution has evolved into a beacon of excellence, featuring 1,575 bedded multi-specialty tertiary care hospital that offers advanced medical services at affordable prices, particularly to the rural population. The college proudly hosts prestigious accreditations, including NAC, A+, NABH, and NABL, which reflect its commitment to quality, safety, academic integrity, and institutional strength. In addition to the medical college, the Trichy campus hosts various allied health institutions, creating a multidisciplinary environment that nurtures future healthcare leaders. Thanks to the visionary leadership of Dr. Shivakumar and the strategic guidance of Mr. Niranjan. Please put your hands together for a loud applause for them.
May I request Air Marshal Dr. Pavan Kapoor, our patron, to also join us on stage. I think he was absent. We were missing you, sir. Ladies and gentlemen, part of the success story of CAHO is the engagement with students. As we move ahead, we launch 4 new divisions of the CAHO Student Engagement Committee, also popularly called the CAHOSEC. On stage, may I please invite Dr. Amita Marla, Dr. Usha Manjunath. We are launching the medical wing with Dr. Jawahar Pillai and Dr. Sunil Mundkur, the nursing wing with Dr. Lata Venkatesan and Professor Elizabeth Varkey, the MHA wing with Dr. Eileen and Dr. Medha Wadhwa, and the Allied Specialties Wing with Dr. Sunita Saldana and Dr. Anuja Singh. The stage has been tested to bear the weight of all these lovely people. Put your hands together for Cahosec Caho.
We now, next up, will be launching the first white paper for Patient Safety Forum entitled Engaging Patients to Enhance Patient Safety. May we have on stage Mr. Som Mittal.
A big round of applause for Mr. Mittal, a true crusader in the fight of patients for patient safety. Okay. To launch the report, Roadmap to Address Vitamin D Deficiency in India, we were hoping to have Dr. Ashish Chaudhary, but he was unable to come. And therefore, may I please have the pleasure of inviting Dr. Pallavi Verma, co-author, to come up on stage to release the Roadmap to Address Vitamin D Deficiency in India. Put your hands together if you are not vitamin D deficient. A larger round of applause. With that, we come to the end of the Caho launches. But before we step off, we would be grossly amiss if we don't ask ask Dr. Yashpal Bhatia to kindly honor our guest of honor, Dr. Ezekiel Garcia Loria, President ISQA. May I request Dr. Yashpal Bhatia to kindly felicitate Dr. Ezekiel. Big round of applause for Dr. Ezekiel. Thank you very much, ladies and gentlemen, all the dignitaries on the dais. You've been a wonderful group of people to work with, and you've helped us a lot. We can request you all to step off. They're coming next. Ah, okay, you're supposed to launch. Yeah, we're doing it. They have a presentation. Okay, 1 minute. Presentation. They have a presentation. Okay, 1 minute. I think some confusion. However good MCs we may try to be, there's always room for improvement.
Okay. I'd like to call on stage Mr. Anand Iyer, the Chief of Operations of 5C Network, and Mr. Manan Reshamwala, Head of Customer Solutions with 5C Network. Allow us to introduce you to a visionary leader in the world of healthcare innovation, 5C Network, a trailblazer in the field of AI-powered radiology. 5C Network is transforming the practice and impact of radiology across the globe. With a deep capacity for research and commitment to foster excellence, 5C Network has developed groundbreaking solutions that are redefining the landscape of radiology and hospital operations. Their approach integrates cutting-edge technology with hands-on understanding of the unique needs of healthcare providers, ensuring that their solutions are simply impactful. With their solutions, 5C Network is setting new standards in the data and analytics-driven quality, collaboration, and operational efficiency, empowering clinicians and institutions to deliver the highest standard of care. As they expand their scope to solutions with relentless pursuit for innovation and driving the future of healthcare through better diagnostics, their work is helping to create a smarter and more personalized healthcare experience for patients everywhere. Today, 5C Network is about to unveil their latest innovation, Iris, built using their AI expertise, technology underpinning, infrastructure understanding, and operational excellence. I invite the 5C Network team to come over and formally launch their product to the world. A round of applause for them, please.
Thank you, everybody. We are extremely delighted to announce the launch of our AI-powered radiology information management solution. It's called Iris. I mean, true to term, it's the Intelligent Radiology Information Solution. It's a complete AI-powered radiology management solution. And the key thing that we do with this, which makes all the difference in the world of radiology information, is that there is complete AI-enabled automation end-to-end. All orchestrations of workflows, all dashboards, and all manual tasks that can be put to the machine can be moved into the AI-powered radiology management system, which is called Iris. Manan, to talk about. My colleague Manan will just briefly explain what are the key functionalities, 7 functionalities that we are going to do with the Iris AI-powered radiology management solution.
Thank you, Anand. So when we hear AI, we've been hearing AI a lot. What exactly do we mean by what AI is going to offer? So there are 3 broad spaces where we are going to look at solving using AI solutions. One is the operations of the radiology department. So the idea is we automate the workflows, which otherwise are manually handled. It's extremely paper burdened, right? So the key is we can increase resource utilization and improve patient experience at hospitals by operationalizing the automating the operations using our AI solutions. Second is clinical assistance. So we have significant amounts of computer vision and LLM generated tools to assist our radiologists to give greater clinical outcomes for AI solution for their radiology outcomes. And more importantly, this will also help set up and automate QA processes which are required for our JCI, NABH, and such accreditation that we go forward to provide standard of care for our patients. And third, most importantly, is analytics. Now, RIS historically has been a data warehouse. It has loads of data, which is extremely hard to read. How do you go across it? So what we are using with our analytics, AI and analytics, is to support with RCA. understand what the requirement is, where the problem statements are, and suggest solutions and highlight where the issue originally generates, right? This will invariably help the hospitals achieve their research support and their strategic objectives they may have for their departmental management, right? So, yeah.
The other aspect that I wanted to talk about is hospitals are getting larger. The hybrid infrastructure of ours, it can work in on-premise, online, offline, centralized, localized, cloud, public, private, all combinations that are there in hospitals as they grow, as they make strategic acquisitions, they have to deal with multiple interoperability issues. The AI-powered RIS system that we've got is going to be able to take care of all of this. For more information, I would like to invite those of you who are interested to talk to us in stall number 20. Thank you very much.
Hi, good afternoon. I am Dr. Shruti, a Cahocon.
Good afternoon, everyone. I'm Devanand.
So please, can I have the dignitaries of the stage? Thank you so much for honoring us with all the launches. So after the enriching session 1 and 2, now let's dive in the session 3, which is the Viksit Bharat. And the chairpersons for the session is Dr. Atul Kapoor, founder and MD, Regency Hospital.
And the next chairperson is Dr. Satyajit Kumar Singh, Managing Director of Ruben Hospital, Patna.
Can we have the chairpersons on the stage, please? Dr. Atul Kapoor, Dr. Satyajit Kumar Singh, sir.
Can we have Dr. Satyajit Kumar Singh? Yeah, he's coming.
So, for the session, the first speaker for the session is Dr. Atul Mohan Kochar, sir, who's the Chief Executive Officer, NABH. He would be talking on NABH standards as catalyst for digital adoption, India story.
And the second speaker for this exciting session is Dr. Jitendra Sharma, MD and CEO, AMTZ. He'll be speaking on building healthcare resilience through the Make in India story.
The third speaker would be Dr. Vishwa Srivastav, MD, President and COO, SS Innovations International. Topic would be SS Innovations, Bridging Technology and Patient Care with Mantra 3 Surgical Robotic Systems.
And the last speaker of this session is Mr. Subroto Gupta, Chief Strategy and Transformation Officer, Compass Group India. He'll be speaking on how to revolutionize healthcare nutrition. So can we have the speakers, please?
Atul sir, Dr. Jitendra Sharma, Dr. Vishwa Srivastav sir, and Mr. Subroto Gupta sir.
Please, 50 minutes.
Yeah.
I don't see Dr. Atul Mohan here.
Can we have the speakers, please, on the stage for session 3?
Yep, please. Can we have Dr. Atul Mohan? Dr. Atul Mohan, CEO NABH.
Was here only just now.
We shall wait for a minute for him to come and then start the session.
Yeah, he's here. Yeah, he's here. So, Dr. Atul Mohan Kochar, I think, sir, you will be the first speaker, but over to the chairpersons to take the session. We have 55 minutes for this session. So there is a slight change in sequence as one of the speakers has to travel. So I request the other speakers to kindly accommodate. Mr. Subroto Gupta has to leave early, so he has requested to be slotted in number 2. So over to the chairpersons.
Thank you.
Well, I think You said that sir के बाद में होगा. Okay, so Dr. Kochar will start the first lecture for this session. He needs no introduction. And this session is primarily on Viksit Bharat, Made in India, Make in India, and the digital health and digital way forward. Thank you, Dr. Kochar.
Good afternoon, ladies and gentlemen. On behalf of NABH Quality Council of India, it's my immense privilege and with gratitude. So respected chairpersons, my colleagues on the dais, it's indeed a great pleasure for me to be here today. I have been given 10 minutes and the topic for discussion today, the theme for this session is Viksit Bharat. And the theme for the conference is all about collaborations. And the topic which have been assigned is NABS standards as a catalyst for digital adoption, the India story. So probably all of us are aware about the Viksit Bharat theme, which has been given by Honorable Prime Minister. Just a few minutes back, the Honorable CM of Delhi also spoke about what Viksit Bharat is and how collaborations can make a difference. But as far as I see, there are three key words which are in the subject. One is NABH standards, the other is digital health adoption, and the third is the India story. So without much ado, thank you so much for taking NABH where it is today. We are into the 20th year of our operations. And over the past 20 years, we have managed to, with your support, release 29 programs. So we started in 2005 with one accreditation program, but we realized that for a country our size and scale, one size does not fit all. And we today stand at 29 programs of accreditation, certification, empanelment, and these standards have become extremely popular, not because they are thorough, but they are in a language which all of us understand and which all of you have contributed to build. We keep revising these standards every 3 years or 4 years. As the case may be, our flagship standard of accreditation is accredited by ISQA. Not only as an organization, we take pride in ISQA, but our standard also is accredited by ISQA. And all our new standards, whether they are for dialysis, whether they are for blood bank, or whether they are for the Indian system of medicine, the Ayush, all have stood the test, and they are extremely popular, and they have helped raise the level of patient safety and healthcare quality in at least the country. In 2010, we started with the NABH International Program, and today we feel very privileged that 8 countries besides India also are following NABH standard, and very soon we wish and hope to take this number of countries to 20, because we have keen interest from 12 more countries as far as Somalia. So today, 20 countries very soon will be following NABH standards in their own way. What goes behind our certificate is of very much interest to everyone, not only the ISQA mark, but the credibility which NABH brings on the table. Because voluntarily we subscribe to right to information, we open all our books to third-party audit by CAG audit, and about 20 more programs which make, and the endorsement by the government. So Government of India, the Insurance Regulatory Authority of India, they endorse NABH certificates, which translates into financial incentives also, which is not there for any other accreditation body, which I believe is a true test of credibility, responsiveness, transparency, and innovation. We build portals which are totally transparent. We build apps on which assessments are conducted. And though we realize that assessors are our strength, we work with nearly 2,000 assessors. Some of them, of course, may play rogue, and we take no time in eliminating them from the system. We continue to capacity build, train, retrain, and thank you so much, because many assessors I've met today who are amongst from the Cahocon delegates. This is the program data as of today, as of 31st March rather, and 24,377 facilities we take privilege in standing tall on their shoulders. Of course, this is a dynamic figure. There may be some attrition, 10% of overlap, this and that. But by and large, I think the industry support has been phenomenal. So thank you so much to all of you once again for supporting NABH and learning jointly and taking the mission of healthcare quality and patient safety to the next level. This is where I wish to take a pause. Please reflect on this map for a while, where the population of the developed world has been mapped against the federal state structure of India. All of you are aware that India is a federal government. There are 28 states, 8 union territories. So, and if you take all the entire developed world population and some more and map it against the Indian states, then only you can grasp the total impact and the perspective of how big and diverse India is. Dr. Shen, Japan is entirely subsumed in West Bengal, which is a one state. And Sir Jeffrey, in case I can see him, the entire population of not only Australia, but New Zealand is less than that of Chhattisgarh, which is not even a major state. So this is where we are. The entire US of A, including Mr. Trump and Mr. Elon Musk together, is comprised of UP and Bihar. And similarly, the entire developed world. So this is the challenge and this is the opportunity. And whatever solution we think of defining, I think we have to target to this scale and we have to match that with speed. So this is the India, the Indian states and the entire world. And here comes the importance of digital. Because when you speak about such a large population, such a diverse culture, the only bridge which can bridge this fantastic gap is a digital bridge. And that's where the collaborations will come from, which is the theme of Cahocon. And if we are to speak about collaborations, keeping all these things in mind, Government of India about 5 years back released the Ayushman Bharat Digital Mission. For the first time, there is a national framework which tells you how to go about creating digital bridges in healthcare. Something which for the first time gives you a framework where entire digital ecosystem has to come on one platform with interoperability, with unique IDs, with healthcare infrastructure mapping, and not only that, health professional mapping also. And you'll be very glad to know, and Honorable CM also just spoke, that already about 40,000 hospitals are already on that platform. And keeping that in mind, NABH proactively about 2 years back released the first global digital health standard, and already 350 top cutting edge accredited hospitals are already on that platform. And on 1st of April, just gone by, we released that for the entry-level hospitals. And the day we opened, 50 hospitals joined. And of the 13,000, which itself is a very small number, we realized that. But in the days to come, every hospital needs to be on these platforms. And today we have a standard not only for the hospitals, digital infra and digital technology, but also for the software companies, also for the health tech, also for the wearables. So this is something very exciting which is happening. And this is the significance. Not only the NABH Digital Health Accreditation is going to provide enhanced digital care, but also a structured technology, medical innovation, and it's also going to address operational efficiencies and bring in whole lot of benefits in the form of clinical audit trails, information security, and confidentiality. So if we were to summarize the benefits, there is going to be enhanced operational efficiency, clinical decision support, patient satisfaction, and data-driven quality improvement in the terms of monitorable, objective, transparent outcome monitoring and patient outcome monitoring. So that brings us to the collaborations and well-structured forms which can lead to, which is the theme of the conference, of enhancing quality through collaboration, which is the theme of the Cahocon today. And thank you so much to the ISQA president and the entire team of ISQA for coming and sharing the new framework. And thank you, Shane, and thank you, Dr. Lero, Dr. Anuradha, for spending some wonderful moments with us yesterday and releasing the safe care standards. And such standards, such collaborations are the only way forward where we can make a very impactful patient safety journey. To sum it all together towards Viksit Bharat, we all keep speaking about Viksit Bharat, but to understand Viksit Bharat, probably you all have to realize that Viksit Bharat is not only healthcare, but it's also education, it's also technology, infra, agriculture, and of course, the sustainable environmental practices for which NABH also has a standard. And ultimately, ladies and gentlemen, Viksit Bharat is not a concept, it's not an idea. It's an ideology, it's a way of life. And all of us either reach in 2047 together and make India a developed nation, for which all of your support is absolutely essential, or we do not reach at all. And it's a beating heart kind of a surgery where at one moment India is building bullet trains and fighting the space age war. And at the other, we have the challenge of big and diverse country where we really have to think of the last in the line and create meaningful difference of patient safety to their lives also. So at both ends of the spectrum, and the only people who can help India take the Viksit Bharat route and the future of healthcare is you, because all of you are the biggest driver of Viksit Bharat. And with support of you and NABH and CAHO and similar organizations and collaborations, and of course, ISQA-like bodies, I think I have no doubt that we can be there not only in 27, but much before that. Thank you so much for this opportunity.
Thank you, Dr. Kochar. It is really nice to see that where NABH is going now. And this digital health is something which is the way of the future. I'm sure with your, dynamic leadership, NABH will still go places all over the world. Anybody wants to have one or two questions with Dr. Kochar? Anybody? Okay, fine. Then the next speaker is Dr. Subroto, please. He has to travel, so.
Can everyone hear me? Yeah. Well, thank you so much. Good afternoon. My name is Shubroto Gupta, and I think I wanted to kick off on behalf of Compass Group India by thanking the organizers of Cahocon 25 for giving us the opportunity to speak at this event. The theme of Cahocon 25 is collaboration, the heartbeat of progress, and the theme of this particular section is Viksit Bharat. So what I wanted to do in the next 10 minutes is to walk through what we feel could be a partnership between healthcare providers and service providers in building a nutrition-backed foundation that can take us towards building a developed India by 2047. Is there a clicker? Thank you. Before I do that, I wanted to introduce Compass Group a little bit. Compass Group is the largest food and facility management services company in the world. We are about $42 billion. We serve 5.5 billion meals a year across 33 countries. And we are very proud to count 96 of the Fortune 100 companies as our clients. We are one of the largest sectors we have globally is healthcare. We serve about 3,500 clinics and hospitals around the world from an F&B and facility management standpoint. And we count famous hospitals such as the Mayo Clinic in the US and the NHS group of hospitals in the UK as clients. We've been in India for more than 10 years, one of the leading food and facility services providers in India. We are very proud to partner with more than 25 hospitals, premier healthcare institutions in India in their journey as food and beverage partner. And we serve more than 1 crore meals every year in India in the healthcare sector. From the perspective of this particular conversation, there are a couple of important trends that are impacting the healthcare sector in India today. The first is an increasing focus of everybody in society, all consumers, on wellness, nutrition, and experience. So if you look around us, all of us, smartwatches, smart rings, dietitians, healthcare technologists, healthcare tech platforms, there is a general view that people are trying to take more conscious control of their health and well-being. There is a broader understanding that food plays a very important role in the health and well-being of individuals. There is an absolute explosion of organic food and nutraceuticals that are essentially geared to meeting this need. There is also a greater focus on experience. We all talk about being in an experience economy, and experience is extremely important for all of us as both as consumers as well as in every other aspect of our lives. The second trend is, medical tourism is a very big trend in India. Last year, we had more than half a million, 5 lakh medical tourists. The reason it's important for the healthcare sector is it presents a very unique cohort that is now there in the hospital whose dietary and experiential needs need to be kept in mind. India is relatively underserved from a population to doctor ratio. And therefore, what that means for healthcare providers is they need to ensure that these doctors who are stretched, who are stressed, they have the right kind of nutrition, the right kind of support needed to discharge their responsibilities and care. And finally, India is seeing a large amount of private equity and a lot of private capital flowing into healthcare. And what this means is that especially in the bigger cities, there is an increasing concentration of large hospitals. Therefore, it is important for healthcare providers to differentiate themselves, to build stronger brands so that they're able to grow. We believe that healthy citizens and a healthy, strong healthcare system is a foundational pillar for Viksit Bharat, for building a developed country. Healthy citizens are more productive. Healthier children have better educational outcomes. And a strong healthcare system allows us to counter or manage disruptions like the pandemic that we saw a few years back. As a country, we are on the right track. There is an increase in healthcare expenditure per capita, but I think around this room, we'll all agree that we are still far away from where we need to be. Overall, hospitals in the healthcare sector has seen incredible innovation over the last couple of decades. If you just look at, for example, the hardware of care, diagnostics, imaging, from antibiotics to diagnostic imaging to precise robotic surgeries today, there has been a huge evolution over the last couple of decades in the hardware of care. There has also been incredible evolution in the software of care, the data, the EMRs, the HIS, the ability to collect diagnostic data and to be able to create personalized care services has increased by leaps and bounds. But what has happened to the nutrition of care? If I were to take a poll in this room, I think most of you would agree that the thalis you're serving in the hospital today to patients is pretty much exactly the same thalis that were being served 15 or 20 years ago. So while the entire rest of the hospital has moved ahead, while the science linking nutrition to health outcomes has advanced by leaps and bounds, that science has not made its way to the plate in front of the patient. And this is not a conversation only about patients. We believe that this challenge exists across the spectrum. If you look at doctors, for example, they are stretched, they are stressed. Most doctors, most days in the hospital, they do not get time to eat food. Whenever they get time to eat, they do not get the nutrition that they really need to remain focused and productive. Similarly, if you look at patients, more than 60% patients have expressed dissatisfaction with the type of food that is served in hospitals. And there could be up to, studies have shown more than 16% reduction in overall healthcare cost if nutritionally tailored meals were to be served to patients. Food is something that touches everyone every day. It is deeply emotional. It is rooted in who we are. It is an identity marker. It has emotional, social, and nutritional needs. If you look within the hospital, the way this reflects is for patients, what this means is what they really want is nutritionally tailored meals that affect their well-being and outcome. They affect their length of stay, affect their recovery process. For doctors and healthcare providers, what that means is they need to have access to the right food at the right time so that they are nourished, they're refreshed, and they're focused and they're productive in their work. And for visitors, what that means is they need to be able to access the right food throughout the hospital while they're there taking care of the people, their near and dear ones within the hospital. We at Compass India understand this. And our view is we need to look at a delivery of care, a holistic care approach that enhances stakeholder satisfaction across the board. The first part of this is well-being and nutrition. For that, what Compass has done is it has built a proprietary database of macro and micro nutritional data for every dish that we serve in the healthcare sector. So we are able to help dietitians design tailor-made meals for the individuals while they are in the hospital. And all of this has been incorporated in an app. We call it MediRest. I'll show that in just a minute. Safety and quality. In a hospital, it is extremely important, from the ingredients we buy to the cooking process, to the way we serve the food, the operating standards. We believe it's a foundational pillar of greater care and enhanced satisfaction. And finally, experience. We talked about being in an experience economy. So we have the technology stack that allows seamless dining experience for all stakeholders, doctors, care providers, patients, and visitors, from discovery to ordering to payment, and allows them to be able to access a wide variety of food and beverage offerings within the hospital. What all of this does is enables the hospital to drive towards its sustainability journey, for example, reducing things like food waste. And it also helps the hospital maintain standards for accreditations and certificates from bodies like JCI and NABH. Overall, what does this create as outcome? We feel it creates nourishing dining experience that meets the unique needs of each of the stakeholders that we talked about. For the patients, it's about creating tailored meals that impact their well-being and their experience and their happiness and their emotional state while they are in the hospital. We talked about the fact that patient satisfaction is a very big driver of growth and differentiation. For doctors and care providers, it provides them with the right kind of meals that they need at the right time so that they are fueled, they are focused, they are productive in their work. And for visitors, it gives them the flexibility and the variety that they require for them to be able to sustain themselves and to be emotionally stable while they are in the hospital taking care of their loved ones. Some time back, I talked about our nutritional guidance app. We call it MediRest. So we believe this is a state-of-the-art capability that Compass has created to help the dietitians. It's a short video that we want to just show to all of you.
In a hospital, every meal served is not just food. It's a part of someone's journey to recovery. Introducing MediRest app automates the patient menu planning and diet ticket process in just a few clicks. The super intuitive patient meal planning has a menu suggestion based on patient's clinical and digestive state. The dietitian can add or remove a dish and change its serving quantity, provide special dietary remarks with just a tap. While MediRest app filters dishes from the menu that contains allergens based on patients' dietary conditions, the dietitian can even add the favorite dish of the patient or override the system recommendation. With the on-demand option, the dietitian can instantly plan a meal if the patient is hungry between 2 meal times. A critical element of MediRest app is allowing the dietitians to input NPO. Back in the kitchen, MediRest app is equally powerful, instantly generating diet slips for each patient with key individual details captured. The consolidated daily reports by MediRest app enables seamless kitchen operations for the hospital. Compass MediRest app truly prioritize the patient experience and wellness, and remain compliant to the regulatory needs for healthcare certificate accreditations towards its FANB services.
So just to summarize, what this app does, it is actually meant for the dietitian staff within the hospital. It serves 3 primary needs. One is intelligence and better nutritional planning, which allows the dietitian to be more effective in her job. The second is productivity. 40% of a dietitian's time today is spent in analyzing data and aggregating data and creating diet plans. All of this can be done automatically in the app, which saves the dietitian time that can be spent in front of the patient, talking to the patient. And finally, it enables compliance and adherence to standards. For example, in things like allergen management. Ultimately, this is all brought together to ensure that there is the highest operating standards and the right patient gets the right meal at the right time within the hospital premises. We started this entire conversation by talking about collaboration, and we truly believe that a collaboration between healthcare providers and service providers can make a difference. We talked about the fact that today healthcare is a foundational pillar of Viksit Bharat. We believe today that there are several challenges that the healthcare industry is facing. We believe that a core part of that care, nutrition, is something that has not evolved over the last couple of decades, like every other part of the hospital that has evolved. And we believe that the right nutritional approach, the right technology, the right operations, the right standards coming together can really make a difference, help the hospital provide better care to all its stakeholders, and to create better outcomes and to drive differentiation and growth. So we are an F&B company. We cannot really end any presentation without talking about food. So we are proud to present some of the offerings that we present to the healthcare sector. It is available in the counters outside. These are designed by our chefs and nutritionists, keeping patient needs in mind, whether it's around healing, immunity, recovery, mood, emotion, etc. And we would love for you to kind of enjoy this food outside. With that, thank you so much for your time. And it's a pleasure speaking to all of you. Enjoy the session.
Thank you, Subrata. It's really a revolutionary product that you've designed. And I'm sure it'll be a great help to all the healthcare providers who are here. And I think food does elevate the mood of the patients to a large extent and makes their well-being better. Thank you.
Thank you so much.
Dr. Jitendra.
Just before lunch, this man has talked about food so much. Thank you. Dr. Vijay Agarwal and the Caho team. Thank you for organizing the IPL of quality. Nothing in India completes without
getting attached to cricket. And I think this is the best season that you all have brought everybody together. Let me tell you that today we are not standing here by our own merit. It is the work of people like Dr. Girdhar Gyani way back 20 years ago, Air Marshal Pawan Kapoor ji, many people from healthcare quality fraternity, the CEOs of NABH who have done exemplary surveys, Dr. Gayatri Mahindru, our friend Harish Nandakarni, now Dr. Atul. Generation after generation has impacted, right from Dr. Narottam Puri's brilliant cricket commentary and healthcare commentary. A lot has gone into the making of healthcare quality. When it all started, and I remember because Air Marshal Pawan Kapoor was the, I think, first chairman of the technical committee of the standards. When it first started, it started with quarrels. It started with insecurities. It started with fear of penalty. Very quickly, there was a process which was institutionalized, creating something called NABH, which not only gave confidence, it gave knowledge. It not only gave training, it gave incentives. It not only gave brand ambassadorship, it gave even better package in reimbursements. Very quickly, everybody turned a challenge into opportunity, and the whole thing got institutionalized. Then there was a little phase of adoption, because until 2010, the fear was adoption will be in metros. Adoption will be in large hospitals. And I remember as advisor to state government of Andhra Pradesh in 2015, advising the then chief minister, who is also now the chief minister, Chandrababu Naidu ji. I personally signed the MOU on behalf of state government with NABH in presence of our honorable CM, where every single district hospital and medical college was mandated to take NABH. And we became the first state in the country to become NABH compliant from a public sector. That was a phase of adoption. After that, every outcome requires an impact. If you look at the government file on creation of NABH, it mentions a word, the green note sheet file. And I'm sure we should archive this and make a museum out of it, frame it. It mentions a word, it will empower patients. After huge amount of adoption happened, we didn't know whether patients will get empowered. Then the Patient Safety Foundation came by Cahocon, and it empowered the patient. Now we have 15 lakh requests, queries coming in. If you look at the quality journey of healthcare in India, institutionalization, adoption, empowerment, we have successfully completed that in 2 decades. We arrived at the party late, but we have done a great job, because I think true Marwadis start with a dessert. And we have done a great job. Now I'm here to just mention about 2 things, very simple, very specific things. Healthcare quality, as you all know, is a mix of everything. It's a bundle of everything. If a drug is of poor quality, it will have a reaction. NABH can do nothing about it because drug control is under regulatory department of Government of India. If sterilization is at fault, there are issues in another sector. It could be water. Medical technology, if there is a patient burned due to cautery because patient circuit failed, NABH can do nothing about it because medical technology production was at fault. Blood products, the logistics and supply chain is not in the control of a hospital. Now, all these things put together give us the net outcome called quality. Now, I am here to talk about something which is unique, which is medical technology. Until 2015, India was importing 98% of its medical technology requirements from abroad, whether it is CT scans, MRIs, heart valves, pacemakers, operation theater tables, anything, you name it, and we were importing. In 2018, we set up a public corporation, an SEZ, which I head as founder managing director in Visakhapatnam. It's called AMTZ, a centrally supported public sector enterprise. It's a campus of about 8 kilometers with 158 factories, 22 centers of Government of India, 7,000 people. And today, we are able to produce almost 24,000 crore worth of medical technology from one city in India. The same MRI machine that I used to buy in health ministry for 6 crore, I am exporting at 2 crore 80 lakhs. The same biochemistry analyzer that we were buying for 8 lakh rupees, I'm making for 3 lakh 20,000 rupees. The same pacemaker that we were importing for 3 lakh 75,000, I make for 75,000 rupees. At the peak of COVID, when India was consuming 12 lakh RT-PCR test kits every day, we were supplying 11 lakh every day out of it. 1,000 oxygen concentrators, 250 ventilators. But the problem statement is different. You go to Vande Bharat Express, you see made in India. You go to a factory, you see make in India. Do you go to a hospital and see made in India written there? The answer is no, sadly. We don't have made in India hospitals. No hospitals can proudly say made in India because despite producing now everything, we don't prefer what is made in India. Perhaps due to apprehensions of quality. And that is where we are learning from our elder brother NABH how to institutionalize quality in medical technology. We are learning because they have led with an example. So today, my request is, if we are able to make as a country from vacutainer to ventilator, from anesthesia workstation to linear accelerator, from CT scan to MRI, from biochemistry analyzer to operation theater light, please reach out to us when you expand your hospital, when you set up your hospital, because Indian-made medical technology products, best in the class, best in the world, are costing almost 50% lesser than what you would pay if you were to import. And we are setting up these made in India hospitals where first time from a needle destroyer to an MRI would be made in India. The entire hospital will be using only made in India medical products and also exporting to the world. So my suggestion is join us in this story of Viksit Bharat in medical technology. My second point, and then I'll simply stop, is medical technology is a very complex domain. From a mask, which is a spun-bound melt-blown fabric, to a surgical instrument, which is cobalt, chromium, tungsten-plated steel, to an ECG machine, which is an electronics, to a biochemistry, which is a reagent, to an X-ray, which is a rotating anode physics tube. We are a diverse set of items packaged together. The upkeep time of medical technology products due to lack of spare parts, trained human resource is a problem. As much as 32% of medical technology, medical equipment sometimes remain dysfunctional in hospitals, impact the quality of healthcare. So what we have done, because we specialize in medical technology and as a public sector enterprise, this is even a space for us to collaborate between two government institutions, NABH and AMTZ. We have created, along with Indian Medical Device Manufacturing Association, a scheme exclusively for biomedical equipment maintenance certification, where we look at, you don't know the engineer who is coming, to maintain and calibrate your medical equipment is even trained or not. So the certification system looks at the skill of the engineer, looks at the availability of spare parts, looks at the track record of controls and calibrators, looks at the circuit diagrams used, looks at the maintenance records, looks at everything that gives foolproof maintenance as a service. And if maintenance of medical technology as a service, as a quality standard, which we already have, can be integrated with healthcare quality standard, we would have fixed a huge problem in our healthcare, which is confusion around medical technology. So I'll stop there just with these two requests, that our two steps of Viksit Bharat is made in India medical technology. We welcome you to partner with us and collaborate to make medical technology safe by making good maintenance systems possible in your hospitals, for which we already have solutions. Thank you and Jai Hind.
Thank you, Jitin. It was really enlightening because if the equipment is made in India, I'm sure that we'll be having, economical products and healthcare delivery can be cheaper for the patients. I think radiotherapy is one machine which is, not made in India at the moment. And I think Jitendra, if you can work on radiotherapy machines, because the duty by the government is 37%. Duty on a CT scan is about 20%, but on radiotherapy machines, 37%. And the government wants that it's not encouraging lesser duties because they want us to manufacture in India. Now I'll have Dr. Vishwa Srivastav, who is the next speaker. He is a doctor turned entrepreneur, a cardiac surgeon by profession, who has created manufactured this SS Mantra robot for the first time in the country, which is extremely economical. And I am sure that he'll enlighten us more on his product also. Thank you.
Thank you, sir. Just one quick correction. So I'm not the cardiac surgeon Srivastav. My father is the cardiac surgeon Srivastav. I'm just a normal surgeon. So first of all, on behalf of SS Innovations, I'd like to thank the organizers from Cahocon for giving me this wonderful opportunity to present what small part we are attempting to make to change the face of healthcare, not only in India, but globally. So I'm going to talk briefly about our Mantra system and how we're planning to advance surgical robotics globally, emerging from India and then now reaching beyond its borders. This is a picture of our Mantra system. So we, as an organization, we build advanced, affordable, and accessible surgical robotic solutions. I'd like to establish the qualifier that we are Make in India. We are in the highest tier of Make in India, maximum number of parts. The system is completely designed by us in India, by a wonderful team of creative and imaginative engineers. We have our own production facility here in Gurgaon, in Udyog Vihar. And we wanted to be different. We didn't want to copy and reverse engineer like so many other companies are doing. We wanted to make something different that would be better while remaining cost effective so that more patients globally would be able to benefit. So our vision was to make something new, which would surpass the existing technologies while remaining cost effective to benefit more patients around the world. And our vision has always been to make gold standard healthcare affordable and accessible to every single patient in the world. This is sort of our ethos and philosophy at SS Innovations. We want to take our technology expertise, humanitarian vision, manufacturing expertise, and be able to provide advanced surgical robotic technology, affordability, quality, and accessibility to this entire population of surgeons who are clamoring, for the opportunity to be able to get the latest technology so that we can achieve the ultimate goal of decentralizing and democratizing excellence throughout the country. So till date, we've done now 3,500, actually, as of today, close to 4,000 procedures, covering 9 surgical specialties. So from head and neck to colorectal surgery and everything in between, including cardiac surgery. It's worth pointing out that ours is the only system that can support the entire spectrum of robotic cardiac surgery. Till date, now we've launched in 80 hospitals throughout the country, or 75 hospitals throughout the country. We've done 16 telesurgeries and almost 200 robotic cardiac surgeries. I think it's also worth pointing out that we're the only surgical robotics company globally that have a formal regulatory approval by CDSCO to perform telesurgery and teleproctoring with the blessing of the Indian regulatory body. And again, because our chairman, Dr. Sudhir Srivastav, was one of the early pioneers in robotic cardiac surgery, it's very close to his heart, no pun intended, to be able to perform very complex surgeries using our Mantra surgical robotic system. Then you can see here that we have our regulatory approval in India, and not only in India, but also in Nepal, Indonesia, Philippines, Ecuador, Guatemala, many other parts of the world, and our US FDA and CE application is ongoing. We expect to have it by the later part of this year or early next year. our chairman, Dr. Sudhir Srivastava. He's actually the first person who did the first robotic surgery in India in 2002. He's one of the early pioneers in robotic cardiac surgery, having performed the highest volume of robotic cardiac procedures globally and trained more than now 400 teams globally, as he's still actively operating and training today. If you don't know much about robotic surgery, I'll just give you a quick history on the evolution of surgery. So as surgeons, we train that in open surgery. So open surgery is wonderful for the surgeon, horrible for the patients. Why? Because it's maximally invasive, huge scars, big incisions, enormous blood loss, slow return to functional status, infection rate, etc. Then came the advent of laparoscopic surgery, which is now better for the patient, but not great for the surgeon. Why? Because it's challenging, difficult. Everything is counterintuitive. If I want to go up, I have to go down, right, left, etc. Suturing is challenging. Then came robotic surgery, offering greater precision, minimal blood loss, fast recovery, magnified vision, because as surgeons, we all know that any magnified vision will allow you greater precision to be able to perform delicate maneuvers, less pain and discomfort, and a quicker return to functional recovery. But if you look at this global scenario today, so one, they have huge barriers to entry. Of all the robotic systems globally, 95% are between the United States, Europe, and Japan. That means 5% of access accounts for 7 billion people. That's horrible. You know, Intuitive Surgical, which is the main company from the US, only has about 10% of the penetration of global soft tissue robotics. US has the highest number of systems, followed by Europe, China and India, you know, third and fourth, and the rest of the world. So just to show that India only has 1.6% of the surgical robotic systems globally. As you all know, India and robotic surgery is growing, you know, it's expected to triple in the next 10 years. You can see the number of surgical robotic systems globally. Of course, North America has the highest number. India now has 300 systems. And I think it's worth pointing out that the Indian surgery market, so due to the exponential growth of technology, industry, positive GDP, you know, within India, you can see a relationship of everything skyrocketing in the next 5 to 10 years. Similarly, in healthcare, we have to keep up with the times. And the healthcare sector is undergoing a profound transformation and growth, as we can see. But India still, with a population of 1.5 billion, 70,000 hospitals, almost 2 million beds, of which 26,000 are large hospitals, being multi-specialty. There's still approximately only 300 surgical robotic systems in the country since the inception of surgical robotics in 2002. It is worth pointing out that of these 300 systems, in the last 2 years, we've placed 1/3 of the systems throughout the country, from large hospitals like Medanta, Fortis, Manipal, Aster, to smaller hospitals, nursing homes in tier 3 cities, you know, throughout the country. So we're being able to support the entire spectrum of healthcare population within the country, and thereby fulfilling our vision of democratizing access and decentralizing excellence. So till date, we've trained now more than 700 surgeons on our Mantra system. And then just wanted to talk a little bit about our company. So what we do is we have our Mantra system, which is our surgical robotic system. Telesurgery is something that we're doing, and actually just a correction from earlier. So Dr. Rawal, he did the first uro-oncology telesurgery in the country, sitting in our office in Gurgaon and operating in RGCI in Rohini, 40 kilometers away. Since then, we've done now 17 more telesurgeries, but we've also developed a mobile telesurgery platform, which we unveiled at our recent SSI Mantra Surgical Robotic Conference in Gurgaon a few weeks back, which I'll show you in a second. Mudra are our instruments. We wanted to give Sanskrit names to everything. We didn't want to borrow another Italian name for a piece of technology, considering that this is an indigenous system. It's made in India for the world, and it's completely done by our local team of engineers here in the country. And then we have Maya, which is our teleproctoring and simulation and virtual surgery. As you can see here, this is our surgical robotic system. This is set up traditionally for a beating heart, totally endoscopic bypass procedure. So our system is one of the only systems globally that's able to perform this. And till date, now we've done more than 100 different types of surgical procedures, from transoral surgery all the way to colorectal and everything in between. This is our bus that we recently developed. This is helping us be able to decentralize access and democratize. to the smaller patient or the larger patient population that exists in the rural communities and remote areas. Through this, we can drive the bus out into these remote areas, utilizing India's version of Starlink, which is OneWeb, who we've partnered with. Now we can offer telesurg capabilities where these high-speed connectivity, point-to-point connections might not be existing. The next thing that we're also developing after this is a mobile operating room so that we can bring these mobile units out into the remote areas. We run diagnostic camps, telerobotic ultrasound, targeted therapies, biopsies, and should someone require surgery, because as we all know, surgery is the last step, we have the mobile operating room ready, which will be equivalent to all NABH standards. And telesurgery. So the reason for telesurgery, the way that we look at telesurgery is this. It's not like having some, omnipresent surgeon sitting in one place and operating in 100 different places, although working in remote areas is definitely an advantage of this. But we want to utilize telesurgery with teleproctoring to create a very holistic training methodology. So just as we train in surgery, we have an attending in the room. The goal of the proctor is not to do the surgery, but to bring the student to maturity. So through teleproctoring, I'm able to proctor a surgeon at a distance remotely. And should that surgeon get stuck, then I can take over through telesurgery, get them through the next step so that they don't have to convert the case due to their own limitations. This is just a short example of our teleproctoring done over 2,000 kilometers between Gurgaon and Bangalore. And you can see here on the lower part, it's fully immersive 3D so that the surgeon has perfect vision and has the same vision that the student surgeon has. And then our telesurgery architecture. And then I'm very proud to say that we here in India, through SS Innovations, we did the world's first robotic cardiac telesurgery, initially from Gurgaon to Jaipur. We did a beating heart bypass surgery. And then most recently, a few weeks ago, we were able to do the north to south telesurgery cardiac, which is actually very complex. So when people say that, your system is affordable, most people confuse the word of, affordability with cheap and saying that you can only do simple procedures. Well, I'll tell you, beating heart bypass surgery remotely, hundreds and thousands of kilometers away is not, there's no shortcoming and it's extremely difficult. We were able to successfully do it in India, and this is something that we should all be proud of as a country. Till date, the most of all these numbers, the thing that I'm most proud of is that in all these cases that we've done, all different complex types of surgeries from transoral to colorectal and everything in between, including cardiac, zero mortalities, zero device-related injuries, and zero device-related complications. I think this is a testament to the fact that when you have surgeons who started the company, running the company, because we ultimately know that patient safety is paramount and most important in the end, especially in surgical applications. This is just a diagram of the dispersion of cases that we've done till date. As you can see, it covers all specialties, including now close to 200 cardiac surgeries. And the next thing that we're working on is a pediatric robotic system, because we believe this is a huge population that goes overlooked. They're still being operated on maximally invasively, and there's no reason why we should let this population of little ones be left behind. Why SS Innovations? Because we offer a complete digital surgery platform at an affordable cost. And these are your brothers, your sisters, your children, our team of young, bright, imaginative, and creative engineers who you should all be very proud of. Thank you so much.
Thank you, Vishwa. I will now request Dr. Satyajit Singh, our chairperson, to conclude the session with his remarks and comments.
Thank you very much. I think the vision, our Prime Minister, Honorable Prime Minister vision of Viksit Bihar, I think we have got great role, Viksit Bharat, that includes Viksit Bihar, and we have got great role in it. To fulfill that vision of 2047, I think we cannot achieve unless we have got a healthy and educated workforce, young youth workforce. And for that, we have already talked about nutrition, environment. Government policy of Ayushman is one of the world's best, most important scheme, and we must comply with that. But only thing is that we need more funding and more support to the hospitals who are doing all the government cashless and Ayushman. Making this, for that, all professionals have to commit themselves. Made in India is a great step towards the Viksit Bihar, Viksit
sorry, I'm very Bihar centric, Viksit Bharat. I think, like Brajesh has said, that there is now association for manufacturing the equipments here. I think the mantra, SS mantra, has taken a great leap of making robotic surgery very affordable to the common people. And I see, I mean, we have installed the first in Bihar about 10 months back, and we are doing very good, and my patient can afford it. So I think this sort of innovations in India is very achievable. I think the NABH has done a great role in quality improvement, and we were the first to have NABH in Bihar. And thanks to you, and I was personally very resistant to that because of seeing the environment in the society, the poverty and all that. And once our quality person started doing it, the tremendous improvement in the nursing care, the health care, and now other hospitals also coming up. So these are the improvements which I think is a must for all of us. This is another for Viksit Bihar, for Viksit Bharat. Bihar has a great potential for medical tourism because for every Buddhist all over the world is a must to visit Bodh Gaya. And we are preparing ourselves for getting accreditation for having medical tourism to enhance the economy and the capacity of the hospital in Bihar. So thank you very much, Dr. Atul Mohan Kochar. So how much help you gave me in our quality improvement. Biswa, who has made revolution in robotic surgery in India and other developing countries. Brajesh, and I have just talked to him that we are going for a medical college and bigger 600-bed hospital. I would like his help to keep my coming up hospital, and Subrato for nutrition. So thank you very much for all of you coming here. And thanks to
Can we have a round of applause,
for
please?
giving me opportunity. Thank you.
So thank you, honorable chairpersons and speakers. Can we have the photograph, the customary Cahocon 2025 photograph at the podium, sir?
That's right.
That side, sir, on the left side.
We'll go ahead with the announcement.
So meanwhile, the photograph is being taken. Let's go into session 4. That's the healthcare sustainability walk the talk. And for the session, the first chairman is Dr. Alexander Thomas, who's the founder and patron, Cahocon AHPI. Welcome, sir.
And we have the second chairperson for the session is Dr. Arun Garg, Chair and President, Canada-India Network Society, Clinical Professor, Laboratory Medicine and Pathology, University of BC.
The speakers for the session, the first speaker, Mr. Andrew Rosen, Vice President, Joint Commissioner International. He would be speaking on collaboration in patient safety, high reliability, continuous improvement, and environmental sustainability.
And the second speaker is Dr. Victoria Lee, the former CEO and President, Fraser Health Authority. She'll be speaking on sustainable healthcare, Fraser Health Experience.
The third speaker for the session, Mr. Peter Frederick, Managing Director, PTS Division, Sumtas Berger, Austria. The topic he would be taking is pneumatic tube system integration with advanced lab and pharmacy automation. The session has 50 minutes, chairpersons. Over to you.
Yeah, thank you. Once again, on behalf of my co-chair, myself and Caho, welcome to all of you. I know we're just going to break for lunch, but we'll try and keep it crisp. So one of the reasons that we're having this session, the reason that we're having this is that the healthcare sector, the healthcare providers contribute about 5% of damage to the environment. So it's a significant amount, and I think together we need to try and see how we can bring it down. So as healthcare systems around the world, they face growing challenges, both from climate change and resource constraints, to the ever-increasing expectations from patients and systemic inefficiencies. We heard a lot about these inefficiencies earlier today. The call for sustainable solutions has never been louder. So this is actually when you talk about sustainability, it goes beyond only environmental responsibility. It encompasses economic viability, because without economic viability, it is not sustainable, operational resilience, and above all, the ability to consistently deliver high quality care. And that's what we're talking about today, high quality care. Very importantly, giving high quality care without compromising the future. So this session is dedicated to exploring real-world strategies and innovations that demonstrate how healthcare institutions are moving beyond conversations and into meaningful and resourceful action. That's why we have actually named it Walk the Talk. We'll hear different models from the experts that integrate patient safety with sustainability, health systems that have embedded sustainability thinking into their healthcare operations, and importantly, technologies that are redefining efficiency and environmental impact. So with that, I think we'll start the session, and I'd invite our first speaker, Mr. Andrew Rosen, to take the stage. Thank you.
Good afternoon, everyone. I see I'm competing with lunch today. It's okay. Thank you to distinguished chair people and distinguished other presenters. My name is Andrew Rosen. I'm the Vice President of Joint Commission International. I know this is a session on sustainability, and I'll get to that, but I hope you'll permit me to take a short detour to begin. The theme for this conference is collaboration. It's a wonderful theme. So I'd like to talk briefly about how we at the Joint Commission think about collaboration in terms of quality and patient safety. And then I'm going to tie that into sustainability. This is the Joint Commission. We turn 75 next year, more than 23,000 accredited or certified organizations around the world. We have a large team that develop our own proprietary standards. We're always learning, we're always working to improve. You may not know this, but we're called the Joint Commission because we started as a collection of different medical and provider associations who came together to improve quality back in the 1950s. So collaboration is really in our DNA. Now, one of the most important ways that we collaborate is with groups such as CAHO. I'm very proud to be on the advisory council. We work with similar groups all around the world to help advance quality for everyone. We recently announced an alliance with NAEQ, which provides certification for individual quality and safety practitioners globally. The second way that we collaborate is through promotion of high reliability organizations. Now, I remember one of the first major quality studies that I worked on a number of years ago, gosh, maybe 20 years ago now, where we looked at a number of big hospital systems who had been able to sustain measurable high quality across a number of years. We tried to understand what they were doing differently. We expected a series of different best practices from each of them, but what we found is that each of these organizations were doing the same 4 things. And one of the most important of those 4 things was that they understood that quality was everybody's job, from the top leadership to the janitor. And that keeping people safe in the incredibly complex 24/7 high-stakes environment of the modern hospital required leadership prioritization, required the use of every pair of eyes, every pair of ears, every brain, including the patient and their visitors, to be continually alert. Now, this is not to diminish the importance of the quality department. You're the coordinators, the educators, the experts. Thank you for all that you do. But in the safest organizations that we've studied, the culture is that the entire enterprise is ultimately responsible for quality. And so I'd like to offer a special thank you to those of you who are here who are not from the quality department, because you understand this. This joint responsibility, one of the many factors of high reliability we call the environment of collective mindfulness, is one of the core principles of high reliability that we teach to many organizations around the world. Third, and I don't think this is always well understood, we see accreditation as collaboration, not merely inspection. Now, our aim at JCI has always been not regulation, but improvement. Organizations who have been with us for decades have seen this. Our surveyors are in the unique position of seeing best and sometimes worst practice from all around the world. And they spend as much time in the survey process educating, coaching, collaborating as inspecting. It's a very, very important part of how we use accreditation to encourage improvement. And I have an announcement to make, an important one. We're taking this collaborative approach even further through the introduction of JCI Continuous. This will be formally announced across the world in the next 2 weeks, I say. So you're getting a special preview here at Cahocon. So while JCI has increased collaboration during the survey, this happens only every 3 years. And I think you'll see a debate about this later today. Our accredited organizations, many of you asked us for more support between surveys to improve, to focus on areas of most importance and to reduce the all or nothing nature of the survey event itself. So we're introducing a new accreditation approach. You still have a survey every 3 years. You still prepare just as you always have done, but we've found ways to streamline that survey and make it more efficient and more focused, yet still robust. And following the survey will be virtual touch points with survey experts every 6 months across the 3-year period. Not inspections, not surveys, but they're there to support the organization in areas that need improvement and to prepare for the next survey. More information to come on that next week. There's no extra cost to this. It's how we think that we can improve collaboration, and I'm happy to discuss with anyone in more detail afterwards. But let's talk about the most important and the theme for this session, the fourth way that JCI thinks about collaboration, and that's the theme for this session, which is environmental sustainability. I'll start by asking you a question. What do these pictures have in common? I'll let you think about it. I'll come back to it in a second. The rest of my time, I want to answer just 2 questions. Why is JCI focusing on sustainability as part of accreditation? And what does that mean for healthcare providers? So in July, we published the 8th edition of our hospital standards. It was a top to bottom revision. Great to see many of you at our session yesterday looking at some of the changes. Our aim in the revision was primarily to simplify. We reduced the number of standards by about 15%, but we also added a few things. Healthcare moves very fast, so we put new guidance on cybersecurity, EMR, and other technological advances. But most notable and new for us and different is a chapter on global health impact on sustainability. So you may ask, why put sustainability in a quality and safety standards manual? Let's go back to the pictures. What do these have in common? Any thoughts? Shout them out. I think so. I think I heard some of that. Yes, these represent important milestones in patient safety and quality across the past 200 years. Hand washing, sterilization, medication management, preventing patient falls. Now, one way to look at the history of patient safety is to look at it as a series of discoveries, right? Where caregivers discovered that something they were doing or not doing in the process of giving care was in fact also causing harm inadvertently to patients, to themselves, to the community. That's how we realized we had to wash our hands. We had to manage needles safely. We had to control antibiotics and among other things. Because if we didn't do that, those things could affect the patient, but not only the patient, but others as well, caregivers, community. So a series of discoveries, but also a series of battles because changing these things was not easy. There was and still is resistance. And the discoveries and battles continue. So if we come back to the Joint Commission, we're now focused on some of the new things that we're starting to understand create risk. Technology use, including AI, inequity, and importantly for today, unsustainable practices. So we're increasingly aware that the operations of healthcare providers, your operations, caring for your community, can also hurt your community and all other communities. Let me show you what I mean. Climate change is already affecting health. I could give dozens and dozens of examples. Here's just one. Heat-related deaths of people over age 65 increased by 85% across the last 20 years. They're projected to rise almost 4 times in the next 25. But we're also talking pollution, food insecurity, new pathogens, increases in mosquito and other vector-borne diseases, and all of these exacerbating inequity by disproportionately affecting those with lower incomes. As you already heard, hospitals and healthcare providers are big contributors to pollution and climate change, right? 5% or 4.4% of global carbon emissions from healthcare. If healthcare were a country, it would be the world's 5th largest emitter. Hospitals account for about 1/3 of healthcare emissions. But for me, a study in health affairs tells the story best. Researchers estimated that health damages from US healthcare pollution in the latest year studied were on the same order of magnitude as deaths from preventable medical errors. Think about that. That's the first reason why the Joint Commission considers sustainability a patient safety issue and why we're fighting it for it to be considered as such. Healthcare operations, caring for people, harms patients, harms caregivers, and it harms communities by affecting the environment. The second reason is a bit different. I don't need to tell anyone here that the weather seems to have become more extreme. Now, an interesting study came out at the end of 2023 from the Cross Dependency Initiative. They looked at over 200,000 hospitals all across the world under different climate change scenarios. And they tried to work out what would happen with flooding, with wind, with fire, and with rising sea levels in each scenario. And what did they find? They found that by the end of the century, if nothing changes, 1 in 12 hospitals would be at high risk of failing, shutting down due to extreme weather. And now, if these hospitals were residential or commercial buildings, they'd essentially be uninsurable. Now, I know the end of the century seems a long way away, but it's already started. In the last 30 years, there's been a 61% increase in Southeast Asia, for example, in risk of damage to hospitals by extreme weather events. And Asia is particularly vulnerable. On the right there, you can see a list of countries with the most high-risk hospitals. Who was number 1? India. 1 in 10 hospitals at high risk of failure. Although I would say island countries in Southeast Asia will be worse off, closer to 1 in 4 hospitals. In most places for now, the issue is flooding. In the future, it'll be rising coastal waters. So whether or not your hospital or health system is contributing to carbon emissions and pollution, whether or not you consider your operations a patient safety issue, climate change is going to affect you in other ways. Extreme weather will make your facilities and operations vulnerable. They may make them inaccessible. You may have no power, no food, no water. Staff may not be able to travel in. And even if you're not damaged, are you ready for surges in volumes when the community is hit by weather or famine or dengue or heat stress? So the other patient safety issue here is to do with how prepared your organizations are for climate change. Hospitals are already pretty tough. You certainly are prepared for heat here. But what happens when it becomes 55 degrees, 58 degrees in summer? We believe that hospitals have to improve their resilience even further to keep their communities safe. That's why the Joint Commission sees it as imperative to start to consider sustainability, not just an ESG issue, not a political issue, but a patient safety issue. And I'm thrilled to see that Cahocon in India are thinking the same way. And this is why we work together with the Geneva Sustainability Center, part of the International Hospital Federation, to create standards for it to be part of our general safety and quality standards for all hospitals and AMCs. We made the standards available to any accrediting organization to use. I know that for some of you, you've been working on sustainability for a very long time. However, I also know from talking with many of you that tackling sustainability is not something that's been on your agenda, and adding it to accreditation can seem overwhelming. Many of you are worried about that. So what I'd like to show you across the last 2 minutes really is that this is nothing.
Can you wrap up in about 30 seconds? We're running out of time.
2 seconds.
Thank you.
Essentially, what we've set up here, 5 areas of standards. Each one of these are around beginning the standards journey, right? So we don't set targets. They're around setting up someone who's in charge of sustainability, someone who is reporting it, educating your staff, using environmental resources, understanding what your power use is. You already know that. Particularly looking at the procurement and supply chain management, where 80% of emissions come from. And finally, looking at your emergency plans. This is a start. We believe there are tools that are available for free to be able to achieve any of these, and a very important part of this. We believe sustainability ultimately is the ultimate form of collaboration, because in a sense, you are collaborating with every other organization around the world to protect everyone's communities. And with that, I'd like to thank you.
Thank you. I'll request my colleague and the former CEO of Fraser Health Authority, Dr. Victoria Lee, to do her presentation. Please welcome Dr. Victoria Lee.
Thank you. Good afternoon, everyone. It's great to be here, and I'd like to start by acknowledging and thanking the organizers of CAHO. It's an impressive conference, and just great to see everybody that's here. So thank you very much for having me. And I'd like to go through sickness to wellness care and how sustainability plays a role in that. So this is just a model, and I don't think it really matters where you are in the world. I've been to many, many different places looking at comparative health systems, and many of the health systems in the world are looking at sickness care, even though we call it healthcare. And I believe that the transformation that's required for us to be sustainable, whether it's financially, environmentally, is actually to turn it from sickness care to wellness care with some of the components that are mentioned here. Apologies, I try to switch it to CAHO PowerPoint template and the words are very small, but basically sickness care is very reactive, whereas wellness care would be much more proactive, and it's empowering individuals as partners instead of doctors as a center of knowledge, and it would be more individualized and precise instead of having one treatment for all, and we would actually know the value of the health system and the outcomes instead of unknown values, which is often the case that we are living in. And you did a great job of looking at all of the impacts of health impacts of climate, and also why it's important for us to pay attention. And whether it's the International Panel for Climate Change or whether it's the World Health Organization, we know that climate sustainability are some of the greatest public health threats for us to pay attention to. So basically, I think from health system perspective, what we're looking at in Canada, even in Malaysia and other places globally, is beyond sustainability. How do we actually contribute broader to planetary health? And we were looking at earlier this morning, one of the quality arms is equity. And healthcare sustainability and planetary health actually impacts equity in that most vulnerable people are most impacted by sustainability, environmental degradation. Impacts of the health system from various emergencies. Even though Canada is much more moderate in terms of temperature, it was very much felt in British Columbia because we actually had 1 in 1,000 heat dome event where we had hundreds of seniors that passed away, and tragically, as well as 1 in a 500-year flooding event and water where we had normal cities that became islands unto themselves. And we already heard about the fact that health system is such a big contributor in terms of our carbon and greenhouse gas generation as well. And in fact, we surpass aviation. So I think what's important for us as leaders in health system is to turn these thinking and background into actions that's meaningful. And I like to focus on actions because we often focus on problems and what's our problem instead of talking about how do we get out of the problem and what can we do, what's our role in the health system. And I do believe that we have a very strong opportunity in our health system to actually have solutions that are healthy for people, healthy for our communities, and also healthy for our planet. So what does that look like? So I'm sure many of you have never heard of Fraser Health. It's actually one of the largest health service delivery systems in the country. And even though it's a small population in comparison to India, it's one of the largest population sizes in Canada because we look after about 2 million people. It's very diverse, 32 First Nations communities, 20 municipalities. We have over 90% of refugees in the province that settle into our region, as well as 40% of newcomers. So when we were looking at what do we do in our sustainability, what do we do overall in health system impact and making a difference for healthy people, healthy communities, one of the areas that we looked at was South Asian Health Institute. And in fact, Dr. Garg had a very, very pivotal role in establishing that in 2013. And the reason that we looked at South Asian population was that was one of the most populous and diverse populations in our region. So I think sometimes when we look at how do we provide culturally safe care and culturally appropriate care we only look at languages. We're translating, so that's enough. So we're translating our services, emergency services, OB-GYN services into different languages. But what we have learned through that experience, and again, Dr. Garg has been incredibly supportive in establishing not only the institute, but also connecting the dots with Canada-India Network Society and also CINI, which is a broader connection between Canada and India. What was really important is the role of culture. And the role of culture became an important parameter for us to establish services from addiction services to health services in long-term care, rehabilitation, elderly services. And we started to actually engage in broader communities in schools and gurdwaras, and also going out to temples and talking about health and wellness in a different way. And in fact, we actually decreased amount of sugar that's being used in chai tea as an example. But I think this is the most fun example. And I think I need help from the folks on the tech side to play the video. And this is a video of how we had in our adult day center had seniors that were able to get their physical activity in a different way. And hopefully it'll play. Says it's not available. No luck? Anyway, we'll have to share it another time because I don't have too much time up on the stage here, but it's basically seniors learning how to dance with Beyonce music. And I thought it would get the crowd going and dancing, but it'll have to be another time for that. So the other very, very important work that we've done is to look at that cultural importance with Indigenous population in our region, because as First Peoples in Canada, they also have lots of learnings and knowledge in climate and how do we live with our earth in a way that's much more sustainable. So the things that we also heard from our Indigenous population and communities was, how do we look at 7 generations ahead? How do we look at sickness from wellness? There's traditional knowledge and healing practices that could be included, as well as some cultures look at impacts of climate differently because there's climate anxiety and those types of impacts that are very different from colonialism as well. I think there might be some, I think, alignments in that area. So planetary health beyond sustainability became one of the anchor areas of our objectives and key results at Fraser Health. And that was looking at reducing our impact as well as becoming an anchor institute, being ready for emergencies, as you were talking about it from Joint Commission and what you're looking at in accreditation, as well as collaboration with our partners, because that's where we can have the biggest change and biggest impact at the population level. And I think what was really interesting was that we could do little things that became a big thing. So this is a very small example of the many things that we've done to be carbon neutral for 15 years of Fraser Health. And one was actually changing the climate impact of inhaler therapy, where going from salbutamol, for instance, to dry powder-based inhalers actually reduced our carbon output by 22%. And that's just one single example of what we've been able to accomplish in a short time to be carbon neutral. But there's so many areas, from food services, how we build our buildings, to how do we actually maintain our buildings and what kind of surgical instruments we use, as well as how we train people in a thinking very much in an integrative, connected way, looking at culture, looking at built environment, looking at all of the determinants, health as well, that will turn from sickness care to wellness care. So with that, I will leave you with this, because I think it also connects back to why we're here in India, because I think there's such ancient knowledge that really integrates mind, body, spirit, that I think Western cultures and systems can learn from. And I hope that we can bridge that gap to actually ensure that we have wellness care that moves forward, not only for our people, but communities, but for the planet as well. Thank you.
Thank you, Victoria, for being right on time. Okay, I'll request our next speaker, Mr. Peter Friedrichs, to speak on the. Please welcome Dr. Friedrich.
So thank you so much to be part of your great Cahocon summit and give me the possibility to introduce Summitsberger, Austrian product made in European Union. And we are proud to give this latest healthcare technology of pneumatic tube transportation system to the Indian market, and already successful in 170 hospitals in India. So we are the founder of the modern pneumatic tube system with fully automated pneumatic tube distributions on hospitals, and using this in laboratory blood samples, transportation and automation, pharmaceuticals and other items like ampoules, blood bags and injections. So all small items in a hospital are shooting through our pneumatic tube system to all the locations in your hospitals. So our company is already well established and was founded 1921, and we are in the total international market of pneumatic tube systems since 1990. The roadmap you can see in my presentation. We started with as a small electrical installation company, and now we are an integrator in hospital logistics using PTS transportation as our favorite product, and then also AMR robotic systems for the bigger and bulkier loads in your hospitals. A small diagram of our pneumatic shooter and pneumatic tube transportation systems to see, but I think this most of the people are already knowing, because it's a must in every modern hospital all over the world. So what is this pneumatic shooter system making so reliable and stable? It's a one-touch only system with a full automated laboratory integration. That means take the blood at the nurse at the bedside and send it fully automated into the analyzers and get the results in a few minutes. It depends for sure what kind of testing you are providing from the blood samples. So this is what the modern pneumatic tube systems are following, and giving this product a totally new market presence and gives it as a modern transportation application to all of the hospitals worldwide. It's fully automated and transported in safe and secure capsules, which are manufactured with silver ion technology, and you have no problems. You don't have any infections because of transportation of all your goods to all the locations in your hospitals. So this is the case that you can use it all departments and have no problems with this. The next level of pneumatic tube is to distribute the samples to different locations, to different labs in your hospital. So you are automatically receiving, you are sorting, checking in your samples, valid testing, and send them to the different lab applications using the big players in the market like Abbott or Roche or Beckman Coulter, and send it to their bulk loader to proceed them fully automated. That's the reason why we call it one touch only. So nobody has to touch the sample in the lab. It's just from the nurse, and the result is fully automatically back to the nurse places, and nobody has to check if it's lost or if there is any complaints on this transportation. This is possible with an integration in the Sort Pro, which is a high sophisticated 3,000 sample check in an hour, which is amazing fast, and is already possible to give all the pre-analytic sample checks in 3,000 samples per hour. So this machine is already coming soon. So we are proud in Holy Family to install this in the next 3 months and give also this new innovation to the Indian market. The next step is the box picking system of integration into the PTS, that you make the logistics from the pharmaceuticals up to the point of care to the nurses in a full traceability. So you just order the boxes of medication from the automation. It's fully automated, loaded into the pneumatic tube shooter, sent to the right location, and the nurse can access with an access card to this medication, and you have the full track and trace of all your items you are moving from this machine to any places in your hospital. The robotic pneumatic tube station can be integrated in any of these logistic centers where you are stocking your medications and sending them out to the point of care of the nurses. And at this point of care, we have a software application used for handheld devices which can scan the medication, scan the wristband of the patient, and you have in every second the full traceability of all the medications which you already gave to your patient, and have the full report during his stay in your hospital. The same is happening with the blood samples. You scan the wristband, you print the barcode, you send the sample to the lab, and the one-touch system is giving you the results immediately from the analyzers of any of your equipments you are using in your lab automation. So all these equipments are full automated. The vision is to have the logistics in a hospital in a full automated systems and track and traceability and reporting of the patients during the stay in your location, in your hospital. So what is the conclusion of this? The best choice is to go with box picking automation, traceability of medication, sorting of samples, checking into your lab automation system, and report the results immediately to the nurses as soon as possible. So Summitsburger is the #1 choice for hospitals 4.0 IoT solutions, and makes the hospital much more sophisticated, and you are ready for NS2, and all these regulations are coming soon. So thank you so much for following my presentation, and I hope I can give you a small intervention of our product.
Thank you, Peter. Thank you for being on time. Yeah, so thank you very much. Now, this is my great opportunity to conclude the session by saying few words. I want to start by acknowledging and grateful for my heritage of Indus Valley Vedic yogic science of some 5,000 years young and its influence on my career. I am from Canada. We have a custom of acknowledging of heritage of First Nations and its interrelations and impact on present. These are acknowledgement a part of sustainable thinking. Our theme of our session is similar to the Diya lightning of India. Sustainability is a value, interconnected and part of other values like quality, safety, collaboration, accountability, among others, and what it means. Sustainability needs to be, friends, sustainability needs to be part of our thinking, which is our mind, and part of all decisions we take, all policies we develop, every action, every thought, strategy, tactics, process, and incentives must include sustainability. The biggest threat to sustainability is our dependence on reductive thinking and not integrative thinking. We need both, as progress of last 500 years is possible because of reductive thinking. It provides focused outcome and it is linear and concrete. Integrative thinking is a circular and abstract. Again, we need both for sustainability. Biomedical model fused with psychosocial model. In other words, fusion of best of East and best of West. India is the leading this, and Caho can provide a global leadership. It's natural with our theme of Vasdev Vasu Kutamba. As stated by my colleague, Dr. Lee, and mentioned several times by Dr. Jeffrey Brathwaite of Australia in his opening remarks, India can lead the globe in sustainability. So thank you. Long live quality. Thank you very much.
Thank you, chairpersons and honorable speakers. Can we proceed for the photograph at the Cahocon 25? So before we have the launches, there are a few announcements. The EndoSafe and iComply awards would soon start after a few launches. So the nominees or the winners can be here in the conference room. Please gather here for the award ceremony.
And one more announcement is that the delegate kit, your delegate kit will be available at room number 8. So please don't forget to collect your delegate kits. So we'll get ready for the launch of the Supply Chain Leaders Forum. And I invite Mr. Vinod Kumar and team to be on the stage. I also request Dr. Lalu Joseph and Dr. Dilip. Yeah, also I request Dr. Vijay Agarwal and Dr. Pawan Kapoor to be on this stage, please. Alex sir, can you please remain on the stage for the launch of the Supply Chain Leaders Forum? Yeah.
Yes. So we have the Caho Supply Chain Leaders Forum. The Caho Supply Chain Leader Forum is a strategic initiative aimed at strengthening supply chain management in healthcare, recognizing the critical role that procurement and supply chain professionals play in ensuring efficient, cost-effective, and patient-centric healthcare delivery. This forum seeks to build capacity, encourage collaboration, and drive innovation in healthcare supply chain management. The healthcare industry faces unprecedented challenges, including supply shortages, cost fluctuations, regulatory requirements, and the need for sustainable procurement practices. The forum will serve as a dedicated platform for professionals, industry experts, academicians, and students to share best practice, discuss the emerging trends, and promote innovations and can lead to efficient healthcare supply chains.
The vision of the forum is to be a leading platform for procurement and supply chain professionals dedicated to advancing quality patient care through collaboration, education, and innovation in patient-centric sustainable supply chain management practices. And the mission of the Cahocon Supply Chain Leaders Forum is to empower procurement and supply chain professionals by providing a forum for knowledge sharing, networking, and professional development.
Good afternoon. It's a very, very proud moment for us at Cahocon to be launching the Cahocon Supply Chain Leaders Forum. Let's give a big round of welcome and appreciation to Mr. Vinod and his team for being here. Please join on the stage. So, Cahocon Supply Chain Leaders Forum, we see the importance of having sustainable efforts in supply chain, and this is the main reason as to why we are forming this forum. So give your support to the forum. For all the purchase managers in hospitals, this is the forum for you. Kindly join us. Give them a big round of applause, please.
Cahocon, that the console thing somebody else has to manage.
And now we have the SHCO Forum launch. So can I invite Father Johnson, Mr. Ranjit Krishnan, Dr. Nirmal Frederick, Dr. Francis Roy, Mr. Adel, Dr. Malati, and Dr. Balamurugan and Ms. Gayatri Sandeep. Please be on the stage.
So this forum is a real boon to the small healthcare organizations led by Father Johnson. Give them a big round of applause, please.
The next we have the release of white paper. Okay.
What is that?
Ladies and gentlemen, let's give a big round of applause to the Small and Medium Hospital Forum. We realize the importance of having a forum for small and medium hospitals, particularly considering the complexity of operations and the lack of availability of trained manpower in these hospitals. So this forum was initiated in our state conclave at Tamil Nadu, titled UIR. So really appreciate the efforts of Father Johnson and the team here. Let's give them a big round of applause. They are going to be handholding the small and medium hospitals in the country. Thank you so much.
Thank you so much. So now there is another launch, the release of white paper by Cahocon Student Engagement Committee, led by Dr. Amita Marla. Can we have her on the stage, please? So the white paper Cahocon, re-imaging healthcare education, integrating patient safety and quality assurance. It was prepared by the Student Engagement Committee and Cahocon. Health has evolved greatly over 2 decades in terms of knowledge of disease and technological innovations, making it very challenging and it to provide safe care in healthcare settings. Among trained healthcare categories like doctor, nurses, and allied sciences. The future of healthcare depends on a strong educational foundation that prioritizes patient safety and quality assurance as core components of the healthcare programs. Despite the increasing complexity of the healthcare and the growing emphasis on the reducing medication errors, they lack structured education. So can we have the Student Engagement Committee.
So I think they are not around. We will do the launch a little later. This is a white paper by the Caho Student Engagement Committee. Yeah, so would request the Healthcare Engineers Forum to kindly come on stage. Let's give a big round of applause to the Healthcare Engineers Forum. What started as a very small spark is now with more than 450 engineers. So now we have 3 verticals under the Caho Healthcare Engineers Forum. One dedicated exclusively to the clinical engineers, led by Mr. Arul Prakash, Chokalingam and Jennifer. The hospital planners, the maintenance teams, Mr. Vinod, Mr. Vijay, Mr. Prem. Let's give them a big round of applause. They have a huge army behind them, the Healthcare Engineers Forum.
So we are moving to the awards presentation for the EndoSafe and I Comply. So can we have the guests of honor, Dr. Shin Ushiro and Dr. Shani De Silva on the stage, please. We also request Dr. Vijay Agarwal to join the stage and the program coordinators for EndoSafe, Dr. Parivalan Rajavelu, Ms. Danya Michael, Mr. Nikunj Goenka and Ms. Barnali Barik.
So the awards are So the awards would be zone-wise and into 3 categories: large, medium, and small care organizations. So we are starting with the EndoSafe Awards, East Zone. So in the East Zone, large healthcare organization category, the winner is CK Birla Hospital, CMRI, Kolkata, West Bengal. Congratulations.
Big round of applause for the CK Birla Hospitals.
The next category is medium healthcare category, East Zone, and the winner is ILS Hospitals, Dum Dum, Kolkata, West Bengal.
Yeah, we need some more energy, please.
ILS Hospital, Dum Dum, Kolkata. Small healthcare organization. The winner is Indian Institute of Liver and Digestive Sciences, Kolkata, West Bengal. Please, till I announce, they can just line up here. So East Zone, again, large healthcare organization. The runner-ups are from Ruben Memorial Hospital, Patna, Bihar. Can we have near the stage, please?
The Ruben Memorial Hospital. We have someone from the Ruben Memorial Hospital. Okay, we go to the next.
We have the medium healthcare organization category East, Orchid Medical Center, Ranchi, Jharkhand as the runner-ups. Can we have them on the stage, please? Orchid Medical Center. So we have the small healthcare organization category East runner-ups, Tata Steel Medica Hospital, Kalinga Nagar, Odisha. Can we have them on the stage, please? So moving on to the North Zone, the large healthcare organization category winner, Fortis Hospital, Mohali, Punjab. Round of applause, please. May we have somebody from Fortis Hospital, Mohali? Anybody from Fortis Hospital, Mohali? The next is medium healthcare organization category North Zone, Rukmani Birla Hospital, Jaipur. As the winners, please can we have them on the stage?
Rukmini Birla Hospital, Jaipur. They are the winners in the medium healthcare organization category from North.
The next small healthcare organization category North Zone, the winners are Sehgal Neo Hospital, New Delhi.
Can we have the Sehgal Neo Hospital team be here?
The North Zone runner-ups large healthcare organization category, we have Aadhar Health Institute, a unit of PLCom Healthcare Private Limited, Hisar, Haryana.
Next is in the large healthcare organization category runners-up from North is Mahavir Jaipuria Rajasthan Hospital, and my co-host is also joining the team there. Mahavir Jaipuria Rajasthan Hospital. We need some more energy to motivate them, inspire them, please. Keep the applause going on. So we move to the south in the large healthcare organization category. The winners, Justice K.S. Hegde Charitable Hospital, K.S. Hegde Medical Academy, deemed to be University, Mangalore, Karnataka. Can we have? Yeah, I think team is here. Now the winners, please. You all had lunch, right? Not be in the sleeping mode, please. South in the medium healthcare organization category, the winners are SCS Hospital Private Limited, Mangalore again. SCS Hospital, Mangalore. Do we have anyone? In the small healthcare organization category, South winner is Morris Matthias Hospital, Nagarkoil. Yes, Morris, yeah. We have the runner-up from South. Yeah, well, the Morris team is there. We have the runner-up from South, large healthcare organization, Lakeshore Hospital, but we are informed that they are not present here. So we'll move to the runner-up category in the large healthcare organization category. Sri Gokulam Medical College and Research Foundation, Thiruvananthapuram. Do we have anyone from the Gokulam Medical College? We don't have, yeah, sorry. So the large healthcare organization category South runner-up, Pushpagiri Medical College Hospital, Tiruvalla, Kerala. So we have one more runner-up in the category after Pushpagiri, which is Caritas Hospital and Institute of Health Sciences, Kottayam. This is the large healthcare organization category. Do we have anyone from Caritas Hospital?
So now we have medium healthcare organization category South runner-ups Sri Kaveri Medical Care India Limited, Radial Road, Chennai, Tamil Nadu. The next is medium healthcare organization category South runners-up Kims L Shilpa Healthcare Private Limited, Kerala.
Please wait, Kim's team, please wait. Kim's. The Kim's Al Shifa team is on the stage. Sri Kaveri Medical Care India team has to yet come to the stage. Yes, next Sri Kaveri Medical Care India Limited, Chennai, Tamil Nadu. Runner-up for medium healthcare organization category, South.
The next is small health organization runners-up South Zone Apollo Spectra Centers Private Limited, Chennai, Tamil Nadu.
Now we move to the West. The large healthcare organization category, the winner, Kim's Kingsway Hospital, Nagpur, Maharashtra.
Can we have a round of applause?
Audience, please cheer the winners, the runners-up.
Next we have medium.
We have Kim's Kingsway Hospital, Nagpur on the stage.
The next we have medium healthcare organization best winners Noble Hospitals and Research Center, Pune.
Global hospitals are the winners in the medium healthcare organization category from West. Keep the applause going, please.
The next we have large healthcare organization category best runner-up Ruby Hall, Pune.
Ruby Hall Clinic Hospital, Pune, Maharashtra, runners up for the large healthcare organization category.
The next we have large healthcare organization West runner-up, Jahangir Hospital, Pune.
Jahangir Hospital on the stage now, runners up for large healthcare organization category. The next hospital is KD Hospital, Ahmedabad, Gujarat. Again, runners up for the medium healthcare organization category from West. KD Hospital, Ahmedabad, Gujarat. Do we have anyone from KD Hospital?
Anyone from KD Hospital? The next is runners-up medium healthcare organization category West Zone Holy Family Multi-Speciality Hospital, Bandra, Mumbai. Thank you so much, Dr. Parivalan, Ms. Dhanya, Mr. Nikunj, and Ms. Bernali Banik for such an amazing EndoSafe program, which was designed exclusively for the endoscopy units. And I hope this is going to continue. The journey will be strengthened more. Thank you so much. And now we will move on to the I Comply Awards. The program coordinators for the EndoSafe can step down, and for I Comply,
We have Dr. J. Jayalakshmi, Dr. Grace Mary John, and Dr. Rolinda Baker. Can we have them on the stage, please? Dr. Grace Mary John.
so again, it is against zone wise. So we are starting with East. So East Government Healthcare category winner, Chitranjan National Cancer Institute, Kolkata, West Bengal.
Let the applause continue, please, audience.
They have put in a lot of hard work. Zone winner, Woodlands Multi-Speciality Hospital, Kolkata, West Bengal.
We have the Woodlands Multi-Speciality Hospital team here. Woodlands, India. Chittaranjan National Cancer Institute. Yeah, now we have Woodlands Multi-Speciality Hospital from Kolkata. Winners for the East Zone.
The next we have the first runner-up East Zone, Shija Hospital and Research Institute, Imphal, Manipur. Shija Hospitals, Imphal, Manipur.
Do you have anyone from Shija Hospitals here? Okay, move on to the next.
The second runner-up East Zone, Charnock Hospitals Private Limited, Kolkata, West Bengal.
Yeah, Charnock Hospital Private Limited is on the stage.
The next we have second runner-up East Zone, Bente Hospital, Shillong, Meghalaya.
Can wait, wait.
Can you wait?
Madam, wait.
Can you?
We have the Charnock hospitals on the stage now. Yes, followed by Bethany Hospital, Shillong, Meghalaya. Second runners up East.
The next we have Best Zone winner, Bharatiya Vidyapeeth University Medical College Hospital and Research Center, Pune.
The West Zone winners, Bharatiya Vidyapeeth University Medical College Hospital.
The next we have West Zone first runner-up, Bharatiya General Hospital, Mumbai.
We have someone from Bhatia Hospital, General Hospital, Mumbai.
Bharatiya General Hospital first runner-up, West Zone. The next is West Zone first runner-up, Cahocon Hospital, Umrao Institute of Medical Sciences, Thane.
We have our stage committee chairperson himself coming to get the award. Dr. Bharat. Good round of applause for the Cahocon hospitals.
The next we have second runner-up, West Zone, Medanta Super Speciality Hospital, Unit of Global Healthcare Limited, Indore.
Vedanta Indore.
The next we have second runner-up, West Zone, Kim's Kings Highway Hospital, Nagpur.
Kim's Kingsway Hospital, second runner-up for West. I Comply Awards.
The next we have second runner-up, West Zone, Ankura Hospital for Women and Children, Pune.
Do we have someone from Ankura? After this, we move to the north. The winner for North Zone is Rukmini Birla Hospital, Jaipur, Rajasthan.
The next is North Zone first runner-up, Fortis Hospital, Mohali. Shweta ma'am, where are you?
On stage now, Rukmini Birla Hospital, Jaipur, Rajasthan. Audience, I think you all have slept.
The food has made everybody lazy.
Please give a huge round of applause for these hospitals who have done a wonderful job. Can we have Fortis Hospital, Mohali on stage?
The next is South Zone winner, Royal Care Super Speciality Hospital, Coimbatore.
Winner for South is Royal Care Super Speciality Hospital, Coimbatore. We have the first runner-up from South, Rajagiri Hospital, Alua, Kerala. We have Father Johnson here. Or anyone from Rajagiri Hospital. Yeah, Danya is here.
The next we have second runner-up South Baby Memorial Hospital Limited, Porticode.
It's Kozhikode. That's my place. Second runner-up from South Baby Memorial Hospital. We have the stalwart Gracie, Madam Gracie Matai coming to receive the award.
The second runner-up South Zone Apollo BGS Hospital, Mysore.
Do we have Apollo BGS? Yes.
The second runner-up South Zone Malabar Institute of Medical Sciences, Aster, Calicut.
Yes, that is my team, part of Asta.
So we have Special Recognition Award South Zone Daya General Hospital, Kerala. Daya General Hospital on the stage. Second Special Recognition Award South Zone Meenakshi Super Speciality Hospital, Madurai, Tamil Nadu.
Do we have somebody from Meenakshi Super Speciality Hospital, Madurai?
Oh, ma'am is there. The Special Recognition Award South Zone Mary Queen's Mission Hospital, Kerala.
Mary Queen's Mission Hospital, Kanjirappalli, Kerala, Special Recognition Award. After that, we go to the Special Recognition Award again, South Aster Hospital, Bangalore. Since it's my organization again, I will take the privilege to join the team.
The last of the category, the Special Recognition Award South Zone, Sri Kamanchi Medical Center, Tamil Nadu. Sri Kamachi, sorry for the pronunciation. So this concludes the award ceremony for I Comply. We thank Dr. Jayalakshmi ma'am, Dr. Grace Mary Johnson, and Dr. Rolando Bakker for the amazing program designed for the infection control practices.
We also thank the guests who have come to give away the awards. We request the next MCs to come in. Dr. Nirmal is on his way.
I hope the delegates have collected their kits from room number 8. That's available in room number 8.
Lot of things to come. The most awaited debate is going to happen very soon. Please be here. It's going to be very, very entertaining. So over to you.
Thank you for the day. Thank you.
Thank you, Dr. Dev and Dr. Shruti. So good afternoon, everyone.
Good afternoon, everyone.
I'm Dr. Nirmal Frederick.
And I'm
We'll-
Devashri Chatterjee.
We'll be taking you through the next few sessions, and the next session is interesting one, clinical grand rounds, enhancing excellence. To chair this session, may I invite Dr. Aparna Jairam, founder and director, Asavli Dr. Aparna's Pathology Lab, Mumbai, India, chairman, Caho Diagnostic Centers. I also invite Dr. Bishnu Panigrahi, Group Head of Medical Strategy and Operations, Fortis Healthcare, New Delhi, India.
With them, I would like to invite the speakers, Rotarian Dr. J. Bala Venkata Subramanian, Senior Consultant Anesthesiologist and Academic Director, Department of Anesthesia and Perioperative Care, Ganga Medical Center and Hospital, Coimbatore, India. He would be speaking on the topic, perioperative patient safety, role of anesthesiologists. Also, I would like to invite Dr. Ashish Chaudhary, Managing Director, Akash Healthcare Super Speciality Hospital, New Delhi. He would be speaking on the topic redefining surgical patient experience.
Aparna ma'am, are you there? Okay.
Dr. Aparna, she's actually chairing another diagnostic session. She's on her way. Dr. Ashish Chaudhary, I would like to request you to come on stage, please. And I would request all the others to please settle down so that we can start the session at the earliest. Dr. Bishnu, sir, please start.
Okay. Hi, good afternoon, everyone. I think so. This is a very important session in the sense that this is what I have been practicing all my life as a anesthesiologist in critical care. And when you look at the perioperative patient safety, the role of anesthesiologist, importance of quality control for improving clinical outcomes, and redefining surgical patient experience. So with that, I'll ask the first speaker to speak on the perioperative patient safety role of anesthesiologists.
Thank you so much, sir. Pranams to everyone. And at the outset, I would like to extend my very sincere thanks on behalf of the Indian Society of Anesthesiologists, for which I have the current responsibility as the president, to thank Caho for creating a tsunami in healthcare in this country. I wanted to, all of us together, applaud Dr. Vijay Agarwal, Dr. Lalu Joseph and Caho team for this phenomenal contributions in creating an awareness and a platform to make sure we prevent the preventable deaths in whatever form it's possible. And thanks for giving this opportunity to speak on the perioperative safety, the role of anesthesiologist. And I'm also very happy that the Indian Society of Anesthesiologists have joined hands with Caho. And thank you to Dr. Lalu Joseph for spearheading, bringing in the book, The Essentials of Safe Anesthesia, which was released today, which is the first step towards patient safety, and all the stakeholders, including the paramedical staff, the anesthesia technicians, the anesthesia postgraduates, would have to go through this, which would create an awareness about patient safety in the perioperative period. And also very happy that we have several collaborative projects together, including environment sustainability in the operating room, the PCPNDT Act and its effect on anesthesiologists and perioperative outcome, and we look forward for future collaborations. Safety in the perioperative period is very crucial and important because a patient walks in for a tonsillectomy and without even having 1% clue that the parents will not be able to take this patient back home because they thought it's a simple tonsillectomy. And if it happens to be negative and we lose a patient who has come for a tonsillectomy, this is the biggest, I would say, even in this modern era,
an episode like this is the biggest catastrophe to humankind. And thank you so much for Caho for joining hands. It becomes important. Does protocols make the difference? Does systems make the difference? I personally feel both are important, but I think more important is every single healthcare provider should introspect and give the best to the environment in which they work. And for that, we need to introspect. When we are born, we are all born as equals, but human glory lies in ensuring that we do not die as equals. For all those who got the award today, there is a big sense of happiness because they've created something and they've accomplished something, and they are no more equals, they are one step ahead. And this is a slide which I wanted every single of us present here to introspect on this statement. We may be born in a middle-class family, but we can scale such heights in this lifetime that we can cause a revolution. We may be born to illiterate parents, but we can die as scholar of world repute. We have been considered a misfit during our childhood days, but we can become role models for the future generation. What we are and what we have been has no bearing on what we can be, and we can be what we choose to be. And this is exactly these kind of statements, when it is driven deep inside, then we will look for perfection and we will see medical errors, negligence never happens. And for doing all this, we need to set our core values. We need, all of us wanted to be successful, but success is all about being in the process of joyfully creating a life that reflects our highest values, our deepest beliefs, and greatest dreams. God created healthcare. He produced a human life and created a healthcare system to preserve life. So each one of us sitting here are part of a sacred mission of God. And our work should be our prayer, because everything that we experience, from the food to the cloth to the shelter, the comforts and the luxury that we enjoy, are all the rewards of the work we do. So we tell all of our anesthesia postgraduates that we revere our workplace, and our workplace should become our prayer. And it becomes very important and crucial that we take examples from our day-to-day life. I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore, a 650-bedded tertiary care referral center for trauma, orthopedics, and major reconstructive surgery. And I also bring to you greetings on behalf of Indian Society of Anesthesiologists, with 49,000 anesthesiologists present over 240 city branches across this country. And we have developed a protocol and a workshop, a simulation-based learning on the 6 common causes of perioperative morbidity and mortality in this country. And we have signed a MOU with 34 centers across this nation to create awareness among anesthesiologists on the common catastrophes that happen, which results in significant morbidity. We wish to collaborate with Caho on this, and we wanted to patent it and take this across the country to decrease the mortality and morbidity. I currently also serve as the secretary of the World Federation of Society of Anesthesiologists, which is a conglomeration of 150 member countries. And here again, our mission is to have universal access to safe anesthesia and to unite and empower anesthesiologists around the world to improve patient outcomes. This is a very important statement for each one of us. It's not the strongest of the species that survive, not the most intelligent, but the one most responsive to change. India was like this when we got independence. And now what has happened to this nation? It's got the largest sea link, the modern downtowns, putting Chandrayaan on moon. So the best way is to say yes to the technology. And in anesthesia, we embark on the journey of all these new gadgets which has come in, technology to empower an anesthesiologist to give anesthesia to critically ill patient and make them live. The ultrasound guided nerve blocks, the point of care ultrasound, the target controlled infusion, the workstations, the neuromonitoring, all has come to supplement and complement the skill sets of an anesthesiologist to give the best to their patient. And hence, ASA grade 4 or the critically ill patients go home today because of adopting the new technology. And the next thing we are embarking on is to make every single anesthesiologist as a preoperative physician. And to do that, they need to know a lot of medicine. We wanted them to be the single point of contact as a physician to do a proper preoperative assessment of the patient. And for this, we need to be extremely knowledgeable, and we teach all the young postgraduates to become extremely skillful, because when skill and knowledge joins together, there is clinical excellence. And along with this, if we keep on updating, we really move on to the next ladder, not only for anesthesiologists, but for every one of us here in whatever spectrum that we are working with. So along with this, we need to create youngsters who believe in what we do, and we need to engage in a lot of clinical audits and research. And I'm very happy that Caho has embarked in the journey of clinical research. It's also very crucial and vital to have the cross-pollination. We need to visit centers of excellence to see different practices that are being done in the perioperative care. But I come to the basics. I think it's very strong self-discipline we promote among our anesthesiologists, because until they sleep well and come to do a surgery, they can't even start an IV line properly. They make mishaps in intubations. So it's a dictum that all of us, to focus well, we need to have excellent quality of sleep. And we also preach on certain personal traits like phenomenal integrity to what you do. Because when you scrub for giving a spinal, just you only know whether you scrub for 3 minutes. So we need to integrate that integrity into every single one of us, that we need to be the same whether we are watched or whether we are not watched. And I wanted to share that when we do a lot of audits, we have found out that the compliance rate of even this wash is not adequate in several. So we need to keep on emphasizing all this. But we wanted to produce an India where every single individual will exceed his expectations by extremely being skillful, being extremely knowledgeable, and along with that, to have tremendous integrity to the system, the patient, and to be extremely honest and humble to achieve his excellence. We have defined the qualities of an ideal anesthesiologist, but we tell them that please begin with end in the mind. You see a patient and you want this patient to go home. And for that, when you do a proper pre-anesthetic evaluation, you play a game of anesthesia the day prior to the surgery, where you look at, you dream it, you see what kind of anesthesia I'm going to provide. So you're mentally played it before you physically do it next day. I think this is the biggest lesson that we wanted to teach everyone: where to start the venous access, what intubation I have to do, what gadgets that I have to keep ready. So you have to physically do that procedure, but you should have mentally worked on it the day prior. And this is what happens to all the peak performers. Vishwanath Anand, when he was the chess champion, he played his opponent several times the day prior mentally before doing it physically. So our performance will enhance if we do this mental model, and this would result in quality anesthesia, which is defined in 6 domains. It should be effective, equitable, timely, efficient, safe, and patient-centered. So we in our institution embarked on the journey, and anesthesiologists took up the role of perioperative physicians and in trauma resuscitations. We have been able, within seconds of arrival of a polytrauma patient, looked out by the anesthesiologist, point of care ultrasound done by anesthesiologist, resuscitation done by anesthesiologist. We don't wait for radiologists to come and do an ultrasound abdomen. If there is a splenic rupture, explorative laparotomy, the time they come in to take it inside the theater will be within minutes. On arrival, we make them ultrasound guided regional blocks, and we have been able to embark on this journey to provide such high quality site specific analgesia for even sick patients. I don't want to elaborate, but these are all patients who are so sick and they can't be given general, they can't be given spinal. So we use the technology of ultrasound guided site specific anesthesia. A patient who would have otherwise died undergoes a surgery with effortless ease. So adopting a technology, learning the skill and using the knowledge and the skill and the wisdom that is needed in every single patient is the one which would result in a great outcome. And we have learned informed consent and taking the patients into confidence is important. We embark on the journey of telling every single anesthesiologist the need to prevent surgical site infection. And it's a dictum now that we need to see the patient in the preoperative period, do a proper anesthetic assessment, understand all the comorbidities and the drugs that the patient is taking, decide on the pre-medication and the preemptive analgesia that you give, clear strategy, what I'm going to do in the intraoperative period, the kind of anesthesia,
Excuse me,
the
Dr. Bala,
hemodynamics that's
we are
introduced. Yeah. And a postoperative concerns, everything would be addressed, taking into care the multimodal analgesia. In a nutshell, every single patient who comes to us deserves the best because each one of us wanted the best in life. And when the patient gives his own life for us to take care, I think we need to contribute effortlessly and make sure that we achieve the status of being a best anesthesiologist by closing all the gaps that we have in terms of knowledge, skill, and protocols. And I'm sure we will be able to send the patients back home very safely. And I would wanted this endeavor to be taken care along with ISA and Cahocon together in the years to come. Thank you so much.
Thank you, Dr. Venkatraman.
Thank you, sir.
To summarize, I think so, you rightly mentioned, for any surgical patient, the role of anesthesiologist transcends three areas. Which you highlighted is the pre-op, peri-op, and the post-op. And the concept of the perioperative surgical home has just started now. And many hospitals in USA, Europe have started using it because they take care of the patient right from the time of admission till discharge. So they become the common thread for a patient and the relatives. So it's a complete teamwork. So that way they support the patient, the relatives, and it helps because in a hospital, there's a lot of time the patient and relatives don't know where to go. So this common thread is where the anesthesiology plays a great role. With that, I'll hand over to Dr. Aparna.
Yeah, so without a further ado, great simplified PPT, and thank you for sticking to the time, sir. Thank you so much. I am inviting Dr. Ashish Chaudhary for an interesting topic of redefining surgical patient experience. He's a managing director of Akash Healthcare, New Delhi. Over to you, doctor. Can we have the slide and the timer? Thank you so much.
Thank you so much for the kind introduction. Well, the clock is ticking, and summarizing my patient experience as a surgeon in the OR spanning more than 18 years in 12 minutes, it's a little difficult, but I'll just try to put the context and the growth path which we have seen apart from just learning the technique of operating a knee. So I'm a joint replacement surgeon specifically, and coming from a mere surgical procedure to actually getting a collaborative approach all these years. There has been so many learnings which I have summarized in few slides. And let me tell you, the first joint I did in 2010, and these 15 odd years, gradually I realized that numbers were increasing every year, but the fear factor and the patient problems, they were not ceasing to exist. Every time, I used to operate a single knee, patient never used to come back for the second knee because of the horrible, painful experience they had the last time. Although the x-rays were fine, the range of motion was good, and everything was fine according to radiology, laboratory, clinically, science-wise, but patient was somehow, they were not happy. That made me thinking, is there something which we are not fulfilling, or there is something additional have to be done? So put the context, I think I'll start with a story. One of my friend's father got operated for a brain tumor from the best surgical hand, great facility, best preoperative preparation. Flawless surgery went fine. Post-operative CT scan showed complete removal. But ultimately, as we speak, the patient is more or less confined to bed, hardly eating, cardiac functions have went down, multiple admissions because of medical issues, GI bleed, sepsis, and all those things. So ultimately, even despite having the best surgeon in hand and great facility, the outcomes are still questionable. So what many a times, just like any other specialty, we also look at a procedure like, for example, a knee replacement as a surgical procedure, but we forget to look at many other aspects which might be affecting the outcomes, the ultimate outcomes. Patient may not be happy with a great looking X-ray, but unless and until they can go back to the same, the activity or the expected outcomes, they usually feel disappointed at the end of the full recovery. So as a result, we thought there has to be a holistic approach to try and reach the expectation of the patient and reasonable outcomes, which we have envisaged even before the procedure. So whenever it comes to a TKR, a lot of my family friends, they come with their loved ones and they want me to operate. The first and foremost thing is that it has to be a safe and a successful procedure. Rest of the things, whether we are going to have a luxury room or a robotic procedure or some fancy post-operative patient-controlled anesthesia equipment or any other things, those come secondary. But ultimately, everybody wants a safe surgery procedure. And what I fear is, of course, X-ray is looking good, but patient is unhappy, chronic pain leading to a bad experience and sulking in all the years after the procedure. Sometimes robotic procedures can also go wrong. Though we committed a minimally invasive procedure before surgery, but the outcomes were very horrifying. And a lot of medical comorbidities pushing the patient for repeated admission, hyponatremia, hyperglycemia, chronic infections, deep infections, superficial infections, so many other things. So there are many factors, many variables which come into play when we are telling the patient about the surgery. These factors sometimes they crop up and affect. And one dissatisfied patient stops 100 other patients coming to us. So a usual typical patient journey starts from symptoms, going and visiting the doctor, getting the diagnosis made, and then going for the treatment plan. And if it is a surgical procedure, then from PSC till the post-operative ICU care or the HDU care, and then finally getting discharged and going for the rehab. But whenever this happens without a coordinated team or a plan in place, things can go wrong in any which way. So that's how, after going through multiple procedures and a lot of feedback from patient, we thought, let's have something which should, more or less cover all the factors. So we came up with a program which doesn't actually mean a speedy procedure. It just means we're trying to fill the gaps. First and foremost is the safety profile. How do we make sure that patient doesn't end up dying or getting another comorbidity which he or she was not destined for? And how can we make it more and more pleasurable and painless experience? How do we make sure that the procedure lasts a lifetime? And how do we make the patient go back on feet at the earliest? So these elements, of course, they fall into the Kaizen principle. And why I specifically chose this principle, because of all these factors. We realized that we were giving blood to almost every patient. So is there a way we can reduce the blood transfusions? So we brought in tranexamic acid, we avoided drains, putting up drains, and that gave us, and then tranexamic acid in the preoperative area. Then focusing on the diet, essential amino acid, curcumin came up very handy as a Ayurvedic component, but really helped patients recover faster, have better immunities. And of course, the most important part, anesthesia part, which of course every surgeon forgets to even consider worthy. But we realized that the pain was causing all the disability after the procedure, and we were not able to control it despite giving all the NSAIDs and opioids. And then came the rescue blocks, peripheral blocks, and that gave us a sigh of relief so that we can focus more on the rehab part and changing the physio protocol. And that's how we found that the experience starts to change. And we created a dedicated recovery unit rather than sending the patients to ICU with all the ventilated patients. It was a better looking and a more friendly environment where patient recovery was much faster. A loss reduction started to happen. And then going from a muscle cutting to a muscle sparing approach, from, and bilaterals, of course, gradually came down depending on the comorbidities. And then the robotics and technology were adopted very slowly so that ultimately if the functional outcome is not getting impacted or improved, we don't usually adopt the technology. And of course, from the implants perspective, we found that Indian made implants also made a lot of difference, as if not superior, but they were equally performing as the Western counterparts. And then we followed all the ERAS protocols for getting the better outcomes. And this is where we landed in those 4,000 odd patients we did. The patients were getting ambulated in first 6 hours, and use of NSAIDs, significant reduction, almost by 70%, and average length of stay coming down from 5 days to 3.65 days, and in a unilateral and a bilateral from 5.6 to 4.2 days. And VAS scores were all-time low despite post-operative day 1 or 5. And all these patients, they're coming from various backgrounds. So the protocol was getting implemented everywhere. And despite having an implant, which of course designed outside, but made in India, and giving better results than the Western counterparts. So I strongly feel that SpeedKnee program gave us an opportunity to review our plan time and again, take the patient's feedback critically, and try and go back to the drawing board and see where we are going wrong, and try and plug all the gaps so that the overall patient outcomes become better. So I strongly feel that teamwork, innovation, and relentless pursuit of achieving better outcomes, actually that made all the difference. So here I would just leave with the last slide, where after 15 odd years of implementing these protocols, this is the difference we could see. And what matters to patient at the end of the day is how well they can go back to their normal lives, what they were not able to do earlier. Now they are able to do everything without pain. So these are some typical examples of varus knees which usually come to us. And this last patient which I have just met is an Indian football coach, and he was having significant disability. He wanted to go back to football. We were not, hopeful, but with all the physiotherapy and the teamwork, this is where he landed. And he every year he comes to India and shows how well he has returned to all the normal activity what he used to do once upon a time before the knee replacement. Thank you so much.
Thank you, Dr. Ashish. First of all, seeing is believing. Rather than having words, showing the video was the most thing which we will carry back. I remember those days when it used to be 1 week, and now we are looking at 2 to 3 days. And it's an amazing work. And secondly, for the time, you have really managed that very well and delivered the message effectively. Thank you so much. Thank you.
Request all to please join for a photograph.
Thank you, chairpersons and speakers.
The corner for the
Please
photograph.
join for the photograph.
Now, the most awaited debate of the evening.
Yeah. So today we have with us an exceptional panel of experts who will share the perspectives on whether accreditation is merely a 5-day exercise or a transformative process for healthcare organizations. May I invite our distinguished moderators, Dr. Clive Fernandez, Global Healthcare and Patient Safety Leader, and Dr. Narayan Pense, VP of Medical Strategy and Operations at Fortis Healthcare, to take us through the interesting debate, grand debate titled, Is Accreditation Just Wo Panch Din?
As the name suggests, Wo Panch Din, for the debates or the debaters for and against. For, I would like to invite Dr. Neil Sequeira, COO of Thane Cancer Hospital, and Dr. Anil Mulpur, Joint Director, Sri Satya Sai Institute of Higher Medical Sciences, Puttaparthi, India. And for the against, I would like to invite Dr. Sanjeev Singh, Medical Director, Amrita Hospital, Faridabad, and Dr. Parag Rindani, CEO and Senior Vice President, Wokhard Hospitals Group. Let the debate begin.
गुड इवनिंग। वो गुलाब जामुन फिरनी खाई थी, उसका क्या हुआ? यहाँ ऑलरेडी देखो इतना तू मैं हो रहा है कि फॉर इधर बैठो, अगेंस्ट इधर बैठो। एंड यस, so before we begin, I just was thinking, let's introduce the topic. And मेरा टैक्सी ड्राइवर मेरे को लेके आ रहा था एक बार, and I told him, भैया थोड़ा जल्दी चलाओ, लेट हो रहे हैं। He said, सर यहाँ जल्दी नहीं चला सकते, यहाँ कैमरा है। एंड वहां पे कैमरा था और लाइटें बहुत थी, बट ही सेड जल्दी नहीं चला सकते, कैमरा है। एंड देन एक अंधेरे से जंगल में जहां पे कुछ नहीं दिख रहा है, ही सेड यहाँ जल्दी चला सकते हैं, यहाँ कैमरा नहीं है। एंड आई सेड यहाँ मत जल्दी चला। एंड ही वेंट सेइंग यहाँ कैमरा नहीं है। टुडे वी आर टॉकिंग अबाउट वो 5 दिन, एंड आई वाज थिंकिंग अबाउट वो 360 दिन, because अगर 5 इधर है तो 360 है। So before we go to the debate and we introduce all our panelists and we start everything, I just wanted to ask the audience, do you believe accreditation में आजकल वाकई में वो 5 दिन phenomena है कि नहीं? Do you believe? All of you who say yes, raise your hand. Wait, there are 40% people who are saying yes. All of you who are saying no, raise your hand. Wow, so for and against is good. But there's still about 35% people who are saying, I don't know or I don't care. Is it so? So now this is more like a Shah Rukh Khan movie, kabhi haan, kabhi na, kabhi karenge, kabhi nahi karenge. So the best place to be in this debate is not on the left, not on the right. It is to be in the center. And we have got the CEOs and the COOs. And before we go forward, I'd like my co-moderator, Dr. Narayanan, also to say something.
Thank you and welcome to this debate. Actually, I don't know about the audience, but the moderators are very excited to listen to both sides. And like Clive has already taken a vote of hands, and it's kind of evenly split at the moment, but there are a lot of fence sitters, it's quite evident. And let's look forward to the debate and see how the results change. So looking forward to this interesting session along with all of you.
And we have only one ground rule. Hello, we have only one ground rule. No WhatsApp. You listen to her because some people have bought off the audience. ऐसा सुनने में आया है, correct? Some people have bought off the audience because it's going to be a voice vote. But I'm going to involve the audience from time to time also. So, without saying ado, we have a few ground rules so that people don't go on to WhatsApp and, are listening to us. Each of our speakers will begin, they'll talk for 2 or 3 minutes. So whoever is for gives their view for 2-3 minutes. Whoever doesn't want to agree with them gives their view for 2-3 minutes. Then we come in the middle and then we rebut. So that's how we are going to do it. So it's going to be a round robin. Cordial, because unfortunately, normally hospital में होता है ना, तो PPE साथ लेके घूमते हैं. Now I don't have an helmet, I don't have anything. It's going to be cordial. So is accreditation really accreditation, or is it just wo 5 din? So we have people, the people for our. I am totally confused. He's honestly confused because यही तो नहीं होना चाहिए. यही तो नहीं होना चाहिए because 360 दिन यही तो होता है.
क्लाइव, अभी आप हम पे छोड़ दो. अभी आप हम पे छोड़ दो.
अभी छोड़ नहीं सकते. Okay, so is accreditation?
It's between Parag and me now.
So now we take, you all are 4, right? So 4. Okay, so let's begin. So let's begin. Do you really believe accreditation is there for? Okay, wow. So accreditation, 2-3 minutes, and you start, give your views.
Okay, when you said whether it's 5 days or something, it reminds me of, I won't take her name. We were dating and we decided to go for before we decided to get married, we decided to go for a 5-day vacation. I'll use the word vacation. And I said, gosh, it was too much. And then I just ran away from there. Uh, for me, quality is a mindset. The company IBM once decided to test Japanese quality for some components which they wanted for their mainframe computers. So they ordered some components in Japan and they told them that we want a rejection rate of 3 pieces in 10,000. So that was the success rate they were looking for. They got the shipment, and along with the shipment, they got a note saying that we really don't understand why you want 3 parts to fail in the shipment of 10,000. But since you are the customer and you have asked for this, we'll give it to you. We have identified these 3 parts and we have packed them separately to ensure that they don't mix together. Accreditation, according to me, is a process which is tedious, which is a process which is overhinged on documentation. And in many cases, it does not actually reflect the true mindset of quality. The scholars at Stanford did a lot of research on quality, and they found that the largest important determinant of quality in service industry is an engaged employee, and they came up with a model called as the professional fulfillment model. Now, what does this say? In simple words, it says that when an individual feels professionally fulfilled, he will deliver quality irrespective of whether he's, being checked or not being checked. And this comes from 3 things. First is what they call as a culture of wellness, which begins from the leadership commitment that everybody in the organization has to be happy and has to be well. It also hinges on the support that you should have a mechanism where you recognize, you appreciate and all that. And most important, be fair. The second is what they talk about, efficiency of practice. And that is where all teams in the organization act as support to one another. And they are able to actually, do teamwork. And here it is. The organization has to be adequately staffed. I'm once again saying the organization has to be adequately staffed. The third one is developing personal resilience among professionals themselves, which includes financial security, safety for all these people. Rather than telling people what to do, so let me explain this in a very nice story. In China is very well known for jade sculptures. An American diplomat went to a museum in China and he saw a large, beautiful jade statue. He looked at that jade statue and he asked his colleague over there, who was Chinese, how do you think that this jade statue was made? It's so beautiful. He said, sir, there is a difference in the American approach and the Chinese approach. He says, you Americans look at life as an empty canvas and you start filling in different types of colors in it. You add this, you add this, you add this, you add this, you add this. And when something doesn't work out, you try to change it. He says, we look at things very differently. The sculptor who saw the statue, who saw the piece of ugly rock, which you would say is ugly, found it beautiful as it is. He started chipping small weaknesses, small parts, bit by bit by bit, and that is how it has become a beautiful statue. If you are able to actually tackle one weakness in the system, I think every day, every month, etc., you are automatically going to walk the path of the quality, irrespective of whether somebody checks you or no.
So Dr. Neil, that was good. I am more confused now because Dr. Neil was actually supposed to talk about कि quality 5 दिन होता है कि नहीं, पर ये तो sculpting में चले गए और
मैं ये बोल रहा हूँ सर, आपको 5 दिन भी करने की जरूरत नहीं है.
अच्छा, वो 5 दिन ये टॉपिक था, अगले साल ऑर्गेनाइजर्स प्लीज नोट करे, वो 0 दिन. Okay, so but in one line, do you believe accreditation, and we understand what you said, rightly said, and in an ideal world, that is what should happen. But yes or no answer. Do you believe as of today, I won't say everywhere, in most places, generally quality is practiced wo 5 din. Would you believe that? Yes or no?
Yes.
Wonderful. So before we go to Dr. Mulpur, I would like to hear from sir, please. Can you? Okay. Yes.
Organizing Secretary of Cahocon 2025, Dr. Sanjeev Singh.
There's a small star, you know, all this organizing secretary and all this does not go into the vote count in the end. वो बहुत छोटा star है.
So we were sitting there and I was trying to get a medical terminology done for what he spoke. And I could only get that it was a mindful bullshitting which was happening. Dr. Neil, this is completely not accepted. I was speaking to my head of department of neurology and wanted to understand when the husband and wife fight, next day, why does husband doesn't recollect anything and wife doesn't forget? And the head of department neurology said, the wife even remembers how many times you gave a vacant look, how many times you were yawning, how many times you were fiddling with the mobile. Husband doesn't remember anything. My head of department neurologist said, don't go there. It is XX amygdala complex ka chemical locha. I didn't realize that there'll be a bigger chemical locha here where they don't know where they belong to which, either for or against. And they are bullshitting. They are bullshitting about American and Chinese and God knows what kind of sculptor. So there was again a husband and wife. So the husband was not feeling well. Wife took him to see a doctor, and the doctor saw and said, "Do 4 things and he'll be okay. Don't give him dirty looks for 1 more year. He'll be okay. Don't ask for diamond and jewelry for next 1 year. He'll be okay." Lalu is an exception. Don't discuss mother-in-law for next 1 year. He'll be okay. Don't discuss mother-in-law, daughter-in-law serials which come at 9 p.m. with him. He'll be okay. So both of them were going back home. Husband asked, what did the doctor say? Wife said, you're not going to survive for long. This team is definitely not going to survive for long. And I'll give a clinical example also, because what they do, they say 0 din, accreditation, not even. So this is what they do. When a patient comes with an AQI index of 440 with a shortness of breath, they advise this team on the right hand side, they advise CBC. उनसे पूछो क्यों? क्योंकि आया है तो CBC तो करना ही चाहिए. Why LFT and KFT? कि सर ब्लड भेज रहे थे तो ये तो करा ही लिया. Why chest X-ray? सर इतना तो होनी चाहिए क्योंकि shortness of breath है, ऐसा नहीं कह दे कि कुछ नहीं हुआ. ABG, because it has come to a tertiary level hospital, you have to do something different. HRCT, sir, कुछ तो अलग करना चाहिए. ये तो secondary level के hospital भी करते हैं. The treatment which they advise is short acting. ये क्यों किया? Because sir, हमको पढ़ाया गया था salbutamol देने के लिए. फिर long acting, क्योंकि sir, asthma long भी चलती है. Then methylprednisolone, रामबाण, sir, पता नहीं क्या हो रहा है. So you give methylprednisolone. This is what they do. Terifylline, जिसकी absorption is 18% orally, but they give because I don't know why. Marcel, ये नाम इतना अच्छा Italian लगता है, Monteleuca, so they give. They give Allegra because they have no clue what is happening, so allergy to शायद होगी ही. Then since he is complaining so much, to keep him quiet, they give a chewable tablet called vitamin C. And then कुछ मालूम ही नहीं है, immunity booster, they give Bicosol. हमारा हॉस्पिटल, मेरा और पराग का हॉस्पिटल क्या करता है? They do evidence-based practice because it takes time, which is pulmonary function test, inhalational corticosteroid. So that's the difference, Dr. Mulpur and Dr. Neil. That is where they don't have a purpose. Ikigai क्या है? मालूम नहीं है, क्योंकि this was in Madrid. I was walking through. They were selling the bags. After a few times, I noticed when I turned back, there was nobody actually at that point of care. And this is what happens in a 0 day or a 5 day thing. So there is a hierarchy of evidence. And that is what Cochrane says, Dr. Mulpur and Dr. Neil. I don't know whether you know that. So it says that there is an experience base. So when I was doing a round in one of the hospitals, I went to the orthopedics ward. I looked at the drug chart. The orthopedics doctor gave meropenem. I asked him why. He said, 10 साल से 15 साल से देते आ रहे हैं. Then he gave piperacillin tazobactam. I asked him why. He says कि दो antibiotic तो देना चाहिए वरना recover नहीं होते. Then third drug was tramadol. I asked him why. He said बहुत pain होता है. I asked the patient, do you have pain? Patient said no. Fourth drug was injection ondansetron. I asked him why, because tramadol दिया है तो nausea होता है तो इसलिए दिया. I asked the patient, do you have nausea? Patient said no. Then fifth was 3 pints of normal sun and asked him why. जो भी आता है उसको infusion तो मिलता ही है. 1 decade back it has been declared as very abnormal normal saline. Sixth drug was MVI. I asked him why. बोलते हैं yellow colored fluid जब जाता है तो they feel powerful. What is that? This is Anil Molpur and Neil Sikula opinion within the evidence-based practice. So please pull up your socks, have some sense. Don't go for him. He'll do all kind of drama. Please vote for us. Thank you so much.
Abhi Dr. Mulpur has pulled up his socks and he's on the way. But you know, for some time I was really thinking, are we talking wo 5 din? Or are we talking of someone who's come with respiratory arrest, is in the, you cannot breathe, क्योंकि salbutamol, methylprednisolone, ये सब तो कहीं agenda में था भी नहीं. And अब now it's in the hands of the CVTS surgeon. So God help us, अब किधर जाने वाले हैं?
General Pavan Kapoor is the principal assessor. He is going to assess ROM and CQI. Camera, rolling, action. Confusion किस बात का है भैया? Neil and Anil, we are going to say just वो 5 दिन, बाकी सब बकवास. Now, my learned friend Sanjeev said husband and wife. I want to stick to Pati, Patni or O. Pati is healthcare organization, Patni is quality department, O is NABH assessor. This movie, like NABH book, at least has 2 versions. First one is NABH first edition, next one is NABH 6th edition. In the original movie plot is the Patni thinks there is something between Pati and O. Whereas in accreditation, O thinks there is nothing between Pati and Patni. There is no carriage, there is no miscarriage. Because it is arranged marriage. If that is not so, you all are from different hospitals. Why is there bakwas about prophylactic antibiotics? The 4th dose you give is no longer prophylaxis. I can tell you there is not a single exception. Every hospital has cefoperazone, sulbactam, promoters among clinicians. No one has any control. Medical records, clinical records, medical record audits. This confusion is eternal. Sound understanding is seen in 5% of people. Other naam ke waaste bakwas points, nursing and managerial audits, effectiveness of committees, job description, appraisals and privileging, employee satisfaction audits by a third party, bilkul bakwas. Then why are we sitting and Caho is taking this seriously? As the quality man of India who is sitting in the first row yesterday said, it all began with the unfortunate linking of CGHS tariffs to hospitals. That is it. You have ECHS tariffs, insurance payments according to tiers. Therefore, we are all sitting here. Otherwise, we have better things to do in our lives. And unfortunately, you have international representatives for whom I will say, apart from Tamil Nadu contingent, please learn Hindi. Otherwise, you will be left out. Because you won't understand what is that O 5 din. And accreditation post-COVID is now a pandemic for which there is no vaccine. Now, what is the typical cycle what we have? Sharma ji ek hospital chain ke de Dilwale Mard.
ग्रुप सीईओ बन गए, बढ़ रहा उनका हर दिन सर दर्द, दिन ब दिन फैलता जा रहा उनका हॉस्पिटल चेन। शर्मा जी तो दिखते हर वक्त बेचैन बेचैन। NABH, NABL, JCI, ISO, इनके फुल फॉर्म तो मालूम नहीं, लेकिन दिमाग चला के लिए एक डिसीजन बिल्कुल सही। अपॉइंट कर दिए थे एक ग्रुप क्वालिटी मैनेजर, दिखने में बड़ी खूबसूरत, हुआ तो क्या एकदम फ्रेशर। नाम भी बढ़िया, दिखने भी अति सुंदर, अमीलिया अमर। शी लुक्स एंड स्मेल्स लाइक जास्मिन फ्लावर। कंसल्टेंट को लगाया एनुअल बिल में 10% लेकर। एक्रेडिटेशन कंसल्टेंट का नाम था अभिनव डफर। अभिनव जी कॉलेज में थे आयुर्वेद के गुरु। अभिनव जी कॉलेज में थे आयुर्वेद के गुरु। अब एक्रेडिटेशन कंसल्टेंसी में नया इनिंग्स शुरू। हर हफ्ते में इधर या उधर होते रहता है हवाई जहाज में अक्सर सफर। अभिनव जी जिम में बनाए अच्छे बॉडी। टू कॉम्प्लीमेंट ऑल दैट एक छोटी सी दाढ़ी। अमीलिया पहनती थी एक पांव में पायल, करती थी पूरा हॉस्पिटल एम्प्लॉयज को दिलों का घायल। अमीलिया अमर और अभिनव डफर था जोड़ी बिल्कुल बेफिक्र। खुदा न करे और लग जाए किसी की नजर। दोनों का था एक्रेडिटेशन और क्वालिटी की कम खबर, लेकिन फैशन और स्टाइल में दोनों का एकदम बराबर। प्रिंसिपल एसेसर थे जनरल पवन कपूर। प्रिंसिपल एसेसर थे पवन कपूर। ही न्यू इन द ओपनिंग मीटिंग इटसेल्फ क्वालिटी इज वेरी वेरी पुअर। बना तो दिए IPL सेंचुरी NC के नंबर, लेकिन अभिनव और अमीलिया के स्वीट रिक्वेस्ट सुनकर MOM, FMS, HIC, ROM को कई बार पीस कर फाइनल NC नंबर बना दिया केवल 75। अंग्रेजी में ब्रीफ लेकिन हिंदी में चड्डी। लास्ट डे करने बैठे डीब्रीफिंग, खुल गया सबका चड्डी। ब्रीफ इस चड्डी, ब्रीफिंग चड्डी पहनाना, डीब्रीफिंग चड्डी उतरना। For censor board reasons, for censor board objections, I'm not putting any photographs. What was there after debriefing? COO पूछे, वो 5 दिन के बारे में बताइए अमीलिया। COO पूछे, वो 5 दिन के बारे में बताइए अमीलिया। अमीलिया अमर ने बात को उल्टा समझ लिया। तुरंत बिना सोच के एक ही लात मारी। वो 5 दिन बोलते ही she thought of whisper and stay free. वो 5 दिन pathology of accreditation and physiology of menstruation. Both are inevitable and painful. Thank God in the end is in close vicinity, end of assessment. Oh God, it will come again, reassessment. The time was very too short, as I have now. 75 non-conformities to sort out. But Abhinav Duffer was quite good at hand-holding the team and helping. Amelia was to go another hospital in the group for one more assessment.
We need to wind up.
Abhinav started singing, requesting her to stay back to address final report. Can I have the lights dim, please?
अभी न जाओ छोड़कर के दिल अभी भरा नहीं।
That was hand only.
न जाओ छोड़कर के दिल अभी भरा नहीं।
Sir, your time. Wind up, Dr. Milpur.
No, I had 14 minutes plus 6 minutes of mine, 20 minutes we are taking it. And I have the permission of Moderate तो बात
Totally,
करेंगे
I think,
भैया।
I think,
Throughout the
I think,
confusion अभी चल रहा है।
if we were in a Kavi Sammelan, hands off, sir would have won it fully, है ना? अभी तो मैं इधर आ जाऊं पहले तो, you know, because इधर ही पर्ची नहीं फटी है, नहीं तो कपूर सर से लेके ज्ञानी सर सबकी पर्ची फट चुकी है।
हाँ, अभी तो विजय अग्रवाल साहब की बारी है, 2 मिनट बैठिए।
But sir, in your next,
I will.
because you see now, I think Dr. Parag.
Many of you don't know that there is a Hindi version of Caho anthem. And this is Dr. Vijay Agarwal. In the short clip, you will also see Lalu Joseph in her youthful days. And at the end, you will see Parag Rindani as well. Lights down. That is Lalu.
अभी तुम एक ख्वाब हो, अभी पसे हिजाब हो, मैं छू के तुमको देख लूं,
Parag Rindani. Are we accredited or just decorated? All over the world, we are highly fragmented, loosely regulated. It is event rather than process. They have NABH or JCI for what? Insurance empanelment, foreign patients and brand image, not for internal reforms. British Medical Journal study says the outcomes, there is no difference between accredited and non-accredited hospitals. It is a superficial facade. In the very city where we are sitting, consumer redressal forums have pinned down many hospitals leading for privacy. I don't want to name them. It just shows it is just wo panch din. Patient safety is never a priority. 58% of nurses in Delhi who were interviewed, they said it is all bakwas.
I think now in the interest of time, no, because see, I think अच्छा है कि वो 5 दिन ही होता है accreditation.
नहीं, audit week है. This is menorrhagia. It was originally 5 दिन. Now there is audit week syndrome and a post accreditation. It is all theater. For the benefit of you, National School of Drama in Bangalore has now got special courses for acting for healthcare professionals. Accreditation has never led to better outcomes. And in the paucity of time, as I'm walking, just listen to this. Thank you.
So Dr. Mulpur, so it's difficult for moderators to stay neutral when it is so passionate, if I may say so, with briefs, debriefs, and etc. coming into play. But I'm sure Dr. Parag will do a forceful plea for Bopanch then.
One can only rebut with force when there is something to rebut. When there is nothing to rebut like Neil Anil have done, I don't think we need to get very scared. I put to you this proposal and like the vote to happen on this. Till there is a Cahoite in each and every accredited organization, accreditation is alive and acting every day. Yes or no? I can't hear you guys. Well, Dr. Mulpur, since you're my teacher on accreditation, I will only recall your words. Your words in 2008, 18th to 23rd January, when you taught us in Mumbai, in North Mumbai, you said, you must remember that accreditation has to be part of the DNA. Yesterday, Dr. Peter Lackman spoke about the 3 levels of accreditation. First, where you merely get the accreditation. The second, where you put in systems and processes. And the third one is where you actually co-produce product and service, and you're able to give the optimized outcome to the patient. Ladies and gentlemen, accreditation is like marriage. I guess the Neil Anil duo would like to believe that you only need to give flowers and peck your wife or your spouse on his or her cheek on the day of your wedding anniversary. I, for example, give my wife a hug every single day. Those of you who believe in the concept of love, even beyond marriage and days of marriage anniversaries, a big round of applause for Neil Anil, because they don't seem to comprehend this. And I think the most important thing is, today's generation of people have realized that they wouldn't like to put money anywhere if it's not adding value. To my mind, accreditation continues to add value day in and day out. every process that we improve. This is like every step you take, every move you make, I'm going to be watching you. You don't need any watching in this particular thing. People have understood AMR is being practiced on its own. Antibiotic receptor is looked on its own. People have stopped using teicoplanin and vancomycin for routine knee surgeries. And I think this is what, unlike Dr. Molpur, I would like to compliment Dr. Gyani for this, for bringing about this revolution in the country, where people are actually looking at things that are supposed to be looked, where a door to balloon time is done appropriately, irrespective of the day or time. One doesn't look at a door to balloon time or a door to thrombolysis time only in wo panch din. That, ladies and gentlemen, is practiced day in and day out. Because to my mind, accreditation has penetrated the DNA of the organization in its fullest form. And I think, frankly, that while you may still worry about the assessors and wo panch din and all like Neil and he love to do, I think that you've imbibed it well, which is why CAHO is a thriving organization. We are not saying the accreditors are bound to build capacity. Somebody else has to do it, and CAHO has done it very well. So if you believe that CAHO has done this well, a big round of applause for Dr. Vijay Agarwal, Lalu, and the GC, as well as all our patrons who are sitting here. Ladies and gentlemen, the expectation that it has to be the accreditation agency is going to lead you unto everything is wrong. That is what the myth here is in these two lovely people, both of whom are also my friends. Dr. Molpur, also a teacher. The misunderstanding which we have to clear, the misunderstanding is that actual quality begins after accreditation. And I think Dr. Gyani, I have my good friend Dr. Rana here, my own teacher, Colonel A.M. Ashley Kapoor, they've always said quality beyond accreditation. So till you believe that once the assessors are gone, and I guess that's what happened in these two gentlemen's offices and hospitals, because that's all they've seemed to have done. They've managed to pick out all the ugliness that they seem to have had with their assessors. And I hope Dr. Kapoor was not their assessor, because I know him to be a fair, what did he say? Peace ke 75. Peace ke pachdi hoti hai, sir. Peace ke 75 nahi hoti. And don't you dare, Dr. Clive, my good friend, talk to me about time. Ladies and gentlemen.
मतलब एक मॉडरेटर का इतना पर्ची आज तक कभी नहीं फटा. टू वालों ने फाड़ दिया, अब अगेंस्ट वाले फाड़ रहे हैं.
I said it with a lot of love and affection. Dr. Clive and I work in the same organization. Ladies and gentlemen, those of you who actually believe that accreditation is here for those 5 days only, I think all of you need to join Neil Anil in lining up to the neurology department of Amrita Institute of Medical Sciences, because that's when you might discover that you don't really need any neurology testing, because there wouldn't be a brain. It's a no-brainer. It's a no-brainer that accreditation has made its inroads into the psyche of people working in hospitals. They have managed to imbibe a culture of safety, a culture of healthcare quality within healthcare in India today. I will go back to the words of the ISCO president, as he said today. India has a lot to give to healthcare quality. It is no mean feat to ask such dignitaries to come down to India to talk about healthcare quality, because they believe that the milieu is now ripe. The people are now appropriately geared up, sensitized to get healthcare quality up and running. And those of you who believe that you can equate quality to a menstrual cycle, I think that's the worst form of misogyny. So ladies, don't forget, if somebody can belittle that, I think they can do anything. Don't forget to vote for us. Thank you.
The safest place to be after all of this. You know, and I've learned one thing. Whenever there is a vaad or whenever there is a vivad, हर सिक्के के 3 पहलू होते हैं, और वो बीच में रह के अभी पता चला. एक इनका साइड था, एक उनका साइड था, and then there is the real side. And you know, as we rightly say, quality is not a destination, it's a journey. So I agree that it is those 5 days. At the same time, I agree, it has to be continual. And so now, before we move forward, Doctor, you don't agree for 5 days? Wonderful. इसलिए आप लोगों के लिए एक स्पेशल सेशन रात को 8 बजे 3 dose of C3H5OH के बाद रखा गया है.
Incidentally, Dr. Clive heads quality in our hospital, and he knows that it's 365 days. So thank you very much, Dr. Clive.
So you will take some, yeah.
So thank you. Firstly, I think a lot of animated debates and points which were very well made by both for and against. I would think that it's a mixed house because different hospitals, healthcare organizations are at different points of maturity. For, for some, it may well be the case of wo panch din being wo panch din, while for many it may be wo panch din actually being the remaining 360 odd days also. I think it's something like Lord Ganesha making an appearance and staying at our homes for Ganesh Chaturthi, but staying always with us on a daily basis. So with that, I think we would come back to the audience and take a vote of, hands once again. So those of you who still feel that it's only wo panch din and nothing more, please raise your hands.
See, and this time there is no I don't know, I don't care. Either you're here or you're there. मैं भी थोड़ी कविता करने लग गया हूँ. Okay, so how many of you? And now you have to not look on the stage. Don't get swayed. Now, how many of you actually close your eyes? Don't look at your neighbor. आज अपनी अंतरात्मा को सुनो और एक बार सच निकलने दो. Because now I'm the moderator. How many of you actually believe that wo panch din exists today? Raise your hands.
That is exists on a daily basis.
On a daily basis. Wow, there are a lot of people who have mastered the art of whatever. And I didn't say anything. Okay, how many of you actually believe that it is wo 365 दिन quality and accreditation? Wait, सवाल तो खत्म होने दो. Because सवाल ये नहीं था कि होना चाहिए कि नहीं. जो कि आप लोगों ने हाथ खड़ा कर दिया. सवाल ये है कि वाकई में in our organizations everywhere is accreditation and quality taken seriously and practiced 365 by 24/7, comma, especially when accreditators and surveyors are not looking. How many of you believe? अब थोड़े कम हो गए देखो. Because one wise man often said, people never do what is expected. They only do what is inspected. तो जब भी हम रेड लाइट पे रुकते नहीं है ना और वो पांडु हमारा वो काटता रसीद, हम उसको गाली देते हैं. The red light was the quality, the police was the accreditation. हाँ, पर आप लोग आ जाओ, आप ही आ जाओ. So anyway, so I think it was a good debate.
Excellent. I think overall the impression that we at least not so moderate moderators get is that most of the people do believe that it's a 365 journey rather than it being only wo panch din. But thank you once again to all the panelists for this exciting debate. And okay, those of you who feel that Neil and Anil won the day, please raise your hands.
Yes.
Those of you who feel Sanjeev and Parag did their job well today and won.
अभी ऑप्शन सी भी है. आपको लगता है अभी धर्म संकट है और भाई कुछ ना बोलना है तो रेज योर हैंड.
How many of you think the moderators did a good job?
Okay, so the matter is settled once and for all. There are 99% hands raised for the moderator.
But on a serious note, thank you all of you, the panelists and the organizers.
Thank you, moderators and debaters. That was a wonderful debate. Like to please join for the photograph.
I'm sure this moderation is going to give us a hangover for the rest of the evening. Now for the next session, sir.
We now move on to the next session, learning from international accreditation organizations. To chair this session, may I invite Dr. Aarti Verma, Senior Vice President, Medical Quality, Max Healthcare, New Delhi, and Father Johnson Varpalli, Executive Director and CEO, Rajagiri Hospital.
For the speakers, I would like to invite Dr. Amina Malik, Consultant Advisor in the Medical Regulation at the National Health Regulatory Authority, NHRA of Bahrain, and Mr. Majid Zahoor, Global Director, Healthcare Sector, BSI. The topic would be ISO 101, and Mr. Cresimir Antonio Palisca, Group CEO, SVP, AACI America. The topic would be the Centers of Excellence Standards.
And we
The
have
speakers.
50 minutes for this session. Over to you, chairpersons.
We would be having timers at the end of each speech. So please carry on.
Again, good afternoon, all. Some 5-6 years back, in most of our conventions, conferences, we at the most hear about NABH or Quality Council of India. But then gradually, again after a few years, we started talking about JCI, ACHS, and then a lot of stuff. And now we started talking about NHRA, that's from Bahrain. And then ISO 7101 and AACI. So when we hear all these expressions, the question that comes up is, where are we, the all participants of Cajo conference? It is undoubtful that we are neither with any of these agencies. We are with the patient. We are with the caregiver. We are with the patient relatives. So the beauty of Cajo is that we are with the patient. So it is absolutely fine and enriching to listen to and learn from any accreditation agencies as long as they benefit our patients and they are more safe. Today we have 3 eminent speakers, Dr. Malik, Dr. Majid, and Dr. Paliska. And we have Dr. Arati Verma to moderate with me. So let's start. We are already late. Let's listen, Dr. Malik.
Good afternoon. I hope everybody can hear me. Right, so my name is Amna Malik. I'm a physician by training, and I am also the head of the accreditation in the Kingdom of Bahrain. I'm quite sure many of you are wondering, maybe you don't know where it is. It's a tiny little island, very close to Saudi Arabia. It might be a very small island, but it is a very mighty island. We have about 1.6 million people, and it's a mixed cohort of people. We have, many people, a lot of people that are expats, and then we have local Bahrainis, and then we have local Gulf Arabs that also come and live there. So we have a real mixture of population that lives in the Kingdom of Bahrain. The life expectancy is, in the 70s, and we have the usual problems with NCDs. Nothing spectacular there. I think that this is a world problem now. I work for the National Health Regulatory Authority. I'm an advisor to the CEO there, and I also am in charge of the accreditation program there. We implemented the accreditation program under a regulation that was a law that was passed in 2016. Our vision at our authority is to provide safe and high quality for health services. And most of our mission surrounds the regulation of healthcare licensing, not only for professionals and facilities, but also for medication and medical devices. This is basically just to give you sort of an overview of what we do. We are quite a busy regulatory authority. It is, I think, the only regulatory authority in the world that has inspection under the same umbrella as accreditation. So you can imagine the challenges that we had to implement this program. And when we look at our goals in general, the goal that we were trying to attain was for safe and trusted health services was through accreditation. And the goal of regulation and accountable health facilities impacted our licensing function. This is just to give you a very busy slide about what has happened in the past couple of years. Since 2015, we have put down and set down the structure and the function of accreditation and how we were going to implement it. Right at the inception, I was head of the implementation of this program. So we have really started from scratch. We had absolutely no accreditation in place. We did have inspection, but it was a very technical inspection, which had a lot of sort of technicalities of healthcare and how to run a healthcare facility in Bahrain. But other than that, we had nothing for accreditation. So this is just a slide to sort of give you some kind of flavor of what has happened in the past couple of years. And just to give you sort of an update of where we are at the moment, we have attained 87% of all of our hospitals have been accredited in Bahrain. So most of our private facilities have been accredited. We have only 2 facilities pending in the government sector. But we are at almost 100% of accredited facilities for the hospitals. And for the primary healthcare facilities, which is where most of the population receives their care from, they are also almost at 100%. What we are working towards now is the private medical centers, which we have quite a lot of. In terms of what we do, we provide accreditation. We have a robust set of standards that have been accredited by ISQA. We have a set of standards for hospitals, and we have a set of standards for medical centers. I have probably 55 surveyors that we self-train and sustain. Our training program is also accredited by ISQA. So we have a pretty robust community of accreditation. And we do have a lot of checkpoints in between accreditation, so we don't just leave the facilities alone. In terms of the awards that we give the facilities, we give them, it is a tiered award system where it is from diamond, platinum, gold, right down to silver. We only allow you up to about 75% compliance with our standards, beyond which we will reassess you. This is what we also have introduced. We have introduced a Center of Excellence Awards where we have identified 3 areas. Because we're a young country with accreditation that has just started, we have opened the opportunity for facilities to highlight and showcase different areas of accreditation that they have done very well in. So the 3 areas that we do look at as centers of excellence are infection control, quality, and governance. What has accreditation done for us? So as you can imagine, we have, accreditation is sort of a good sort of foundation for us to start with at the moment, because we are implementing a socialized health insurance in the next couple of months. In addition to that, we have never had accountability in terms of any kind of standards or anything like that. So this is the first time that we have had this accreditation program that has come into place. And this has allowed us to capture a lot of information. And what we do with the information is where we see the value. So just to give you a flavor of what has happened, when we look at non-compliance, every non-compliance, so by that I mean anything that is partially met or not met or even met, because we have a fully met criteria as well. Anything that is below a fully met criteria actually feeds into our regulatory activities. So when we look and we analyze accreditation every year we're subject to a cabinet report that which we present to the government of Bahrain, and we feed them with the information of what we have found through accreditation. So just to give you an example, in hospitals, just in the last year alone, we realized that we do have gaps in dispensing, in the medication risk management plans, and also we have gaps in the facilities management and facility safety. And we can sort of drill down particularly to the, down to the standard of what is actually missing and what as regulators we have to put in place to either help facilities or to train facilities to do better in that. So we do this both for hospitals and for medical centers. One of the issues that we have found is medical centers is the sort of management of medical devices, because as you know, I think it's a prevalent problem all over the world. Medical devices, lifespan, longevity, the capability of that medical device to perform at optimum, all those issues come into play. And so we are looking at those kind of issues to see how facilities are meeting that criteria. In terms of just the updates of what we are doing, we do give recommendations. So we don't call them non-conformities. We actually call them recommendations for improvement. And we tier our recommendations from high, medium, and low. So when you look at as a whole, our accrediting body, for hospitals, we have largely met all the recommendations we have given. So 94% of all hospitals have actually met the recommendations we have given them. Similarly, in centers, in medical centers, 91% of all centers have actually met our recommendations. So in terms of value for the Kingdom of Bahrain, the value comes through that, for them attaining that recommendation and sort of not being non-compliant to either regulation or to the best practice standards that we have. In terms of overall reconciliation of non-compliance by year 4, because we only go once every 4 years, but every single year we have a check-in, a quality improvement check-in with every single facility that we have accredited. And this quality improvement check-in is free of charge. We don't charge for it, but we do go in as a team and we assess, we sit down with their team and we assess and how they have met the recommendations we gave. In terms of that, the centers are by year 4, 100% of all the recommendations have been fully met. And in hospitals, we found 94%. And the reason for this is because hospitals have a hard time attracting the right talent. So most of our issues in hospitals comes from one law that we have, that every department in a hospital should be headed by a consultant of that specialty. So because we're such a small country, it's difficult to attract that kind of talent. So these are the gaps that we have. What we started in the past year is collecting KPIs through accreditation, and this has become sort of the bread and butter of the foundation that we're going to lay for benchmarking. I don't know if you know, but in the Gulf, in the GCC, there are no databases for benchmarking of any of the data that we collect. So we are working towards building that database for Bahrain. And at the moment, we are in the process of meeting with the other GCC countries. I'm on the panel for the Saudi patient safety, and we are figuring out how we're going to work together to get this data repository and work on a benchmarking criteria. Because at the end of the day, I mean, it's all well and good if we have benchmarking data from Australia or from the NHSN in the United States. But at the end of the day, it doesn't properly reflect our region. So we are looking to building our own database. And this has come through accreditation. We're able to pick up these KPIs. We pick them up through accreditation. We have specialized training for this KPI sort of information we pick up, and we populate them into a dashboard. And this is a real-time dashboard that the Supreme Council of Health also has access to, and they can make real-time change even when the insurance is implemented. So these are sort of our newer areas that we're working on. And so in terms of the achievements we have had in the past year, we have accredited our surveyor training program. And now we have a robust, sustainable training program. We train our own surveyors. We provide free training for all facilities. We do not encourage a consultant coming on board. We give them bespoke training. I have a small team However, I have a big team of surveyors, and the surveyors are involved in the training as well. So we provide once a week, every single week, online training for the facilities. Anyone is free to attend. And then in addition to that, we have kind of bespoke training. As a consultant, I will go out to a facility and I will help them with any questions or anything they might have. We also give a lot of information through the KPI dashboard, and that KPI dashboard feeds into a lot of the regulation that we pass as a regulatory body. So that's it. Thank you so much for listening.
Thank you, Dr. Amina.
Thank you.
Your model is certainly brilliant. And I really enjoyed hearing about the partnership between the regulator and the accreditation. Also, your Centers of Excellence program is extremely interesting for other accrediting agencies to also emulate. So thank you. That was a brilliant presentation. We now welcome Mr. Majid Zahoor, who's the Global Director, Healthcare Sector of BSI, to share his thoughts on the accreditation systems.
Hi, everybody. My name is Majid Zahoor. I'm the Global Director at British Standards Institute. So talking about certification and accreditation is an interesting topic. It's particularly an interesting topic to follow after the Neil and Neil show, because I'm sure most of you really enjoyed that, as I did. So look, I just want to talk about the standard that we are sort of actively working on, ISO 7101. But before I do that, I really want to thank the team at Caho, as well as AV Hospital and Mehta Hospital Group, because they participated in a pilot program to kind of showcase the standard and the value of and the benefits of the standard. So I'll just take you briefly through this. But first, a little bit of housekeeping, because most people might not know much about the British Standards Institute. So we were founded in 1901. So we've been around a long time. We're old, but we're young at heart. We have 84,000 clients around the world. In 2022, we had our biggest delegation of training. So we provide training services around standards and understanding quality frameworks and how you can implement them. So we do a lot of work in that space, and that's been quite prominent for our organization. We have over 5,500 colleagues around the world that champion the cause of quality and other initiatives. We have a presence in 193 countries with 76 offices in 76 countries. And most importantly, for this audience today, we have over 10,000 healthcare clients. So you kind of understand healthcare, the challenges and complexities you're all facing in terms of delivery, resources, funding, complexity of insurers, complexity of private versus public, complexity around delivering consistent service, and how we might be able to support. And we work much like the team at Caho with over 12,000 experts from around the world on quality and patient safety initiatives. So our engagement, because we're a global organization, we work with various parties and we try and incorporate that journey of building a standard or working through what is essentially a framework that will be beneficial for the healthcare sector by engaging with suppliers, by engaging with providers. So there's, you guys in the room, a lot of you provide direct healthcare services. Some of you are obviously in the regulator bucket. So you might be working with regulators around defining regulation. We also work with funders. Quite often funders can be insurance companies or families, or broader than that, the other streams or revenues through which people fund their healthcare services. So it's about bringing that entire ecosystem together, understanding the challenges and building frameworks that will be not only functional, but sustainable longer term. So ISO 7101 was created and published in October 2023. The standard was a culmination of an effort by over 24 countries represented, more than 40 global experts in healthcare. So these are clinicians that were involved in developing the framework, and key stakeholders like UN and WHO were involved in that process, and over 40 national standards bodies worked across developing the standard. So what does that mean for you as individuals that might be looking or wanting to understand more about the standard? Is it was built by the ecosystem. It was built by healthcare clinicians for healthcare settings. So it's not a bunch of academics sitting around a room and deciding what's right, but actually it was designed by the sector. And in fact, we had Dr. Lalu and Dr. Anuradha Pichamani that were involved from, Caho in helping build the standard. And we had, wonderful engagement from the team at ISQA. We had Dr. Shin Ushiro, as well as Dr. Peter Lackman that were involved in helping support the development of this framework. The most important part, because it was a global framework and ISO represents, not countries around the world, it was important that we built a framework that was flexible enough to work with most healthcare systems, but also had the opportunity to work in small organizations as well as be able to scale up to large, complex corporate style setup healthcare providers. The biggest principle in the framework, which we sort of touched on earlier, and our Master of Ceremony today highlighted that, was it is about 365 days. So how do you build that culture of quality, build that culture of continuous improvement in healthcare providers? And how do we support that long term? So I think that is at the core of the standard. That is the core principle that we try and follow through this framework. Okay, so in terms of the support that the framework is designed for and where will it really address key issues and challenges? One of the focuses on ISO 7101 is around workforce. So this is around how do you help support the workload, better planning, and support the education and literacy of healthcare workers to ensure that they are, encouraged but also empowered to do the roles much more effectively. So that will help with workforce shortages and burnout. Care quality and patient safety. So there's a huge focus around standardizing processes to help minimize errors and to create consistency across the organization. So that is a core focus of the standard. Technology integration is another component. Obviously, we're all seeing the emergence of AI in healthcare. We're seeing emergence of robotics. So the standard emphasizes the focus of healthcare providers to think about what is the right way to integrate that technology into their services? How do you encourage the engagement from service users as well as clinicians to kind of have this discussion openly to see what the value and benefits of these integrations might be for the healthcare systems and how we can support effective integration. Rising cost obviously is a big challenge, and so there is a big focus on how do you create efficiency, how do you reduce waste, and how do you improve the overall performance of the organization. Data security and privacy, that's another challenge that we have seen in healthcare. In fact, healthcare organizations, I'm sure most of you know, are the most hacked around the world. So how you secure your data, how you protect that data is important, and the standard plays a critical role in defining some parameters around that and helping you become much more sustainable around that. And lastly, but not leastly, most of you work in healthcare systems which have some level of regulation. And the idea behind ISO 7101 is we didn't want to supersede or we didn't want to say this is a better way of doing things. We actually want it to be a complementary framework into which you can integrate your regulatory requirements. So the framework provides a lot of flexibility around that so that national or international regulatory requirements are met. So at the heart of the standard is obviously quality of healthcare. And what it's designed to do is help deliver safe, effective, efficient, people-centered, timely, and equitable healthcare. And I think those principles are very simple. They are core to any good healthcare service provider. And it's about ensuring that you have a robust system in order to enable you to deliver that. And how it works essentially is what we call the PDSA cycle. So the plan, do, study, and act. So the cycle essentially is a continuous improvement framework. And it's outside of that framework essentially is designed people-centered care, timely, safe, equitable, efficient, and effective care. So I think the idea behind is these elements, if you continue to do them in your organization in a systematic way, will enable you to deliver better outcomes, but also help improve and enhance the performance of the organization. So this is a continuing cycle. Once you do this once, the idea is you repeat this. At the core, you will see is leadership. And we enhance this for a reason, because leadership is at the essence of every successful implementation. We understand that organizational leaders or organizational executives need to make decisions around quality. They need to showcase that they are bought into the principles and values. Otherwise, successful implementation is quite often challenging. It does happen at the grassroots level, but without leadership buy-in, it's very hard to implement these frameworks across the organization. So, I mean, I guess the journey that we want to just show, I call this standardize, harmonize, optimize, and then accelerate. So standardizing is around helping you as an organization come up with a framework that works for your organization. That's what ISO 7101 is designed to do. It is not a framework that dictates how you should do things. It is about your organizational size and scale and what is right for your organization. So you design a standardized process around your organization. Then you harmonize, which is bringing in the right departments and functions within your healthcare provider, within your healthcare setting into that standardized process flow. And then based on that, you're able to identify areas where might be opportunities to improve or drive performance outcomes or enhance delivery. And once you do that, you're obviously optimizing. So that helps you really accelerate, which is what most people want to do, is be able to grow their healthcare service providing capability to enhance the quality of care they deliver, but also to grow their organization. And inevitably, if you do that and follow the methodology, you should be able to accelerate growth. Just finally, conscious of time, and we're running behind time. If you have any specific questions or anything that you guys want to reach out to us about, specifically about ISO 7101, please reach out to our head of healthcare, Prashant. He's around here as well, and we've got a booth outside, so please feel free to do that. I talked initially about the 2 case studies that we're doing with AB Hospital and Meta Group Hospitals. We have those case studies published now, so the interim data is out. The benefit of that obviously is, to kind of complement that story that Neil and Anil were talking about, evidence. So we decided that the best way to prove that the framework works, the best way to showcase that the framework works is by giving evidence. So those case studies obviously provide evidence of the implementation, the learnings that those hospitals have taken away, and then the benefits they've got by implementing this framework. So I encourage you to come and visit our booth, scan the QR code, get the case studies, and then, obviously you can learn from your peers the benefits that they've seen from implementation and the benefits they've seen from taking this framework into the organization. Thank you.
Thank you, Mr. Zahu. I think it's a very interesting step of getting the ISO very specific to healthcare quality. Your presentation was very useful to a lot of us, and we are going to look into details for this. Thank you so much. So we welcome our next speaker, Mr. Paliska. Thank you. Mr. Paliska heads the AACI group, which is the American Accreditation Council.
Good afternoon, everybody. Thank you, Caho, to be here. I think you did a great job. So my session is going to be related to the clinical excellence certification, or what's beyond the accreditation as we know. So just a couple of words about the ACI. We are American Accreditation Commission International, and we are based in, our home is in Hendersonville, North Carolina. It's a small town, so we like to call ourselves small town boys. And we believe that we are one of the world's most experienced accreditation body, not because we are out there for a long time, but because we are old. We have more than a century of experience combined. So our mission is ruling risks and saving lives. So our concept is wrapped around the risks. So everything we do, risk is in focus of. I think there is something wrong with time over there, but you're gonna make it fixed. And we have a vision that says that we are trying to mitigate of human error in healthcare. We used to have a vision that was the world without the medical errors. But then we have realized that we will never accomplish or achieve that goal and vision. So we have changed into the mitigation of human error in healthcare. So our presence worldwide is, I'm not going to read the countries, so we are well presented in many, many countries worldwide. So what we do is basically, our core business is in the accreditation services, but I'm not here to present accreditation business today. I did it last year. My job today is to initiate the discussion about what's next, what's behind the accreditation process. So there is a 3-year cycle that we all know, but what we do not discuss about is how many accreditation cycles do you need to complete to become excellent? I think that's a philosophical question. You know, in ancient Greece, philosophers pondered that a similar dilemma. They asked, when does a man become bald? Is he bald after losing 1 hair, 2, 3? That's the same with the accreditation. So we don't know when exactly you become excellent organization. There are some hospitals in the United States being accredited for 70 years. Now, do the math. How many accreditation cycles is that? A lot. Is that enough to be considered excellent? So our concept is around that no 2 hospitals are the same. So you cannot have the same approach all over the market, because every hospital is just unique. Our standards, including the clinical excellence standards, are not prescriptive. So we are not telling you what to do. We are asking you, how do you demonstrate the clinical excellence, the patient safety, and the quality of healthcare? I don't think that's me. So we have, considering that approach, we have developed different clinical excellence certification programs. The main requirement for applying for the certification is to be accredited. So we consider accreditation as the starting point on the excellence journey. Having said that is that we have developed the different clinical excellence programs and standards. For instance, we do have the endoscopy clinical excellence certification, maternity, oncology, acute stroke, and something that is quite recent, that is medical lab content certification. I'm not gonna, waste your time with this. So what we want to achieve with the clinical excellence program is to achieve and to exceed the expectations of the customers, and of course increase the level of patient safety and culture. The main concept is decision of which standard to develop is primarily guided by the potential risk to patient safety. So if you think a little bit about our standards, you will come to the conclusion that all our clinical excellence standards are closely related to the risk involved. Endoscopy, one of the most risky procedures in medicine today. maternity, oncology, and stroke. So we believe that on that journey, there is a step beyond accreditation. So the clinical excellence certification, I'm going to give you one example of our standards. For instance, the oncology standard that has been recently published and launched as a program. We have the oncology standard that is covering, obviously, oncology services. So, for instance, the standard is developed receiving the feedback from the hospitals providing the oncology services. They said, well, the accreditation is good, but there is something missing. We don't get from the accreditation what we need in order to improve our quality of service and excellence. So we have developed the excellence certification program for oncology. The standard has 79 standards or requirements that are divided in 7 different chapters. One more piece of information for those who are not aware of what we are doing. We have also launched the e-trust. This is a digital safety in healthcare, and the purpose is to certify the websites that provide medical content to ensure ethical, accurate, medically relevant, and patient-safe digital information. You wouldn't believe if I tell you that a lot of hospitals that we have accredited are providing misleading or inaccurate information on their websites. This gave us an idea to introduce the program that is focused on accuracy of the medical content provided on the web. And you wouldn't believe I tell you that 99% of the website providing medical content are very questionable regarding the information they are providing. So providing the accurate medical information is about patient safety. So what we want to achieve with this clinical excellence certification, we want to go beyond the accreditation process. We want to unify approach worldwide, and in order to have the global benchmarking in the different specialties, I think this is the right way to combine and collect data from different countries, regions, and hospitals. And then, based on that information collected, decide what's the next step and where we want to be with the clinical excellence program, which is the next certification we want to develop in order to achieve and increase safety culture and patient safety. And the future development of our standards and or programs will depend on you, on your feedback and your needs. And we are here to accommodate your needs, and we are here to support you and help you. Thank you very much, and have a nice evening.
Thank you. Thank you, Mr. Paliska. I have had the good opportunity of reviewing your standards because 3 of our hospitals in the Max Group have gone in for AACI accreditation. And I must compliment you. There are many, many good practices in your standards and lots of learnings there, and wish you success in your journey in this part of the world. So,
Thank you so much.
we would open the house in the interest of time. We can take a few questions for our esteemed speakers. Do take advantage of their presence here. If anybody has any questions to ask, please go ahead. So I have a question for you. All right. Mic may please be given to the audience.
I missed your name, so the last speaker, man. Yeah, question to you. You mentioned that my name is Dr. Subiraj. I work as a surgeon in Delhi. My name is Dr. Subiraj. I'm a surgeon as well as an accreditation, with NABH. I'm an assessor. I listened with interest to your presentation about culture-specific practice, the AACI. I assume it's a differentiator from the other accreditation systems.
Well, I didn't mention any other accreditation.
You didn't mention, but you alluded to it. It's sort of indirectly. I gathered that maybe. So maybe could you elaborate on that bit because that's interesting because that's more real time that a hospital accept its, I would say its limitations and work within that to improve it. Would you like to see how your system supports that? I listened to you last year in Kolkata too. You told the same thing. So I'm wondering how that in real time could help.
Well, we see this accreditation process as a journey, okay? So it's a journey. So you reach the point where you feel that there is no added value that you can put in the improvement cycle, okay? So you feel that there is something missing there and you want to move forward and offer something that is new, that is different, but not go outside of the accreditation framework. So you want to keep what is good and what is beneficial from the accreditation program, but in certain areas, you want to move on. That's why we have developed specific risk-related programs. So because if you take a look, all of these 5 programs are risk-related. Probably the higher risk involved than in other areas. So we feel, and this is what we got as a feedback from our clients, they say to us, we want to move on. We know we are good, but we think that we can do better in certain areas. And then we ask them, what do you think and which direction you want to go? They said, well, we think we got a good oncology, but we don't have the specific criteria in order to fulfill them and to know that we are doing well or good or excellent. This is how we see this certification program, like a step move forward.
Thank you.
Thank you. Thank you for that. So, Dr. Malik, is your accreditation, the standards are aligned with the ISQA standards?
So can you hear me? Yeah. So just to speak about culture, our standards were made by Bahrain for Bahrainis. So they're extremely cultural specific. And to answer your question, yes, all of our standards are ISQA accredited. And in addition to that, we have made the standards so that they are in the context of the Arabic lifestyle. We've respected the Sharia law. We've respected every legal stipulation and have included it into standards.
Thank
but
you.
It's very specific, yeah.
Thank you. Any other questions? One more question we can have from the audience.
I was just going to touch on that same cultural question you had. And I think culture is quite an important part of service delivery in most parts of the world now. And I think the beauty of a framework like ISO structure is it gives you the skeleton and you determine as an organization what is right and what is fit for purpose for you, but also in the context of service delivery, right? So if you're delivering services in the Middle East, nothing dictates that you as an organization can't define those parameters that are culturally sensitive to your country or your region. Similarly, if you're operating in India and you have particular things that you want to incorporate in terms of family, in terms of how you do care delivery in a broader context of community and people's beliefs and values incorporated into service delivery. If it's important to your organization, you can define that. So we're not coming to assess have you done this tick box? We're saying, what have you defined as the parameter for your organization? And then how do we help you improve that moving forward? Because that's important to you. It's not, a fixed point. And, kind of elaborating on that to build your own journey as an organization. And therefore you can continue to build on that.
As a continuation of that, you had an interesting slide on burnout. How do you address that with workflow with burnout. You had a slide on burnout.
Yeah, so I think the burnout is probably, not something that all of us are not aware of already, because, through COVID-19, we saw the healthcare ecosystems were in enormous pressure. So what we have done is we've went out to the market, a lot of healthcare providers, but also other sectors, and we can share those surveys. And we sort of saw what the churn rates are in organizations, or why people are leaving those kind of organizations. And healthcare was one of the top. And a large part of that was, mental fatigue, emotional fatigue. A lot of it was just, physically draining work. And I think people, it is you guys operate in a very tough ecosystem, and it is always under enormous pressure. So I think, that's how we went out and we got that data. And then, so we looked at what we can do to encourage healthcare organizations to be more engaging with their employees, to have more, open discussions around, is there flexibility an issue? Is, mental health sessions an issue? I think one of the teams that we're working with at AV Hospital, they found that, offering yoga sessions was one thing that their team wanted to really do. So they kind of incorporated those practices to kind of help engage employees more, engage the workforce more, to kind of keep them more happier, more outside of work environment, involved in activities that could keep them, mentally and physically happy.
So thank you very much, Dr. Malik, Dr. Zahoor, Mr. Zahoor and Mr. Paliska, for bringing in such interesting global perspectives onto the doorstep of Cahocon. I'm sure this would be a very enriching experience for all of us who have listened to you. Thank you so much. We conclude the session here. Thank you, Father. Thank you.
Thank you so much, the chairpersons and speakers, for this program. Kindly join for the photograph near the Cahocon logo. So now we go on to the launch pad, the launching of Sustainable Event Certification of Caho. And I would like to invite Dr. Karan Thakur, Ms. Kirti D'Souza, Dr. Nareen Sehgal, Mr. Satish Kapoor, Mr. Palaniyappan for doing the honors. The 2025 Sustainable Event Certification soft launch of SEC, Caho's assessment on sustainable event. This is a Caho CAPS initiative. And it is an event certification which took into consideration the environmental impact, social responsibility, and economic viability of the entire process. The event cycle, life cycle as they call it, from preparation to certification. And there have been several steps towards it, starting with the pre-self-assessment, and then activities engaging the participants and creating a lively atmosphere, and the evaluation and follow-up success. I would like the team to come on stage to do the honors. I would like to call upon Ms. Kirti to say a few words about this launch.
Good evening, everyone. The launch of the Sustainable Event Certification is basically a motto of Caho to encourage events like this to become more sustainable. So all of us aspire events like this to become sustainable, but we do not know what are the steps to follow, how much have we been able to achieve, and where do we stand. This event certification program is through an app developed, and internally we have gone through a few rounds, and today we had a round table also to seek comments, criticism, so that we could incorporate the whole thing into the process. We had very value-adding suggestions coming from Dr. Raj, Jeena Sharma, Anil Juari sir, and our Sustainability Forum, Dr. Karan, and we have Dr. Naren and Mr. Satish from Apollo, who have implemented this already in their hospital during the pre-cons. We had a pre-con in the month of March, and we also had one yesterday. So it was like a trial, and it is very much appreciated. So this is not limited to hospital. It can go to any event, and shortly we will be circulating it across. And so y'all can do a self-assessment, know where you are at the planning stage of the event. During the event, you can self-declare that we are attempting towards this. Post-event, you can put the evidences and then say where you are and what level you have achieved. So we are looking towards the authentication of what has happened through a back-end validation or maybe surprise audits too. So thank you very much to the leadership of Caho for supporting in launch of this app called Sustainable Event Certification. And thanks for the support that has been extended by the whole team.
Thank you so much. Kindly join for the photograph at the Caho logo corner. Well, hand over to the next MCs for the evening. Thank you very much. Please enjoy.
Good evening, ladies and gentlemen. I'm Dr. Anil Kumar.
Good evening. This is Anusha here.
We'll be moderating for the next 2 hours and comparing for various sessions. Now we'll start with session number 8, which is going to be for 45 minutes. It's going to be on medical travel, opportunities and challenges. Would like to invite the distinguished moderator, Dr. Deepak Saxena, Director, Indian Institute of Public Health, Gandhinagar, India.
And the next moderator will be Dr. Gaurav Agarwal, Vice President, Operations and Unit Head, Max Super Specialty Hospital, Vaishali.
And the esteemed faculty are Commandant Pankaj Mishra, ODS Rapid Response Cell, Dr. Palok Gupta, Center for WTO Studies, Ministry of Commerce, Dr. M.I. Sahadullah, Founder, Chairman, and Managing Director, KIMS Healthcare Management Limited, India.
And other faculties were Dr. Monica Kocher, Advisor Health Dakshin, Dr. Mohammad Afzal, Medical Director and Chief Flight Physician, Blue Dot Air Ambulance, Dr. Mridul Kaushik, Senior Director, Operations Planning, Chief Operating Officer, Cluster 1, Max Healthcare. And the last faculty was Ms. Luna Lenda Mary Edward, First Secretary, High Commissioner of Nehru, New Delhi, India.
I now would like to hand over the time to the distinguished moderators, Dr. Deepak Saxena and Dr. Gaurav Agarwal. 45-minute session, sir. Thank you.
Thank you. A very good evening to all of you. And, this is one of the much debated, hyped and discussed topic pertaining to medical value travel. And, I'm Deepak. I'll give a quick prologue that, whenever we talk about medical value travel, it is said to be one of those domains in the industry which can yield high dividends. And if you look at the projections, the global projections for medical value travel can be as high as 275 billion US dollars by none other than 2026. But when it comes with reference to that of India, there are various stakeholders, whether you talk about the hospitals, whether you talk about the Ministry of External Affairs, whether you talk about WTO, or whether you talk about those agencies or those private hospitals which actually are giving this medical value travel. So I'm happy to invite all the panelists here, which represents the various diverse sectors where which will actually give their own perspective on the same. But before that, I hand it over to my fellow moderator, Dr. Gaurav. Gaurav.
Hello. Good afternoon, everyone. So nice to be here at Cahocon 2025. Medical value travel, the topic is opportunities and challenges. So it's a very, very hyped word, medical tourism. We have to really look into the other aspect that are we really tapping the potential of our country with regard to medical tourism, number one. And number two, what are the opportunities with regard to the sector? Number three, the challenges what we as a nation or as a sector are facing to grow this medical value travel. But the other challenges are which the world is facing, the challenges in terms of the healthcare delivery there. So that brings opportunities to us. We have a very, very esteemed panel for discussion today. There is a representation from Ministry of Commerce, Ministry of External Affairs, somebody from Public Health, people who are driving the international emergency transfers from point A to point B based from Middle East and covering Saudi Arabia. So we have a good panel, so we can have a good discussion. So we'll start with Mr. Pankaj Mishra. He represents the Ministry of External Affairs, and we can have his take and his opinion about what does Ministry of External Affairs is looking at this sector and this opportunities with regard to this sector at medical tourism.
Thank you, Gaurav. Myself, Commandant Pankaj Mishra, Officer on Special Duty, Director, Rapid Response Cell from Ministry of External Affairs. So this division, which was primarily formulated and created in 2021, aims at supplying the COVID-19 vaccine across the globe, when we have supplied around the vaccines to almost 110 countries. And lately, we have been entrusted with the responsibility for the division which looks after the HADR assistance, the response mechanism upon any disaster. So while doing this activity and reaching out across the global south, whenever you respond to any disaster or any situation, one of the important aspects is the health, the condition of the personnel, the injuries that has been sustained. And towards this, our relief material comprises significantly of the medicines, the medical items, the surgical equipment, and the other healthcare related equipment. So while we are establishing our image as the first responder to the global south and Indo-Pacific countries and as a whole to the globe, and also as a credible humanitarian assistance provider, and re-establishing our image as the pharmacy of the world, we hereby look after that. How do we reach out in a minimal possible time, providing our qualitative and effective medicines all across the globe? Toward this, like, we are promoting our medicines, our equipment, not across to our neighborhood, but to the Latin American countries, to the Pacific Island countries. We are reaching to the Vanuatu, Solomon Island, and to the Latin American countries, which are far from our territory itself. But here, our image, our intention is that let us be the one wherein we can also showcase our effort to the globe. Let's see, we are the one who can reach out all across the globe within the shortest possible time. Towards this, our government has taken various initiatives apart from providing the equipment and the medicines. How do we intend to promote the medical travel? In the context is that we are trying to develop a trust among the patient about the Indian pharmaceutical industry, about our healthcare system. By doing this, so we have made our endeavor that most of the countries have started accepting our Indian pharmacopoeia. We have taken a collective effort wherein the discussion are ongoing, and you can find the data online that many countries have accepted our Indian Pharmacopoeia Commission, which will provide a great boost in our healthcare sector. Apart from that, as per the announcement made by Honorable Prime Minister to set up a Jan Aushadhi Kendras all across the globe, India is also putting up an impetus wherein we can open the similar Jan Aushadhi Kendras, which will provide the quality and generic medicine all across the globe. So Our Honorable EM has inaugurated one in the Mauritius and Guyana and Nauru, and many are in pipeline. So also we are considering to plan a scheme similar to the Ayushman Bharat and telemedicine, wherein the consultation part for the patient who intend to travel to India, and also provide some scheme which will help them in undertaking the treatment at our own country. So these are few of the initiatives that we look forward. Our aim is to first build a trust across the globe so that we are the credible partners wherein you can look forward for undertaking the treatment. We are here to facilitate you. We have got some few data, in-house data, which we have got from our consular and passport visa division, which shows that these are the sector which primarily looks after the healthcare data, that they do often travel to India for undertaking the treatment, or this they like to do their treatment in India. Mostly, as of now, this sector belongs to the African and the neighborhood, our neighborhood. But we are also trying to ease out these visa policies as well, so that there's a ease of patient or the personnel traveling to India. Thank you.
Thank you very much. And, after hearing from Sir with a very specific perspective from MEA, I'd be very happy to introduce Dr. Pallok Sir, who actually will be throwing more light on the trade aspect because he represents WTO. So, sir, may I hand it over to you to actually deliberate on the very specific focus on the WTO's perspective and the trade-related queries. Thank you.
Thank you. Yeah, thank you. This health services is one of the services sector, and WTO deals with the services sector. So that way, the health services or medical value travel that comes very much within the ambit of the World Trade Organization or trade liberalization. But the irony here is that though health services are very important, and we know that health services are beneficial for everyone because the patient get treated, he or she feels good, his or her family members feel good, and the person can increase the productivity in his or her own country. But at the same time, somehow many countries, in fact, most of the countries under the WTO, they have not taken any trade liberalization commitment. So they are very reserved or conservative from health services perspective. And the reason is probably because health is a sensitive sector. They consider that patient security, patient safety is important. So, but nowadays, in the trade agreements or at the bilateral level, a lot of discussions are happening for increasing health services between the countries. But two important challenges I would like to highlight from the trade perspective. One is the insurance portability. When foreign patients are coming to a particular country, then generally the insurance service provider in that country, they do not cover the expenses incurred on the other country on their health related aspects. So that limits the foreign travel of patients in other countries. It's the same like in India, if we want to travel to other country like for US or UK, and if our insurance provider is not covering our expenses, it is very unlikely that on our own we go to US or UK unless we have very good financial situation. The other issue is the recognition of qualification. And this is important first because many times if qualifications are not recognized, then insurance is not provided. Second, when patient after the treatment in a country goes back to its own country, then there are certain follow-ups. There are prescriptions, medicine prescriptions. Now, these cannot be prescribed unless your qualifications are recognized in other countries. So that is a significant bottleneck. And again, there are efforts that are happening, but in the WTO, unfortunately, nowadays, not much is happening because we all know that there is President Trump has come out with reciprocal tariffs and which are against the spirit of the WTO. So that way, there is a stalemate in the WTO. But still at the bilateral level, a lot is happening on the health services front, and there are recognition by countries that health services is in the benefit of all the nations. Thank you.
Thank you very much, Dr. Pallok. May I now ask Dr. Monica if she can more explicitly tell about this debate on if everything is done for foreigners, what about the Indian patients and what about the equity angle? And is there any need for those accreditation which actually can put in India on the global standards? Madam, up to you. I just missed out. Maybe it's good if you can introduce yourself and then maybe speak on. Thank you.
Hello, everyone. I'm Dr. Monica Kocher. I'm advisor health with Dakshin, Global South Center of Excellence, which works very closely with Ministry of External Affairs. It's an autonomous body. At the outset, I would like to thank IIPH for bringing me here and giving me this important podium to discuss. As a public health professional, it is very important for me that this question be answered, So when India is projecting itself as a global healthcare destination, it is important that the local population, the rural people, the rural population or the underserved population are not left behind. And to ensure that we become a global destination for healthcare, so we need not choose between global excellence and domestic equity, but we need to pursue both deliberately and strategically. That is very important. And there have been several case studies in Thailand. If we can say, we are already projecting that healthcare sector, this MVT is going to become a 15 billion USD market by 2026. And all these revenues which are being generated can be easily redirected into public health infrastructure. Our public health infrastructure, which is for the poor, which is for the local population, can be strengthened. That is a very important aspect, the redirection of the revenues. It is being done in healthcare in Thailand. We have a very strong case study there where they have earmarked levies on the hospitals which are working with the foreign patients. And then second is the regulatory levers for cross subsidy. Many hospitals, they are working on subsidized lands, which are given to them by the government. So these hospitals can in return, take care of the underserved population, the poor patients of our country as well. This is already being done in Delhi and can become a national strategy. And that is how the tier 1 hospitals can, take care of the patients from the local populations as well. And then third, we already are working on digital systems, ABDM. We are working on telehealth for the foreign nationals to give them services across borders. Now, these services can be translated to the services given to the local populations in India as well. A lot of research is happening, a lot of MOUs are happening, capacity buildings can be done, trainings can be done, and that is how whatever is being done for the international patients can also be replicated for the Indian population as well. And that is how we need to bring equity for the Indian populations while we project ourselves as a destination for the foreign nationals for healthcare. Thank you.
Thank you, ma'am. But I think another aspect, as we were talking about the accreditation. So, it's important that India projects our hospitals in terms of our international accreditation standards, because that will give the image of we delivering quality healthcare to the international market. Second aspect, which you rightly said, is the ethical care. When you project your care, which is ethical, which is quality driven, automatically you create a market globally. And globally also the challenges are of various kind. There are Western nations which are struggling to deliver healthcare, and then there are nations which patients come from, even poorer countries like Africa, even Bangladesh, which we are getting a lot of patients. So we can categorize our international medical tourism market into practically 3-4 categories. For category 1, where patients are coming from foreign countries which are price sensitive, you can deliver how you deliver healthcare in our country. Patients who are coming from comparatively developing countries for various kinds of procedures, and then patients coming from even the Western countries which are struggling there, whether it is the UK system or the US system, where the patients can come for high value treatments and procedures. And that is where the role of accreditation standards for our country and listing of hospitals will help us to project that. We also have Dr. Mohammed Afzal. He's the medical director and chief flight physician for Blue Dot Air Ambulance. He's based out from UAE, Dubai, and covers a lot of region in terms of air transfers for medical patients. So I like to ask him to give his take on how he sees this sector of transferring patients from there, and what are the opportunities and challenges which they face as a air transfer, service providers.
Yeah, so in Blue Dot, we are specialized in 2 modes of transfer. One will be the commercial flight stretcher transfers. We utilize the normal passenger commercial airline, like any other part of the world. We use that. And we also have the private transfers in the private aircrafts. So when we talk about the logistical challenges, it's mostly, go around in the commercial flight sector, where there will be the availability is the most important factor. As our national carrier always give the availability as in the stretchers, in the oxygen, all these parts. So this makes a void in the system, and it keeps the transfers delayed for the needy. So that's one of the most major logistical challenges that we face. And this goes same for the air ambulance, the second one, and the commercial is the acceptance part. So when a patient or a client want to travel to India, the confusion about where to travel to, which hospital to go to, they shop around and look into a lot of people. There is no single one-point check system for us, for the patients or their family or insurance for that matter, to look into, to see where they should find the best quality care, a reliable quality care, which has been accredited by any of the national or private bodies. So this is one lack and one logistical challenge we always face. So the opportunity here is that Indian aviation industry is so huge. It's not just our national carrier that we can rely upon. There are a lot of other private carriers as well. They can be supported to transfer patients in. When I'm saying transferring patient in commercial airline, is not just a patient just walking in. We can even transfer critical care patients in a commercial aircraft. So other airlines should be supported from the government and the accreditation bodies for that matter to transfer patients globally. This can bring in a lot of patients. They can bridge the gap. The second major important factor, and that's more relevant to our subject, is the quality and accreditation. So our Indian air ambulance industry flies around a quality vacuum, a void, where there is no regulatory body to regulate any of these air ambulance services. But that goes same with, we started off in Dubai, where when we started, we understood that we are just an office running an air ambulance. We approached the health authority and we asked for an accreditation and a license. Even they didn't have any. Then we went to the ambulance service, DCAS, which is in Dubai, and we convinced them to have an accreditation and a license, and we were the first to get that in UAE. Then we looked into the West, and then we saw there are a lot of other accreditation agencies like URAMI, for that matter, in Europe, CAMS in Canada, NAMTA in US. So we went for the URAMI, which was one of the leading accreditation agencies in Europe. And with the 1 year stringent checks and audits, finally we got that. And that gave us a visibility as an air ambulance company. When we come back to India, the region, then we looked into some agency or any government body which can give an accreditation or license like that, but we don't have any. And that's a big void, which we really want to look into. And that regulatory body will not just regulate the private air ambulance, but also the commercial side of it as well. So this void has to be filled in. And that regulation, just like JCI or NABH, when I say Urami, we looked into Europe and saw that Urami part as a brand international. NABH as an Indian accreditation can definitely be an international brand. We had to uplift that and show it as the brand, and that's what we would like to have.
Thank you very much. And I have been listening to all panelists, but I have one question to my fellow moderator, Dr. Gaurav, who is Vice President and has been, Head of Operations for Max. Dr. Gaurav, my question to you is, and I hope you don't mind, what is the perspective of the private industry? You represent that hospital with very specific reference to two things. One, the changing political scenario. And number two, once they come here, so the post travel back to their hospitals, how follow-ups are done? And, what is your take on what actually can be done to enhance the medical value travel? Thank you.
See, thank you so much. So I suddenly become transition from a moderator to the panelist, but I'll give you my take of the medical value travel, what is happening currently. See, obviously we represent the private corporate side. Max Healthcare is one of the most prominent and dominant player in the NCR region in terms of medical value travel. But let me also tell you it's a lot of challenges, to get this business. This business is still unorganized. It is not organized at all. This business, if you compare it with our domestic business, I would find the domestic business more economically viable than our international medical value tourism, because of it is driven primarily by the so-called facilitators or so-called agents who are working and getting patients from one nation to the another nation. We all know that India is now nicely poised to grow this business at a big scale. The only thing what is limiting us is first the projection of our nation in terms of the quality what we deliver, in terms of the healthcare spectrum of procedures, right from organ transplants to niche procedures, as we were discussing about even aesthetics or everything. So the world has to know that, and India has also played a very important part in crisis management. So Indian healthcare delivery systems, Indian pharmaceutical sector, as he was just mentioning, has to be projected that it is very quality driven and also comes at a good price point, not at a cheap. We don't want to use and project ourselves as cheap medical delivery systems in the nation. Second thing is, how do you project it? When we have stronger accreditation systems like NABH, Cahocon is already driving quality at a national and global level, aligning with ISQA. We need to project that, yes, our quality standards are up to international standards, and patients who are choosing us will be choosing any international standards of healthcare delivery. Third is, you become really valuable when the customer chooses you directly, whether it is directly out of pocket or insurance companies which are based in various nations. They should be able to choose us and they should be able to facilitate us. And that is where listing of hospitals, when you are listing your hospitals at a central level, when the government also partners with the private sector and projects, it is similarly like automobile sector. We are producing cars for our nation also, and we are producing cars for the global market also, because we produce good cars at a standard procedures, and it is global standards of safety what the cars are being produced. Similarly, we can deliver healthcare, as madam was telling, to our nation also, that we set our healthcare priorities for our nation also, but parallelly we project our healthcare systems for the globe also. We can't mix it, because if we mix it, then we will not be able to capture the potential of the international market which is rightly available. Because if we don't get into that bandwagon right now, we will miss the bus. Already Turkey, Southeast Asia, or already Thailand have already taken leads in projecting themselves in the international market. So if we lose this opportunity, and the private players cannot do it in isolation, government knows the potential. And we have to understand why this topic has been chosen for panel discussion at Cahocon. The topic has been chosen today because we know the potential. If we don't tap this potential, we are losing big economic opportunity, not only for the sector, but also for the huge employment opportunities which will be missing. Right now, India has the best expertise in doctors, best expertise in nursing, best expertise in paramedical, technical side. We have the technology available with us. Our processes are more better and streamlined and strengthened. The care delivery is much better what it was earlier. And our pharma sector has really shown the world that what we are able to get to the world. So listing of hospitals, categorizing of the hospitals will make things easier. Insurance agencies tie-ups will make help easier, and technology, as you rightly said. So most important part is for the patients now who want to travel to India or want to avail our services. With the post-COVID era, everything is available on VC. We can have these platforms where the patient can consult our doctors. They can send their prescriptions. A preliminary diagnostic workup can be done at their place. A diagnosis can be reached. A package can be given. A pricing point can be given. Conversation can happen very transparently. And when the patient now chooses to travel, the ease of travel through help from the government, through commerce industry, through external affairs industry, ministry, separate visa windows, immigration windows when they land, and then the pickup and procedures and post procedures. When you align with actually hospitality sector, we can actually grow. See, everybody has to understand. Even I was talking to somebody senior in the hospitality sector. The hospitality sector cannot grow only on marriages and banquet hall functions. Hospitality sector, every sector needs foreign tourists to come and get foreign currencies, and the economy will grow. Similarly, medical tourism and hospitality then aligns post-care. And then our mystique of yoga, Ayush, all these services can add to the end-to-end spectrum of the medical tourism sector to grow. And that is how I think we should project it. Technology post-procedure. I think post-procedure and post when they go back. Our doctors are traveling to almost every country. So post-consultation can even happen in those countries, and post-consultation can happen through VCs also. Our doctors from our hospitals also travel to so many countries and develop, the other thing which everybody has to understand, many countries don't even have high-end programs in their nations, and these are developed countries. Bone marrow transplant program, we recently developed the bone marrow transplant program in the country like Georgia. We are developing and giving mentorship to many good hospitals in good nations like in African countries like Nairobi. Western world, we are tying up with NHS because their waiting times are so high. Those patients don't even have, 6 months for a knee replacement. Those tie-ups can be done at a country, at a government to government level, and the patients can come to us and get those procedures done. And niche procedures, what he was talking about, hair transplant, aesthetic surgeries, all the spectrum of procedures are now available in our country to deliver. Only thing is that we need to market it, we need to position it, we need to brand it and deliver it at high quality, good price, not high quality, cheap or anything else. So technology, aligning with the government sector, positioning it, ease every patient who's traveling from abroad, whether from African countries or Western world, needs ease of comfort, ease of travel, safer journey, safer treatments, and safer post-travel back. And that all thing can be easily delivered. Now the country is poised to capture that position in the world. And India, with the aviation sector growing and our nation and our most of our metros being the hubs of air transfer and what he was just talking about, we can take that opportunity because the travel time for India from any country to any country, 6 hours, 7 hours, 8 hours is doable. Even from US East Coast, we can direct flights, 12 hours, we can reach Delhi or any metro city. So for patients, it is very easy. The only thing is we have to understand this opportunity. It's a big opportunity. If we leave it unorganized, like what is happening right now, we will miss the bus and we will just keep focusing on very low value medical tourism. If we grab this opportunity in a structured way with the people representing the ministry here and very rightly said by him, the pointers and suggestions given by him, I think we are poised to be the biggest player globally in terms of medical tourism.
Thank you. And I'm cognizant of the time. My last question, which is pretty open to any one of you who would like to comment on, are we ready to have something which converges almost everything? Can we have something like a Zomato or something like Swiggy? If I want to have vada pav, I can offer it from. Can we have some platform whereby, we have representatives from ministry, representatives from academia, Cahocon, who actually can facilitate this discussion? Are we really ready? Because this is one of the important questions that we need to answer. And I look forward for your opinion, and possibly then we'll end. Maybe any one of you can pick this question if they really want to respond. Sir?
No, certainly there is a lot of opportunity because this is the model which is the need of the foreign patients. They also require authentic information at one place. And this kind of model like Zomato, Swiggy, where you have all the information in one place and more important, authentic information. So that is certainly the need of our. There were some efforts in this direction. Ministry of Commerce itself, in 2000 around 16, we tried to develop some information, develop a website with the Services Export Promotion Council, providing some information that did not reach that level because of a number of logistic challenges. But this is the time, because now we have grown up. 2016 was the time when medical value travel in India was kind of in emerging. It was in a nascent stage. But now we have come up significantly. After that COVID-19 pandemic, we have successfully recovered from the pandemic, and we have shown to the world that what kind of medical facilities we have. So this is the time that this initiative, which IIPAG is thinking, must be taken up, and we should develop such kind of platform with authentic information. Thank you.
Thank you, everyone. Just wanted to add one point and also a open question to everyone. See, while we discuss on this medicine and the treatment part on the healthcare sector, the very important question is that the trust which we have on a particular medicine or the particular healthcare system. In the last year, during August 2024, Ministry of External Affairs in collaboration with Ministry of Health and Family Welfare have conducted a policy maker visit at a senior level. The participants were from the DG, DDG level, and almost 20 plus countries have participated. So while interacting with these participants, the delegation, we could understand that still there's a lot of cobweb in the mind of people about our healthcare system, about our medicine. And during visits to their pharmacopoeia commission, to our best of the class hospitals, to our manufacturing plant, even to the units at Hyderabad where vaccines are produced, a lot of things got clear. Their understanding, their acceptability to the Indian medicine, and various other factors which were there in their mind, which may have been induced by some of the various factors. We need to clear all these issues so that we can, sitting over within our India, we need to understand that we can't keep boasting about our healthcare sector unless the message has been appropriately promulgated among the people. So government is working on the various scheme, also on the platform, which so you rightly mentioned that similar to the Zomato or the Swiggy, we are working onto the platform which will be easily be accessible by everyone. Our person looking forward for the treatment, long term, short term, can have access to those platforms and get the things at an easier thing. So endeavor is to have built up trust across the globe about our Indian pharma industry.
Thank you very much, sir. And I hope we end this. I have been given signals from there. Thank you very much for your patience hearing, and in paucity of time, we'll not be able to offer any question on it points, but during the tea time, we can discuss this. Thank you.
Thank you, Dr. Saxena. It was an enlightening session. Let's give them a big hand. They have enlightened us on travel, medical travel. Thank you so much, sir. Let's please join for the photo shoot, please.
Next, we are moving on for the product launch from Zuerleze Hygiene India. For this, I request Dr. Manodeep Singh, Professor, Dr. Ram Mohar Lohia, Institute of Medical Science, Lucknow, along with his team to step onto the stage.
Let's give them a big hand, please. We need a lot of energy from the hall. I know all of you are tired since morning, but let's give them a big hand as they launch two important products. Two products. Please come, sir. Please come on the stage. There are two products which they are launching. First product name is Hydro Pro. It is a product which is compared with hydrogen peroxide with EHP technology. Hydro Pro is escalated hydrogen peroxide technology, provides a robust solution for disinfection in healthcare settings, particularly in operating rooms and critical areas. Designed with compliance to CDC guidelines, equipped with detailed material compatibility reports, Hydro Pro stands out as a powerful disinfectant suitable for diverse applications.
And some of its key benefits of HydroPro: it is an effective disinfection, it acts rapidly, it has a low concentration, it has versatile application, safe for all medical area surfaces, it is environment friendly, odorless and non-corrosive, it has enhanced clinical performance and complies with the regulatory requirements.
Product number 2, Cleanzyme. Dr. Manodeep Sen, Professor, we are so happy that you could be here to launch this product. And Cleanzyme multi-enzyme cleaner with FCP technology offers several benefits: quick action, multi-enzymatic formula, enhanced hygiene, ideal for healthcare settings, residue-free, environmentally friendly, neutral pH, low corrosion, improved instrument cleaning, optimized patient load management, importance in operating rooms and for CSSD department. It's a wonderful product. These two products are launched by this wonderful company. Thank you, sir. We wish you the best as you venture into this business in the future. Thank you so much.
And definitely these products undergoes how enzymatic cleaners are vital in maintaining high standards of cleanliness and safety in healthcare, particularly in sensitive areas like OT and your sterilization departments. Thank you so much for the team from Zoology.
Let's give them a big hand. Thank you.
So we are moving on to the final session of the day. It is session 9. It is transformation and opportunities in healthcare.
The distinguished chairperson, Dr. Manish Kohli, please kindly come on to the dais, sir. He's the founder, Pull Alliance for Digital Health and Equity. He's coming to us from the United States of America. We have the next chairperson,
Dr. Rajiv Singhal, founding member, managing director and CEO, Meringo Asia Healthcare.
esteemed faculty, kindly come on to the dais. Dr. Pankaj Raina, leader, medical affairs, MDS India, South Asia, Becton Dickinson Private Limited. Topic: reducing risks and improving vascular access outcomes. VAM India baseline insights. Dr. Sachin Indain, co-founder and CEO, Insanis Lifecare India. Topic: safe wards driven by digital monitoring.
And we request Ms. Roslyn Becker, Director Safe Care, Amsterdam, the Netherlands. And she's going to talk on digital quality improvement journey, the experience of safe care from LMIC. And the next person, it is Mr. Jagdish R. It's a Vice President, Product and Application Health from Narayana Health. And he's going to talk on next is now creating digital backbone for modern healthcare.
We now would like to hand over the time to our distinguished chairperson, Dr. Manish Kohli. Over to you, sir.
Good evening, everyone. Can everybody stand up, please? It's the last session of the day. Let's do your favorite yoga pose. Choose your pose. My panelists can do it as well. Please. All right. Your favorite pose. All right. Are we ready to have some fun? Please. So truly honored to be joined on stage by some distinguished panelists and a topic that's very close to all of our hearts. How do we transform healthcare for the better? I want to start with a story. How many of you have heard of the man on the moon story? Anybody? You have, okay. So we'll share it with the rest of the group. So John F. Kennedy, President Kennedy, was touring the Kennedy Space Center in Houston many, many years ago. And he ran across somebody who was sweeping the floor. President Kennedy asked him, "Sir, what are you doing? Tell me about your work." The man stood up said, I'm really pleased to meet you, Mr. President. You know, I'm going to put a man on the moon. And this is the man of the moon moment for healthcare. We are all innovating. We are all doing amazing things in our own domains. But collectively, we now have to think about how do we create outcomes? Outcomes that improve access to what patients need. So without taking any more time, I'm going to turn it over to our first speaker, and then we will follow this up with some questions at the end. So
good evening, everyone. So I'm Dr. Pankaj Raina. I represent Becton Dickinson. So I lead the medical affairs for India, South Asia, and based out of Delhi. Sure. Yeah. Oh, yeah. So good evening. And one of the common things that we see whenever a patient visits a hospital, right? 90% of those hospitals receive any kind of an intravenous line. And then what the data says and what the different studies are saying that around 50% of these IV lines fail. When we say they fail, they are failing firstly, maybe at the time of insertion, maybe they don't stay for the time that they are intended to be placed in for. But if we are looking at those numbers, they're too high. That means every second patient is having an IV line which doesn't meet its real goals. So the failures, unfortunately or fortunately, are preventable. So these are like infections, phlebites, occlusions that we see, dislodgements, or extravasations. So if anything is preventable, so you don't need to cure it. You have preventive measures which can help you. And the quality of care determines how you can prevent those. And these complications are multi-start and they affect everyone, all the stakeholders which are involved in the care process. Maybe patients, right? They get a lot of discomfort and pain. There is a delay in the therapy for that person, and patient confidence in the caregiver also is reduced. So clinicians also are stressed, and they also see clinical inefficiencies. They see clinician satisfactions go down. And again, for the administrators, because the reputation of the hospital goes down, the patient satisfactions are low, and the length of stay for the patients increases. So the question is, if we reduce these complications together, so that's the theme that we want to open up to you. So what we as an organization started, we discussed and we developed a program which was called Vascular Access Management, where we were auditing a hospital over a period of 3 or 4 days with 3 things in mind, starting off with practice assessments. So, and then followed by comprehensive portfolio of new products that can prevent those complications, and then trainings to the end users there. But the question here was not about implementing it programs. When we started off, hospitals were seeing complications, but they were saying, are we good, bad, or ugly? So there was nothing that we could compare them with, externally as well as internally. So that was our first challenge. So we knew that what is their rate, but whether that is acceptable or that's not acceptable when it comes to complications. So what we did is we did the baseline clinical audits, we provided them recommendations, and then we re-audited them, and we see how things have changed. With respect to that, one question which we often used to get from them was, how are we doing with respect to other healthcare systems? So that's how we did an external benchmarking for that. So there were 40 hospitals, right? All of them were at an average bed size of 250. And we tracked around 1,600 hours of audit across those hospitals. And this tells you about the sheer size of the data, so that, yes, if we are comparing them with another hospitals, it really makes sense. Then what helped us here is, right, you would be able to see the first, right, hospital baseline data, then the external benchmark was whether they are above or below it. Majority of the hospitals where we did it were our 7 hospitals. And post implementation, what we saw was there was a significant improvement in the dwell time, which we say how long the catheter stays with that patient. There was significant reduction of around 22% in the complications, and the needle stick injuries, which is one of the key KPIs that the hospitals track, was reduced to 1. It also helped us look at how they are using technologies with respect to closed infusions. In those hospitals, it went from 37 to 64%. And similarly, the pre-filled saline flush, which is used for care and maintenance of the lines, also went up, which definitely shows that one is technology upgrades with closed systems helps reduce the complications and increase the dwell time for sure. Now, reducing complication, what does it mean for us? It means fewer restarts, decreased product usage. Can I have your attention, please? Can I have everyone's attention, please? Can I have everyone's attention, please? We have a lot of ambient noise in the room. We're having difficulty hearing the speakers. If you must have a group conversation, can we request you to please step outside? Thank you. Okay, so then what does it mean? Reducing the complications has 2 impacts, right? We have fewer restarts of catheters. It decreases the number of catheters that we are using. It reduces the cost of managing the lines per patient. It reduces overall cost, and there is a lower risk of complications to the patient. And you have longer dwell time, which is a positive thing, increased patient satisfaction, which we measured, and we saw there was a significant improvement in the patient satisfactions. It enhances the hospital reputation, because many a times you will see hospitals are being said that the first experience that they encounter in any hospital is when the catheter was inserted. And that's the first experience that they go with when they are moving out of the hospital. Then the experience of nurses, how did they measure them? And there are increased efficiencies in the overall care for the patient. With that, I would like to stop here and say, yes, improving the quality, you need to know the baseline, right? In our countries, unfortunately, many a times we don't have it. We also need to create our own local benchmarks with which you can compare. And third is, yes, look at the implementations and the guidelines that you are following. How is that going to impact you in your hospitals as we move forward? Thank you so much. I invite our next speaker onto the podium, please.
Yeah, hi. Good evening. My name is Sachin Indane. I'm a co-founder and CEO of a company called iSenses. And I think as in line with the theme of the today's session of transforming healthcare and making a difference using technology, I'll be talking and giving you some glimpses about some very, very exciting and innovative technology that we have. So I would just request your attention for just about 5 to 7 minutes, and I'm sure you certainly won't get disappointed. Thank you so much, Dr. Manish. I'll be. Okay, good evening. So as I said, iSenses is the name of the organization, and the solution is called Patient Status Engine. And as you can make out from the name itself, it's basically an entire machinery or the platform that is designed to give you status of the patient anytime, real time, from anywhere. Very important is it is completely a digital healthcare platform, and that has been changing Come this side, Shabazz. Changing the landscape of healthcare in India big time. A little bit of us, we are a UK-based company. We've been in the market, one of the pioneers in this market from 2010. So as you can calculate, like 15 years we have been doing this in market, in global market. And 15 years is long time to master the art of the particular technology that we have, which we will talk about. And as you can see here, our vision for in the Indian healthcare is how can we help you people give a very, very high quality of medical services, but at the same time help patient and the hospitals reduce the cost. Now, one of the ways of reducing the cost both for hospital as well as for the patient is to move the patient from high cost setup to low cost setup. That means, from ICU to HDU to ward and even to homes, right? If you are able to do that successfully without compromising the quality of healthcare, I think all of us would like to do that, right? All hospitals will be happy, patients will be happy. I'm sure the insurers, the payers will be even happier than all of us. So we have a very strong legacy and that brings the trust. If you look at this industry of ward patient monitoring, because now this is a new concept that's kind of coming up last 4 or 5 years, there has been a big surge in this concept of monitoring the high risk vulnerable ward patients. This is not ICU patient. These are the ward patients or HDU patients. So anything below ICU, and it needs a lot of trust. There are a lot of players in this, but that's missing in the industry right now is the trust from all of you. And we bring that. That trust comes from our strong legacy. The trust comes from regulators. The way you people get the trust from NABH, JCI, CARF, multiple agencies, for us, it's the regulators, right? So we get our solutions validated by US FDA, by European MDR, by India CDSCO, and we are the only technology provider who has all possible approvals for this particular technology. And as a result of that, in a very short period of 2.5 years in Indian market, we have been very fortunate to have the A category customers with us, and we are really thankful to all of these for trusting us. Now, what is that? What is the solution we are talking about? So it's basically a completely wireless patient monitoring platform. So as you can see here, we have my colleague here. If you can have a video on him, please. Hello, video master. Video master, can we have video on him, please? Yeah. Where is the sensor? Okay, so that's the technology that we have. So we have this sensor. We have a cardiac sensor that goes onto the patient body. It goes onto the chest, just on the 2 ECG electrodes, completely reusable. It basically uses a simple battery, Bluetooth enabled, reusable. You can replace the battery and use it. You can clean it. You can sterilize it. Then we have a temperature sensor that goes into axilla. Then we have the SpO2 and Bluetooth, blood pressure. The advantage of this is, as you can see here, there are no wires on the patient's body, or there are no wires between the patient's body and the bedside monitor. So the patient is completely mobile, can walk, can go to toilet, can sleep in any position, even go for rehab, do exercises, everything, and still getting continuously monitored. Then we have a very unique bedside monitor. That's not only just a display monitor, but it's also, you can enter data. You can see everything possible on that. As you can see all the parameters. You can see complete trend for each parameter. All the ECGs are seen that on that. You can enter data. You can select conditions like GCS, like patient is on oxygen or not. All that is possible on this bedside device. Now, once you have the data on this bedside device using very nominal Wi-Fi or even a SIM card, we are able to send this information on real time to your servers. Now, the moment you send the information to the server, it is accessible from anywhere in the hospital, whether it is from the nursing station or your command center or even on your mobile. Even the doctor's consultant can see their patient's information, from their consulting chambers. We also have early warning scoring mechanism. And very importantly, a detailed reports, dashboards, and patient reports, single clickable reports are available. All the vital signs are captured here. It's like, heart rate, respiratory, SpO2, blood pressure, everything. And also a lot of manual entries we can do on this. This is how what you see. Not only that, we also have this in the HDU setup. So as you can see here, the small video that is playing now. On that video, this is the HDU setup in one of the hospitals in Bangalore. And you can see this is a respiratory HDU in one of the prominent hospitals. The question is how accurate it is. So it's like 100% accurate, gives you as accurate results as any of your monitors, whether it's from Philips or any other company, GE, it gives very accurate data. And that's what matters at the end of the day. Now, let me kind of quickly tell you how it is useful and where it is used in the hospital. So as I said, this is not for ICU. So this is used for HDU patients or ward patients, or any high-risk patients in the ward, or in transit, even at home, or any of the special procedures the patient is undergoing. Patient can be continuously monitored without any wires, with very high level of accuracy and ICU level of monitoring. As all of you know, we have all these charts and everything maintained by the nurses. This is completely transformed into a digital form. So what we are doing, we are basically taking the digitization right onto the patient bed. Because today when we talk about digitization, we talk about digitization everywhere else. But the patient data, which is actual data on which the hospitals or the doctors take action, that is still manual. And we are able to convert that into a digital data right at the source of that data. And as you can see there, we have remote views which are available across the hospital, even on the mobile phones. And this is to avoid any kind of situations. We have WhatsApp alerts in case of patient's conditions change, or we also have audio alerts. We also have the screen pop-ups which come, giving you the enough time for the proactive action. You can see that some of the cases, all these are ward patients or home patients. Here you can see that the patient's saturation level, oxygen, the heart rate, you can see that the respiration rate is high, saturation is coming down, early warning score going up. And thereby you can see that the patient was proactively moved to ICU. A lot of data available. This is a road traffic accident case, came to one of the big hospitals. Very, very poor patient got onto the road and they got to the hospital, not in a position to afford. They managed this patient for 6 days in ward. And the 6th day patient got completely recovered without getting into ICU. This is another patient admitted in the hospital for a cardiac procedure, goes into syncope. And then when the syncope happens, nobody knows why and what's the main reason for that. Our system could capture the data properly. You can see that the ECG could see arrhythmic beats lasting for 30 to 40 seconds. And as a result, the cardiologist did not wait for the procedure which was scheduled for next day. They immediately got onto the cath lab and got the procedure done for the patient. This was a home care patient with bradycardia condition, went home, the heart rate dropped immediately. And as a result, patient was called back immediately to the hospital, put a pacemaker. You can see here, this is the patient which is undergoing robotic exercise in the rehab, and with the sensors and devices on his body, like the way my colleague Shahbaz has here. And the patient is getting monitored without any wires or anything. And of course, in transit at home, we can do. So this is the technology which is transforming healthcare. It helps you all the way from clinical to operational to financial benefits. Very useful. We have, as we said, we know Manipal, Apollo, Fortis, Max, AIG, Arate. All these hospitals are using it successfully. And we can be very, pretty good technology partner for you to reduce ICU loss, to reduce the emergencies, the code blues, improving nursing efficiencies, and kind of improving overall productivity, efficiency, and effectiveness of healthcare system. We'll be very happy. We have a stall number 10, just outside the exhibition area, outside the conference room. Please do visit. We are very happy. We are very passionate about this. And we want all of you to join us in this wonderful journey that we have begun. Thank you so much.
Thank you, Dr. Indian. One of the things that stands out for me is the talk this morning in the opening by Dr. Braithwaite about innovation and what it means to transform the 60-30-10 rule. And these two examples we've seen are really great examples of how we begin to address the 30 and the 10. And really it's the power of how do we actually look at procedural level innovation? How do we bring in training and automation? And how do we leverage the power of dashboards and data and real-time monitoring to really improve our ability to take care of patients? So our next speaker is Ms. Rolinde Bakker from Amsterdam, and we're going to talk about how do we actually lead organizations who may be in low resource settings through transformation, through the use of quality standards. So Ms. Rolinde Bakker, the floor is yours.
Hello, good afternoon, everyone. It's such a pleasure to be here with you today. It's my first time at Cahocon, but it's amazing. Congratulations to the Caho team. Congratulations to all of you. I want to talk about quality improvements. And I want to ask you a question. What is your dream? What is your dream if you look at quality healthcare and the national and international agenda? We know that a lot of patients don't have access to quality healthcare. And even today, we know that poor quality of care causes more deaths than lack of access to care. As Safecare, we have a team here in Delhi. I'm based in Amsterdam. We have a team in Kenya, Tanzania, Ghana, and Nigeria. And our mission is really to bring quality healthcare to the last mile and to reach the unreached. And we know that there are many challenges. There is a shortage of staff. That is something we see globally. We know there is an increasing demand because of the rise of NCDs. We know that there's a high out-of-pocket expenditure. And we know the pain points of the facilities. I have been to facilities myself in Ghana, in Zanzibar, and I have seen the complexities and the reality on the ground that patients are dying because there is no doctor or there is no nurse. But we know these deaths are preventable. So as Safecare, we support and strengthen health systems and partners through a stepwise approach. So we provide certification, and it's really for facilities to help them to start their quality improvement journey. And it's really to make quality attractive, that they know how they can close the gaps. We use international accredited standards empowered by interactive data insights to drive structural change. Our solution focused on a stepwise approach. It helps and improve and sustain quality. It starts at the level 1, and we help facilities to prepare for accreditation to help them grow their level up to level 4 and 5. We have holistic standards, so it's really looking at the clinical performance and the management performance, because when we know that you can have a great clinical team, but if the laboratory is not functioning well, you can still have a bad outcome. It's really a team effort. HR, cleaning, pharmacy, all elements in the facilities come together when it comes to providing quality healthcare. And we know that quality is a continuous journey. It's behavior change. And the strength of a continuous digital process is that it starts with assessment, because you can only improve what you measure. After the assessment, the facility receives a digital quality improvement plan. And a digital quality improvement plan, it's tailored. So it's the gaps, the criteria that are linked with patient outcomes are prioritized. The facility is supported through our digitized platform that people can access on a desktop or smartphone, through our library, through training. So it's really about breaking down the steps so that it's achievable to work on quality as a team and to monitor the progress. Via the quality platform, the facility receives actionable feedback on the real-time progress, feedback, but also supporting documentation. So what do we see? We have 15 years of experience working in more than 9,000 facilities in 27 countries with 25 partners. And what we see, if you look at these examples from the baseline compared to the end line, and the baseline is the first assessment and the end line is the last assessment, there is improvement. We see improvement on all the criteria: waste management compliance, protocol compliance, resuscitation training, and available triage systems. But we also see that there is still work to do. It's also about how to sustain your level of quality. So if you look at our work, it's really about creating transparency on quality data by connecting partners. We work with private partners, so for example, Cahocon hospitals in Afghanistan, Pakistan, Philippines, and Kenya and Tanzania. In India, we work with Manyata, supporting more than 1,100 hospitals on MNCH care with the FOXY program that is led by the Manyata healthcare stakeholders. But we also support public partners like the regional or the national Ministry of Health. And by creating transparency, there is a possibility to have insight on the gaps and to prioritize the training, to prioritize the staff and the allocation of capacities. As Safecare, we believe that every person has the right to quality healthcare. And we know currently also, for example, in Nepal, that a lot of facilities don't have access to quality for all kind of reasons. But with digitization, it's possible to reach those facilities. Especially during COVID, we were not able to visit the facilities ourselves. But because of the digitization, it's possible also to give remote support and to give interactive data insights. And we always work through local partners. So we train assessors in a methodology, and these assessors bring Safecare to their clinics and to their hospitals. So we are really excited also here to start this journey with you. Because as Safecare, we really work with partners, healthcare stakeholders in the ecosystem. And this is an example from St. Joseph Hospital in Kilimanjaro that participated in Safecare since 2016. Quality of care is a right for every client who visits us. Safecare helps us improve quality, which leads to more visitors and more revenue. Because of their journey with Safecare, there was a more than 90% patient satisfaction rate improvement. There was a 25% increase in revenue since I reached level 5. And there was an increased staff ownership and service efficiency. So it's all about having a business model and a business case for the facility, but also for the network. And I have seen the impact of Safecare at the patient level, because if they feel well treated, they come back to the facility. I have seen the impact for professionals because they feel empowered to work on quality. And as a network, there is more ownership and transparency where to invest and to allocate resources. So it's a privilege to be here today with you. We hope to see you at our booth. And for more information, if you are interested in working with us, we are especially looking at working with small and medium-sized hospitals to help them to start a journey towards national accreditation.
Thank you, thank you. SafeCare is doing some really important work and really aligned with what CAHO stands for as well, making quality healthcare accessible in tier 2, tier 3, and vulnerable populations. So congratulations and kudos. So moving from an organization that's enabling quality care to the masses in low resource settings, we want to go to pioneers of low cost procedures at Narayana Health. We have Mr. Jagdish R, who's going to talk about their journey on innovation and transformation.
Very good evening to everyone. I'll start with a small anecdote. I think being in IT in healthcare, most of our timelines start from yesterday. We get the requirement today, but the timeline is always, I need it by yesterday. So in true spirit of that, I think Dr. Manish has given me the timeline of basically finishing this before I even start. So I'll keep it very short, and hopefully we'll have some quality takeaways from this discussion. So next is now, crafting the digital backbone of modern healthcare. That's a mouthful. So let's start by doing a small thought exercise, right? Let's wind back the clock. Let's go back 50 years. You enter a hospital. How does it look? You see a waiting lobby, you see a registration desk, you see somebody sitting there who will register you, and then you go meet the doctor, then you get your prescription and you walk out of the hospital. Now, how does that compare with hospitals today? So this is a picture of an NHS hospital. The one on your left is on one taken in 1970. And the other one is a hospital taken today. There isn't much difference apart from the fact that they are split by 50 years and some interior decor difference. The processes have largely remained the same. So, automation applied to an inefficient operation will magnify the inefficiency. So we've been investing in health tech for a long time. If you see that 50-year time period that we just saw in those two pictures, that represents the bulk of investment that has happened, bulk of advancement that has happened in technology so far. But why hasn't it changed the way our hospitals operate? Why do we still have similar waiting time and the lack of, I would say, dramatic shift from where we were 50 years back? That brings us to the question, right? How do we view our investment in technology? How do hospitals and healthcare systems look at technology? Are they measured the right way? Are we measuring the right KPIs when it comes to how our investments in technology deliver in terms of whether it is reduction in operational burden, improvement in patient outcomes, quality metrics, or, to put it in a business term, what is the return on the investment? The sad fact is that not much of our technology are measured with the right KPIs. And what we end up is a scenario where we have a lot of digitization, right? But without serious impact or change to the way hospitals operate. What we have are paper charts and long queues that have been replaced by their digital equivalent, but the decision making or the productivity of our manpower, whether it is clinicians or administrators, has not really changed. So looking at one of the most advanced or most digitized markets when it comes to health tech, which is the US, there the situation is pretty grim. That more than 60% of physicians are burnt out in terms of trying to keep up with all the digital interventions that have come up all this while. And manual errors still continue to happen despite rampant digitization. So what is the doctor's dilemma? Like, are they supposed to focus on treatment or learn to log into 15 different applications that have been dumped on them in the name of digitization? Are we really solving the problem or adding on to it? Right? So I don't have any direct or simple answers for this, but I can share from our experience what we have seen and what has worked for us in our setting in Narayana Health, in as Atma, where we have tried to solve some of these situations, right? Our focus has been to create a seamless integration of technology with the current process, rather than trying to change the process, how we can infuse technology which seamlessly connects all the various touch points in the hospital, whether it is bedside equipments or any other lab equipment, or the doctors or the nurses, how they all can be seamlessly connected, and how we can extend the care beyond the hospital, how technology can allow doctors to take care of patients even before they come to the hospital or even after their discharge. And most importantly, how do we bring back the joy of care? So what we call is the approach that we've taken is coding by the bed. That is making doctors and engineers partners in this shared endeavor, where they are truly co-developing the solutions. And it requires that level of tight feedback so that the solutions can be improved and can be refined in a very quick time span. And a lot of focus on user experience. User experience is one of the single most important success factors that decide the adoption of any technology intervention in healthcare. And a lot of people confuse user experience with user interface, the design, how pretty it looks. That really doesn't matter. What matters is the experience. It's the number of clicks it takes to finish a transaction. It's the intuitive thought process that the product and the user have to align on. And finally, design a mobile first ecosystem that will help doctors and nurses truly become unencumbered from sitting at the desk to use their technology solutions. It has to be mobile first. And I've touched upon many of these in terms of how a solid bedrock of a unified EHR can put all these various solutions in perspective. Today, we saw some amazing tech just before in this panel. At the end of the day, all that data has to flow in and help the doctors take that decision, make them more productive, make them more confident in their thought process, and be more when they can take care of much more patients. So we strongly believe that interoperability and seamless integration and decision support can go a long way in increasing our doctors and nurses' productivity without compromising on care. So we believe that the future is here, and we are going to see more and more hospitals where there are no back offices. Forget back offices, there won't be even front offices. Only people in scrubs will be in hospitals. All the other activities will be either automated or moved to an off-site location. And that requires a strong tech backbone. And we will see more stronger decentralization of care. Care will move out of the hospitals and move closer, more upstream towards the patients, to community centers and at home care. And we also are seeing a lot of patients who demand more autonomy and more transparency in the whole process. And that is only possible if it is the entire ecosystem is completely tech enabled, and ultimately leading to bridging the gap between demand and supply, and the patchy distribution of doctors across the country. With a strong EHR, we can predict a scenario where today's doctors can be 10x doctors. They can take care of many more patients without compromising on the quality. Thank you.
Thank you, Mr. Jagdish. So just a few final thoughts. First of all, a big round of applause for the esteemed speakers here. So I think we all agree that our man on the moon is ensuring that everyone has access to quality care. That's what unites all of us. And we all recognize that we are only as good as our weakest link. So innovation, quality healthcare should not be accessible only to the few, but to all. We also recognize that to really transform healthcare, it's the 30 and the 10 we really need to be focused on. How do we begin to align data, people, processes, technology to address the waste and the harm that we cause in healthcare, that exists in healthcare? Just to give you a perspective, globally, we spend 10% of our GDP on healthcare, but $10 trillion. If I tell you 40% of that is wasted or causes harm, that's $4 trillion that add no value. So when we talk about where does the money come from, it is going to come from automation, data-driven decision-making, procedural innovation, standards-based practice, pioneers like Narayana Health who are actually driving the charge of low-cost healthcare and at the highest level, highest quality. So we have to really be respectful and mindful that we live in a time which is exciting, a lot of possibilities ahead, but that can be distracting. We have to be focused on what is our North Star. And Caho has defined it for us. It is safety and quality, nothing else. But we also have to be mindful that our consumer, our patients are changing. When I started my career in digital health, it was a very different consumer market. Now the patients own cell phones, even in the poorest of the settings. They are in the 21st century. We must address their needs. Medicine is changing. Gone are the days when it takes 10 years, 20 years for benchside research to get to the bedside. We have to shorten the cycle significantly, and we have the tools. And finally, technology is also changing. And by the way, this is not about technology, it's about people. So let's come together and let's put a man on the moon. Thank you all.
Thank you, faculties. We request you to join for a group photograph.
Thank you, sir. Thank you, Dr. Manish and team. It was a wonderful and enlightening session. Thank you so much. Now we will have a launch of Blue Dot Air Ambulance. Blue Dot Air Ambulance is an air ambulance which is to be launched now, and we would like to request the following on-stage people to kindly come forward. Dr. Muhammad Afzal, Medical Director and Chief Flight Physician. Dr. Rahul, Lead Medical Director, India. Mr. Sabrish KG, Business Head, Asia Pacific.
And from the Caho family, we request Dr. Peter Luckman, Dr. Anuradha Pichmani, Dr. Shweta Prabhakar, Dr. Gracie Mathai, Dr. Anna George to join on the dais, please.
Blue Dot is a leading licensed and accredited provider of quality air ambulance services, headquartered in Dubai, UAE, with offices in Saudi Arabia and India. Blue Dot stands out for its utilization of its best-in-class aircraft, advanced equipment, and specialist flight physicians, catering to 100 international embassies, consulates, and renowned hospitals worldwide. The company is synonymous with excellence in the industry. Blue Dot has successfully completed over 5,000 medical assists across 100 plus cities and countries, holding a remarkable 100% success rate. Let's give them a big hand, please. A significant milestone was reached with the recent achievement of the Urami Kame accreditation.
Blue Dot has revolutionized the field by establishing a swift response network of proficient medical squads available for missions supported by 24/7 Global Control Center. This strategic approach underscores the company's commitment to ensuring swift and efficient medical assistance.
We'd like to request you to kindly play the launch video, please. The launch video for Blue Dot. As the video is getting played, we can have
Blue
a
Dot is
photo
proud
shot
to
there.
announce accreditation by URAM for commercial airline medical escort services.
Dr. Peter Lickman, please
The
kindly
Cahocon
join them.
Aeromedical
Thank you.
Institute is the world's leading standards organization in medical air transport, with an unwavering focus on safety, quality, and excellence. This accreditation recognizes our dedication to providing exceptional patient care throughout the medical journey. Discover the Blue Dot difference today.
Thank you, sir. Thank you so much. Now we will have, let's give them a big round of applause, please. Thank you. Thank you so much. Thank you, Blue Dot Air Ambulance. Now we shall have the release of the white paper by Caho Student Engagement Committee, CAHOSEC. The lead is Dr. Amita Marla. Kindly come forward onto the stage, please. We'd like to request Dr. Amita Marla to kindly come onto the stage for the launch of the white paper. Along with Dr. Amita Marla, we'd like to request Dr. Sunita Saldana and Dr. Sunil Mundkur. And calling on the stage to launch this white paper, we request Dr. Lalu Joseph, Dr. Meda from IAPHG, and we also request Dr. Pavan Kapoor. Please come onto the stage, please. Dr. Amita Marla on the stage. This is excellent white paper released by the CAHOSEC committee. It is mostly on the title, Reimagining Healthcare Education with Patient Safety and Quality Assurance. This paper is worked by the medical students, the nursing students, the allied health sciences students, and the MHS students of CAHOSEC. It is a wonderful white paper being released. We want to thank and appreciate the CAHOSEC for this wonderful white paper release. Thank you. Let's give them a big hand.
Ladies and gentlemen, a big round of applause for the successful culmination of the quote-unquote academic proceedings of day one. And now we move on to the excitement and the felicitation part of all our graduates and all the various programs that CAHO runs of all the people who have worked for the last year to actually get an academic degree. With the permission of Dr. Agarwal and Dr. Lalu Joseph, may I please start the graduation ceremony? But before that, two housekeeping announcements. Faculty, kindly connect your gowns from the Gowns Center. And for all those students who are graduating, once you complete, kindly return the gowns to the place from where you have got the gown. I hope I'm loud and clear. I can generally speak in about 4 more languages. So in case you require clarification, please reach out. Are we good to go? Okay. Ladies and gentlemen, today we have a ton of graduates who are receiving certificates and so before the first set of awards which are being presented, first of all, I'd like to invite the chief guest for the CAHO ACE Awards, which focuses on excellence in the sterilization domain. I'd like to invite Dr. Peter Hibbert and Mr. Govind Hari. May I please have our chief guest on stage? And I'd also like to invite Dr. Vijay Agarwal, President CAHO, Dr. Lalu Joseph, Secretary General, Mr. Rajiv Gupta, Dr. Vikram Guduri, Dr. Shankar Sen Gupta, and Dr. Jay Lakshmi. JJ, please. May I also request the 3M team to kindly come up with the list so that they can read it themselves. Ladies and gentlemen, the CAHO ACE Awards supported by 3M.
Good evening to the esteemed dignitaries on the dais and in the audience. Isn't it truly remarkable to witness the inspiring journey of the ACE Quality Improvement Project? Launched in 2021, ACE is a flagship initiative by CAHO in collaboration with 3M India Limited as a technical guidance collaborator. To give you deeper insights into the ACE journey, I'm pleased to invite Mr. Rajiv Gupta, Country Business Leader, Healthcare Business, 3M India Limited, to address us on this ACE program.
Thank you, Kavita, and good evening, everyone. I would like to start with thanking the CAHO team for giving us an opportunity to talk about this program, the ACE program, with all of you. A sense of gratitude to Dr. Vijay and Dr. Lalu for making sure this program gets all the support what we see coming in from the CAHO team. We launched this. So ACE program, if most of you are not knowing what it is, it's basically a program which is in the Central Sterile Services Department. And the acronyms stand for awareness, compliance, and excellence. That's what the acronym is for ACE. Obviously, when we started it, it was just like an initiative which we took in terms of continuous improvement in the CSSDs. We wanted to make sure that it's not just an audit program, but a continuous improvement program which helps hospitals comply to international standards, improve their CSSDs to the practices which are meant to improve the outcomes, and also ensure compliance to whatever the protocols and guidelines are. It wouldn't have been possible without the support of CAHO. Means I would really appreciate the support which has come in terms of understanding the program, making sure that the program was, we were given as a technical collaborator partner, all the freedom to go and implement the checklist and do the work in the CSSDs. We have been working with Caho since its inception, so we are proud to be partners with them. When Caho started and Cahocon started, we were the first partners to work with them. And the ACE program was formulated by Dr. Vijay and Dr. Gyani. They were the ones who listened to the pitch which I made to them on what we wanted to do for the CSSD. And that's the story, that's how it started. And thanks to their support and their basically the support in terms of understanding what difference it will make to the CSSDs. And that over a period of time has grown bigger. And as Caho has become more bigger, more impactful year on year, we have been able to make the CSSD ACE program also bigger. We started sometime in 2021. Today, we have approximately 400 hospitals who have participated and about 200 hospitals who have qualified for the ACE certification. It's not, like I said, an audit program, but a continuous improvement program, which means there's a lot of intense participation from the CSSD technicians, CSSD people who are involved from the infection control department, infection prevention department, all the departments put together. And that's where it becomes wholesome. We have seen hospitals who have gone through the ACE certification go higher. They have won Asia Pacific Awards for the best practices. They have also been awarded WHO from a WHO Quality Collaboration Center, the award for practices, which we have been able to implement through the ACE program. Obviously, this whole initiative couldn't have been possible without the auditors who are there. Means we have about 80 auditors who are from Caho. They are the people who tirelessly work with each hospital to implement these standards, protocols, and guidelines which have been qualified by Caho in terms of what is the right practice to be implemented. We have 3 sets of hospitals, medium, small, and large. And in those hospitals, we have different checklists, which is implemented, and the guidelines and protocols and the checklist have been validated by Caho. The hospitals don't have it easy. The auditors are trained on the checklist, trained on the right protocols and guidelines, updated on that on a half-yearly basis. So 3M does a train the trainer program for these auditors, make sure that they are updated on the protocols and guidelines and the checklist so that when they go to the hospitals, they make sure that the right practices are implemented. So today, people whom you see on the stage winning the award, you can know that they have really done hard work in terms of implementing the practices, and it's not come easy. So my congratulations to the winners as well as the participants, and I wish the ACE program, more and more hospitals implement this as a part of their continuous improvement program. So thank you. Thanks a lot.
Thank you, Rajiv, for elaborating on ACE significance and achievements. In 2024, as you see on the slide, we had 132 hospitals included in the 4 categories of the ACE quality improvement. Today, we are here to recognize and celebrate the outstanding winners in each category, those who have demonstrated unwavering dedication and excellence in enhancing their CSSD practices. Starting with the large hospitals category, welcoming the winners from North Region, let's put our hands together for Max Super Speciality Hospital, Saket, New Delhi. I think they are not there today, so let's congratulate them. Moving on to there's a tie in this category. I would like to invite Ethar Wellness Hospital and Trauma Center team to receive the well-deserved award. Congratulations, team. Audience, please cheer them. The large hospital category, runner-up is Graphic Era Institute of Medical Sciences, Dehradun. Congratulations, team. Audience, cheer up. Let's keep encouraging this team. Next, moving on to the South Zone. Big round of applause for the Dr. Rela Institute and Medical Center, Chennai. Congratulations, team. We have a tie here again. Big round of applause for DKNM Hospital, Coimbatore. Madam, let's celebrate their success. Keep cheering, keep clapping. Congratulations, madam. In the runner-up category, let's welcome Access CMI Hospital, Bangalore, with roar of applause. Moving on to the winners from East Zone. Let's welcome Apollo Hospitals, Bhubaneswar, to receive the award. Apollo Hospitals, Bhubaneswar, please come on the dais. Next winner, we have PK Birla, CMRI Hospitals, Kolkata. Please be ready to receive the award. PK Birla, CMRI. Let's give it a big round of applause to the team. I would like to call upon NH Rabindranath Tagore Hospital from Kolkata for emerging as winner in LSU runner-up category. NH Rabindranath Tagore, please come. Keep cheering, audience. Let's encourage them with big round of applause. In LSU winner category, West Zone goes to KD Hospital, Mumbai. The team is not here today. KD Hospital. The team is not here today. The next winner in LSCO category, West Zone, is Apollo Hospitals, Navi Mumbai. Congratulations, Team Apollo. In the runner-up category, West Zone, please put your hands together for Acharya Vinoba Bhave Rural Hospital, Bartha. Keep clapping, keep cheering, audience. Acharya Vinoba Bhave Rural Hospital, Bartha. Moving on to the next category, which is Medium Healthcare Organization. Welcoming winners from North Region. Let's cheer for Eternal Hospitals, Jaipur. For the South Zone, let's welcome Kim Sunshine Hospitals, Hyderabad. Kim Sunshine, please come on the stage to receive the award. We have a tie here. I welcome the Kaveri Hospital, Chennai to come forward to receive their winner award. Congratulations, Kaveri Hospital. Next is the East Zone. Let's welcome Charnock Hospitals, Kolkata to receive the award. Congratulations, Charnock Hospital. Keep clapping, keep cheering the winners. Next, I call upon the winner from West Zone, which goes to the Saifi Hospital, Mumbai. Let's cheer for Saifi Hospital, Mumbai. Next, let's invite small hospital category. The first one goes to the North winner, Sehgal Neo Hospital, New Delhi. Kudos to the team. Sehgal Hospital, New Delhi. We again have a tie in this category. I call upon Maurice Matthias Hospital, Nagarkoil. Maurice Matthias Hospital, Nagarkoil, please come on the dais to receive your well-deserved award. I next call upon Manipal Hospital, Hebbal, Bangalore. Let's applaud Manipal Hospital, Hebbal. Congratulations, team. For East Zone, we will have Mediversal Multi Super Speciality Hospital, Patna. Heartiest congratulations, team. Audience, please cheer them. Moving on to the West Zone, I invite Sainath Hospital from Pune to receive the award. Sainath Hospital, Pune. Congratulations. The final category is the government healthcare organization. I invite Mahanama Pandit Mohan Malviya Cancer Hospital, Varanasi. Mahanama team. Next, moving on to the South Zone, Indira Gandhi Institute of Child Health, Bengaluru. Congratulations, team. From East Zone, please put your hands together to congratulate All India Institute of Medical Sciences, Bhubaneswar. We don't have any representative for this from East Zone, from AIMS. Yeah, let us take a moment to wholeheartedly congratulate all the winners and runners-up in the outstanding commitment and passion in successfully advancing through the ACE program. Thank you, one and all.
I request Dr. Vijay Agarwal and Dr. Lalu Joseph to stay on stage. We are beginning the rest of the graduation ceremony. Ladies and gentlemen, I understand this is exciting. However, first of all, we'd like to stand in single file. Secondly, we'd like you to ensure that we come up as per the requirements. And while our President and Secretary General don their ceremonial cap as well as mask, I'd just like to tell you what is going to be the order of graduates receiving their graduation certificates today. Faculty also kindly correspondingly note, we will be starting with the ISQA Fellowship, followed by the CPQIH Advanced Fellowship. Subsequently, we shall be moving on, and the order there will be Delhi, followed by Bangalore. We'll be moving on subsequently to the Leeds, followed by the CHRM, followed by IIM Shillong, and then we'll come down to the CICP4 and the CICP5 awardees. If that makes sense, we'd like to begin. And as I'd like to begin, I'd like to start with the ISQA Fellowships. For the graduation, may I kindly request to come on board our chief guest, Dr. Jeffrey Braithwaite and Dr. Arun Garg. I know. Dr. Garg, thank you, sir. For the ISQA Fellowship, I believe Dr. Jeffrey might take about a few seconds more. For the ISQA Fellowship, may I kindly invite the Chair of ISQA, Dr. Ezequiel Garcia Lorio, please, Dr. Peter Lackman, and Dr. Anuradha Pichumani to come on. Ladies and gentlemen, a big round of applause for the dignitaries on the dais. And in random order, and I'd request all of you to get your cameras charged, your excitement up, your adrenaline rushing, while our faculty settle down. So you must understand that the faculty in an ISQA fellowship are bound to be perfectionists also, because it's a fellowship in quality. Ladies and gentlemen, graduates, kindly pay attention. You will enter from the center and exit from that side. Are we clear? Are we clear? In no particular order, ladies and gentlemen, put your hands together for T.S. Chakravarti, ISQA Fellow. Coming up next, Dr. Ashish Shukla. I repeat, put your hands together for Dr. Ashish Shukla. Let me remind people that the turnaround time of photographer is approximately slated at 12 seconds, so don't expect more than that. Dr. A. Bhuma Devi. Dr. Amita Marla. Dr. Girish Kumar. Dr. Girish Kumar. Dr. Leena Saini. Dr. Leena Saini. Dr. Mohammad Sarjoon. Dr. Mohammad Sarjoon. Dr. Supriya Sarkar. Dr. Uma Shankar Raju. Kiranmeet Saran. Miss Surya K. Ma'am. Miss Surya K. Esteemed faculty, we have a turnaround time of 12 seconds, by the way. Zareen Ziauddin. Ma'am, please walk up to the stage. Dr. Pavitra Sangwan. Dr. Darshana Rathod. Dr. Arindam Kar. Dr. Anil Chilimunta. Thank you very much. We need to sit down and take a photograph, Dr. Ezekiel. You need to sit down and take a photograph. While Shah Rukh Khan and Kareena Kapoor and all of them get their photographs taken, may I kindly request the photographers in the center to sit and take photographs? People behind, their families are not able to appreciate the beauty of the ceremony. Thank you very much. Thank you very much. I would request President and Secretary General to kindly stay on stage. Thank you very much. The rest of our faculties. May I please have the video on advanced CPQIH, please? Please invite faculty Dr. Sunil Munkur and Dr. Parivalavan Rajavelu to please come on stage. Ladies and gentlemen, the advanced CPQIH program is something to cherish and to definitely people who've worked hard. We'll be asking two professionals to come forward. And I'd like to start. Before that, can we have a big round of applause for everybody in the hall for your participation, for the vigor that you've brought to this conference. Day one is coming almost to an end with the graduation. May I invite Dr. Ashwini Kumar Srivastav and Dr. Bijal Kapadia to kindly come up. Dr. Ashwini Kumar Srivastav, Dr. Kavya Srinivasan, Dr. Kalpesh Rohit, 2-2. Okay. We'll be coming up in twos, please. Yeah. Dr. Kavya Srinivasan. I'm reading out all the names, ladies and gentlemen. Please come up in twos and take your photographs. Please come. Everybody together? Okay. Everybody together. Dr. Ashwini Srivastav, Dr. Bijal Kapadia, Dr. Kavya Srinivasan, Dr. Kalpesh Rohit, Dr. Kiranmeet Saran, Dr. Manisha Singh, Dr. Monica Patni, Dr. Nareen Sehgal, Dr. Pradeep Paul, Dr. Rajesh Pai, Dr. Satyendra Kumar, Dr. Sudeep Roy, Dr. Sudipta Bhattacharya, Dr. Ulhas Udayan, Dr. Vaishali Sonavne, Dr. Vineet Kumar Khemka, Mr. Anupam Das, Mr. Durgesh Kumar Mishra, Mr. George Thomas, Mr. Justin Devasya, Dr. Pradeep, Mr. Pradeep Bansal, Mr. Preetam Kumar Saha, Mr. Robi Bose, Mr. Santosh Shankar, Mr. Suresh Kumar, the Delhi CPQIH, Mr. Kuldeep Sharma, Mr. Rabish Chandrakandi, Mrs. Jyotsna, Mrs. Kalpana Sharma, Mrs. Mansi Bhaskar, Mrs. Monica Verma, Mrs. Sheetal Singh, Ms. Anusuya Roy Chaudhary, Ms. Jhuma Basu, Ms. Joyce Claudius E., Ms. Mamta Jaiswal, Dr. Paulami Rai Sarma, Ms. Rooplekha Chakraborty, Ms. Sharda Rai, Ms. Vijaya Lakshmi Achyutan Nair, CPQH Bangalore, Dr. Lakshmi Narayana, Dr. Sinu Asha Thomas, Dr. Abhishek S., Dr. Ajay Singh Malik, Dr. Arivu K., Dr. Divya, Dr. Esther Rani. Get out of here. Delhi waits. I repeat the instruction. Once you've completed ceremony and completed all photographs, respectfully kindly hand over the gowns to where you have received them from. Otherwise, Meenakshi Jain will chop me into pieces. Big round of applause for CPQIH Advanced Delhi Batch. Ladies and gentlemen, coming up next after this last photograph, thank you. Respectfully step out from the left side of your stage as you're facing the audience. Man, that side. Please welcome and put your hands together for the Advanced CPQIH Batch of Bangalore. Doctor, kindly wait, we cannot afford to mix up. Mr. Brito is a fantastic professional. In our earlier avatars, we used to work in the traffic police of New Delhi. Dr. Lakshmi Narayan, Dr. Sinu Asha Thomas, Dr. Abhishek S., Dr. Ajay Singh Malik, Dr. Arivu K., Dr. Divya S., Dr. Esther Rani, Dr. Kumar Raj, Dr. Prasanna Venkatesh M., Dr. Sarvana Bharati, Dr. Sheikh Manzoor Ilahi, Dr. Shikha Singh, Dr. Shirshak Ghosh, Dr. Tripti Savlani, Dr. Vijayalakshmi Gopakumar, Dr. Vrishali Shasane, Mr. Siriak George, Mr. Jeba Singh I, Mr. Manoj Kulkarni, Mr. Parveen Kumar, Mr. Rufus Shakeen M, Mr. Samrat Sanyal, Mr. Shubhajot Dasgupta, Mr. Shubhra Nath Moitra, Mr. Tamil Selvan K, Mr. Umesh Kumar, Mrs. G. Priya, Mrs. Loga Palani Muthu, Mrs. Shamla V, Miss Annie Pratibha S, Miss Caroline Rebecca, Miss Debosmita Maulik Chakravarti, Miss Grace Marine Thomas, Miss Jaishri S, Miss Jyoti Anthony, Miss Nidhi Makkar, Miss Rajeshwari M, Miss Sanchita Malakar, Ms. Shazeen Munded, Ms. Shilpa Walia, Ms. Sneha Pannu, and Ms. Soma Bakshi. A big round of applause for all our CPQH Bangalore. The future of India's healthcare quality is in safe hands, ladies and gentlemen. From the left of the stage, once you finish the photographs, kindly exit in an orderly manner. Thank you very much and congratulations. Dr. Pari and Dr. Sunil Munkur, kindly step off. Thank you very much for your presence here, sir. And may I now invite Dr. J. Jayalakshmi and Dr. Aruna Pujari, once we have them off, please. The Advanced Program for Certified Professional in Hospital Infection Control faculties, Dr. J. Jayalakshmi and Dr. Aruna Pujari. Thank you, Dr. Munkur. Thank you, Dr. Pari. So kindly step off. Thank you very much. May I invite CPHIC faculty, Dr. J. Jayalakshmi and Dr. Aruna Pujari, and calling the recipients of the advanced CPHIC, Dr. Anindo Chatterjee, Dr. Atiya Kausar, Dr. Beena Jad, Dr. Divya S. CPHIC. Can we move? Dr. Aninda Chatterjee, Dr. Atiya Kausar, Dr. Beena Jad, Dr. Divya S., Dr. Kiranmeet Saran, Dr. Magesh Rangasamy, Dr. Malvika Srivastav, Dr. Masoom Nathani, Dr. Mathivandana Gopalaraju, Dr. Mayuri Bise, Dr. Nisha Singh, Dr. Pooja Raghunath, Dr. Preeti Patil, Dr. Sinu Asha Thomas, Mrs. Ansama John, Ms. Esther Sharon Yedivada. Do we have any other advanced CPHIC? Thank you very much, Dr. J. Jayalakshmi, as well as Dr. Aruna Pujari, to kindly step off. Thank you very much for all the support you've given these brilliant students. The next program we want to invite leaders, budding leaders for, is the LEADS program. And may I please invite faculty, Dr. Stuart Dixon and Dr. Shweta Prabhakar to come on stage. Successfully having completed the LEADS program, we have the following: Dr. Madan Mohan Dung, Dr. Mainullah Rahman, Dr. Sachin S., Dr. Sandhya Cherian, Dr. Wangju Sumnyan, Mr. Hari Haran Sankaraj, Mr. Rahul Vats, Mr. Rajdeep Sen, Ms. Akanksha Bajpai, Ms. Getsyal Kiruba N, Ms. Rosemary Joutin. Thank you very much. Thank you very much, Dr. Dixon and Dr. Shweta. Ma'am, thank you. Kindly exit single file to the left, faculty from the center. We move on to the CHRM. Dr. Lalu Joseph is the central figure here. We have the following students: Dr. Arindam Kar, Dr. Arjun NV, Dr. Faisal Hussain, Dr. Lalit Maudar, Dr. Mainullah Rahman, Dr. Mrinal Madhur Borgohain, Dr. Sangram Jadhav, Mr. Govind Raj Sharma, Miss Annie Matthew, Miss Elaine V. Yi Leng, Miss Tanisha Raheja, and Miss Hilagavati Bellet. Coming up next, the IIM Shillong inaugural program participants, kindly gather. Thank you very much. The inaugural batch of the IIM Shillong program for healthcare management was started in the year 2024, and we are having the first batch of graduates coming out today. Ladies and gentlemen, log in to caho.in for the second batch that is going to start in May 2025. May I please request to join the faculties to join on board. In addition to Dr. Lalu Joseph, Dr. Jeet Patwari, East Zone Chair of Caho. In random order, the naughtiest batch of IIM Shillong, Dr. Madan Mohan Dang, Dr. Swapnil Dikshit, Dr. Subrat Dev Bhagavati, Dr. Sangram Keshav Jadhav, Ms. Dr. Kurung Momokom, Dr. Sachin S., Dr. Sarita Rai, Dr. Himadri Saikya, Dr. Mrinal Madhur Borgohain, Mr. Rahul Vats, Ms. Akanksha Bajpai, Mr. Uday Kumar A., Dr. Rashmi Nishikant Raut, Dr. Sandhya Cherian, Dr. Nishant Rajkakoti, Mr. Hariharan Sankaraj, Dr. Mainullah Rahman, Mr. Govind Raj Sharma, Ms. Getsial Kiruba, Dr. N. Shashidhar Reddy, Dr. Wangju Sumyan, Dr. Lalit Maudar, Mr. Rajdeep Sen, Ms. Dimpy Das, Avinash, Ms. Rosie Mary Joud, and Dr. Francis Roy, the inaugural batch of Indian Institute of Management Shillong Caho batch. I've already got it. Boss, now I can't get it in my system. Whatever I've got, hello, come here. Second paper. But I've got this list. What is that remains? Yeah, papers number. Awards alone. Students kindly exit from the left in an orderly fashion. I'd like to invite the Caho Skills for Men, Dr. Parivalavan Rajavelu, faculty. IIM Shillong. Thank you very much, Jeet. The Caho skills for Med, Dr. Parivallam and Rajvelu, faculty. There is only one candidate who has successfully taken on and completed this program, Monami Dawn. Ladies and gentlemen, put your hands together for Monami. Malti. These awards have been given. These gold medals have been given already, right? Somebody's handling it from that side. Ladies and gentlemen, for the CITP Awards, may I invite Dr. Aruna Pujari and Dr. Malti come on stage, ma'am. Ladies and gentlemen, this is where we will actually be awarding the medals. Reduce the music, please. Debashri, can we reduce the music a bit, please? Thank you. Please welcome the national level first award winner and the Kerala state winner, Miss Devi Krishna, in the category of professional CICP. Mr. Pavan Kumar Dulipudi in the professional category, national level second, Telangana state winner. Mr. Jegin P in the professional category, national level third, Tamil Nadu state winner. Pradeepa M, national level third, Tamil Nadu state winner. Dr. Sana Amreen Mahmood in the professional category, Maharashtra state winner. Mrs. Bani Prasanna Behra in the professional category, Odisha state winner. Ms. Kiran Kumawat, professional, Uttar Pradesh state winner. Dr. Jatin Jain, professional, Rajasthan state winner. Ms. Tipagala Pranati in the professional category, Andhra Pradesh state winner. Dr. Nimi Elizabeth George in the professional category, Puducherry state winner. Dr. Swati Gupta in the professional category, Haryana state winner. Ms. Namrata Desai in the professional category, Gujarat state winner. Dr. Archana Konar Pavan Kumar, give it.
Dr. Sindhu Kohati, gold medal medical category. Dr. Debashis Biswal, silver medal medical category.
Ladies and gentlemen, there has been an error on our part. We confused the CICP winners with the Olympiad winners. With due permission, the CICP 4 and 5 awardees, Dr. Sindhu Shugati, Dr. Debashish Biswal, Ms. Vidhi Talwar, Ms. Maria Delimatin, Mr. Teisinho Kera, and Ms. Ravia CR. Ladies and gentlemen, these are gold, silver, and bronze medalists in the medical and nursing category. Dr. Geeta Vinayak Gole, Dr. Gold Medal Medical, Dr. Soni S, Bronze Medal Medical, Dr. Jaya Banerjee, Bronze Medal Medical, Mrs. Rupali Chopra, Gold Medal Nursing/Admin. Ms. Abhipriyam Gehlot, Dr. Pritika Ravi, Dr. Poonam Katoj, Dr. Jatin Jain, Mr. Kumar Arpit, Dr. Lashmi Shanmugam, Ms. Anusha Rathi, Dr. Nimi Elizabeth. Further going on, these were the medal winners. Further, I read out the rest of the list of these beautiful young people who are glowing in their gowns. Dr. Anshika Arora, Dr. Bezavata Niharika, Dr. Bhanupriya Panwar, Dr. Gina George, Dr. Gitali Bhagwati, Dr. Habib Ali Beg, Dr. Harshita Yadav, Dr. Jashbir Singh Roy, Dr. Komal Kailash Chandra Biani, Dr. Magesh Rangaswamy, Dr. Manjari Kumar, Dr. Narendra Paul, Dr. Pankhuri Kumar, Dr. Partha Guchet, Dr. Rajat Prakash, Dr. Shipra Dobral, Dr. Sushma Yanamandra, Dr. Vinesh Joseph, Dr. Naman Jain, Dr. Vinay Purbia, Dr. N. Ashok Vishwanathan. CICP 5, I'm also calling together, ladies and gentlemen, Dr. Arya S. Kumar, Dr. Ashutosh Pandey, Dr. Baby Merunisa Ansari, Dr. Divya Bharti Arumugam, Dr. Jisha T.U., Dr. Lata Shiuran, Dr. Malvika Biswas, Dr. Shalini Singh, Dr. Shreya H., Dr. Shweta Rena, Dr. Supriya Mukund, Dr. Mohoj Smita Vijayaraj, Mr. Anil Kumar, Dr. Kaushik Kumar, Ms. Deepa Kumari, Mr. Lambam Mary Devi, Dr. Ruchismita Pradhani, Ms. Tejendra Kumari. Big round of applause for this entire group of the CICP, ladies and gentlemen. Very much. May I request you to please take the single file from the left side of the stage. I'm done. That's it. Actually, half of you can go this side. Half of you can go this side. Thank you very much, Dr. Garg. Thank you very much. Graduates, you must realize we have enough time for individual photos later. Graduates, may I please request you to step off? Next year at Cahocon, Chennai, we are introducing the Caho Police. Let's Caho. Ladies and gentlemen, the chief guest for the prize distribution ceremony, may I please request to invite on stage Mr. Rupak Barua and Dr. Sanjeev Singh. Brito, come here. Shoo your people away. Go. Tell them to step up. Go. Two? No, doesn't work like that. May I request Dr. Rupak Barua and Dr. Sanjeev Singh to come on stage? We begin with the winners of the Olympiad. May I request in the professional category our faculties to come on board, Dr. Geeta Fulari, Dr. Malti M, and Dr. Vidya Mani. I request Dr. Geeta Fulari, Dr. Vidya Mani, and Dr. Malti Murugesan to kindly come up on stage. Malti. Thank you very much. I request all of you professionals as well as in the students category, let's take Olympiad winners in the professionals category. Ms. Devi Krishna, Mr. Pavan Kumar Dulipudi, Mr. Jagin P, Ms. Pradeepa M, Dr. Sana Amreen Mahmood Syed, Mrs. Bani. Ma'am, that's all. Nobody said. Mrs. Bani Prasanna Bera, Mrs. Kiran Kumawat, Dr. Jatin Jain, Dr. Thipagali Pranati, Dr. Nimmi Elizabeth George, Dr. Swati Gupta, Ms. Namrata Desai, Dr. Archana Konar, and Mrs. Joel Saha. And now in the students category, Dr. Sumangal Bose, Dr. Vincy Bernie Sweepy, Mr. Paul Christopher S., Mr. Deepesh Sriram Balasubramanian, Ms. Palak Pal, and Mr. Bhupesh Kalangutkar. Ladies and gentlemen, big round of applause for the Olympiad winners. I'm sorry, but I'd also request Dr. Amita Marla, Dr. Usha Manjunath to also come on stage. May I please have Dr. Anita Marla? I'm extremely sorry. Dr. Amita, my apologies, ma'am. Dr. Usha Manjunath is here. Can the students and the professionals spread out to cover all our faculty so that we can have a very good, beautiful photograph? Ma'am, sirs, sir. Sir, second sir, third sir. Pull everybody, my friend. Thank you very much. Thank you, Dr. Marla, and my apologies once again. I think I've forgotten Dr. Aruna George, Professor Elizabeth Workey, and Ms. Devashri Chatterjee to also come on stage. Kindly wait with the photographs. We have, Students is done, no? Already I have no students. Come, no, what is your problem? One person more or less in the photograph won't kill anybody. Come. Anybody else wants to come? Jai udhar khade rahiye. आपका क्या है? Politic quiz है ना? ये क्या हो quiz है या politic? Politic professional. हाँ. नहीं, ये क्या है? Olympiad विधान से इसी में आप हो. जाके खड़ी हो जाना मेरी दीदी. May I kindly request the Caho Quest winners also to be available? But Anna's name is not there. Okay, thank you very much, Olympiad winners. Big round of applause. Thank you, Dr. Vidya. Thank you, Dr. Amita, Dr. Malti, and Dr. Geeta Fulari. Dr. Sanjeev Singh, kindly continue to be on stage. Your haloed presence blesses us all. That's done. It's gone. Students are gone for the quality quiz. ये था ना Olympiad winners. What is quality quiz? I don't have winners for quality quiz. Okay. Ladies and gentlemen, last year, under Vijay sir and Lalu ma'am's guidance, I undertook what is called the CEO boot camp sessions. Currently, I'm heading it, so I will also come there. Don't take the photograph without me, please. Are you? Sir, are you okay? Okay. Ladies and gentlemen, the CEO boot camp professionals who are present here, we've had two, and I'd urge you to register for the CEO boot camp. Ladies and gentlemen, please welcome Dr. Lieutenant Colonel P. Mahendra Kumar, Dr. Ayush Gupta, Dr. Ankita Chawla, Dr. Anupam Karmarkar, Dr. Bipin Chevle, Dr. S. Santosh Kumar Dora, Dr. Sambit Kumar Das, Dr. Suvin Shetty, Dr. Sapnil Kharnare, Dr. Vijay Lakshmi Gopakumar, Mr. Ravi Pratap Singh, Mr. Utkarsh Bhote, Mr. Varun Kumar, Mr. Veera Sekaran Subayan twice, and Mrs. Shweta Sharma and Ms. Jalpa Raichura. Ladies and gentlemen, big round of applause for the CEO boot camp. We intend having three CEO boot camps this year. Hyderabad and Jaipur are finalized. We'll let you know the dates. Thank you very much. From the left, sir. Okay, moving on to the Indian Institute of Public Health Gandhinagar Best Practice Awards. May I kindly invite on stage faculties Dr. Deepa Saxena, Dr. Bipin Chevle, Dr. Ravi Kumar R, Dr. Subin Shetty, Dr. Apurva Kumar Pandya, and Dr. Medha Vadva. Ladies and gentlemen, please give our faculties a big round of applause. Please welcome on stage representatives from the following hospital. GMERS Ahmedabad, Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata, Parul Sevashram, Vadodara, Vijaya Medical and Educational Trust, Chennai. Okay, CEO boot camp. Move, please. Your time is done. Bhada khatam. Koli khali karo. Ladies and gentlemen, please put your hands together for GMERS Ahmedabad. We'll be calling two names of hospitals. The next hospital, kindly be ready. The next hospital is RTIICS Kolkata. Writing, please. Go there and give it in writing. Let's keep a 15-second turnaround time, please, for photographs. We can't take more photographs than that, ladies and gentlemen. Thank you very much, GMERS Ahmedabad. Please welcome Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata. Can I please request Console to switch off the slide names, please? Okay, that's right. Now it's come. Thank you. Can we switch off the console slides, please? Can we please switch off the console slides? Console, can we please switch off the slides? Thank you very much. Rabindranath Tagore International Institute of Cardiac Sciences, thank you very much for being on stage. The love and affection for you knows no bounds. Suvin, thank you. Hand it over. Thank you very much. Parul Sevashram Vadodara. Thank you. Request our recipients to kindly exit from the left side, and can you please vacate the left? Vijaya Medical and Educational Trust, Chennai. Indraprastha Apollo Hospital, New Delhi. Indraprastha Apollo Hospital, New Delhi. Baby Memorial Hospital, Kozhikode. Baby Memorial Hospital, Kozhikode. Indraprastha Apollo, kindly wait. Baby Memorial is receiving. So please wait. Big round of applause for Baby Memorial Hospital, Kozhikode, our very own respected Madam Gracie Mathai. Thank you, ma'am. Thank you, sir. Indraprastha Apollo Hospital, New Delhi. TK Birla Hospital, CMRI, Kolkata. Okay, I have. TK Birla Hospital, CMRI, Kolkata. KD Hospital, Ahmedabad. KD Hospital, Ahmedabad. Thank you very much. KD Hospital, Ahmedabad, please come up. Fortis Hospital, Mumbai. Next coming up, Rajagiri Hospital, Kochi. Next coming up, Rajagiri Hospital, Kochi. Rajagiri Hospital, Kochi. KIMS Hospital, Rajagiri Hospital. Please give a big round of applause for Elizabeth David. Also a birthday today. KIMS Hospital, Gachibowli. If you're here, please come up. Coming up next will be GMERS Solar. GMERS Solar coming up next. GMERS Solar. Next coming up, Sri Satya Sai Institute. Sri Satya Sai Institute. So kindly wait for it. Thank you, sir. Thank you, Sola. Sri Satya Sai Institute. Coming up next, Manipal Hospital, Bengaluru. Coming up next, Manipal Hospital, Bengaluru. Is Manipal Hospital represented? Thank you very much. Manipal Hospital, Bengaluru. Coming up next, Bhatia Hospital, Mumbai. Coming up next, Bhatia Hospital, Mumbai. Coming up next, Hospital for Mental Health, Ahmedabad. Congratulations, Bhatia Hospital. Hospital for Mental Health, Ahmedabad. Coming up next, Christian Medical College, Vellore. Coming up next, Christian Medical College, Vellore. A big round of applause for CMC Vellore. Thank you very much, faculties. You can step down. I'd just like to have Secretary General, ma'am. The awards are done. Thank you, II PhD faculty, as well as all the Cahoites. Coming to CahoQuest, the last but extremely significant part of the awards. May I request Ms. Devashri Chatterjee, Dr. Anna George, and Professor Elizabeth Workey to come up on stage. CahoQuest. Let's start from the third place. In third place, Nazareth Hospital, Shillong. May I invite Dr. Pramod Paharia, Dr. Ankita Sharma, and Dr. Evaris Lingdo. I repeat, Nazareth Hospital, Shillong. Dr. Pramod Paharia, Dr. Ankita Sharma, and Ms. Lindo. In second place at the Cahocon Quest, we have Astor Hospital, Whitefield. May I invite Dr. Rashmi Palad, Dr. Vrishali Vikas, Dr. Ashray, Dr. Isha, and Dr. Pradeep. Thank you very much. And the winners of Cahocon Quest in first place is JSS AHR, Dr. Mangesh Rangaswamy, Ms. Kavita Krishnan, and Dr. Neeta. Big round of applause. Thank you very much. Faculties, kindly step off. I request Secretary General Ma'am and President Sir to stay on age as I invite for the I Comply Center of Excellence and Award that was missed out earlier today. Ajara Hospitals, Warangal, Telangana. Please welcome them. Ajara Hospital, Warangal, Telangana. Please put your hands together for this lovely hospital. I'm very impressed with the dedication of this hospital. They've practically hired a bus and come down, flown an entire plane. Congratulations. Thank you very much, ladies and gentlemen. That brings us to the end of today's awards ceremony. Signing off from day one and getting ready to get into day two tomorrow. This is your host, Dr. Parag Rindani, signing off for today. Thank you very much, ladies and gentlemen. Please don't forget, tomorrow's proceedings start at 7:30 a.m. in some hall, 9 in some hall, and 8 o'clock in some halls. Find yourself something to do. And as we say at Caho, let's Caho! Request Dr. Anuradha Pechumani. May I request Dr. Anuradha Pechumani to come over and take charge of the annual general body meeting of CAHO. Over to you, Dr. Anuradha. I'll take all my little papers and scoot from here. Ladies and gentlemen, while you're welcome to stay for the annual general body meeting of CAHO, the one request is we step off the stage. That's about 1 more minute to be on the stage. We're starting the AGM. May I request Dr. Shankar Sen Gupta, Vice President, as well as Naren Sir, Treasurer, to kindly come on stage. In about 45 seconds, I'll be coming with the bulldozer that side, ladies and gentlemen. To kindly step off. I can say it in about 16 with different languages between Anuradha and myself. One of the requirements of the annual general body meeting is pin drop silence. So if you're not interested in attending the AGM, if you don't have business with the AGM, our humble request is to step outside. Thank you very much. Please return your gowns and your caps and quietly exit. Ma'am, on the left, please. Sir, ma'am. Not you. Ma, step off, please. Dr. Anuradha Pichumani, over to you, ma'am.
Thank you, Dr. Parag, and did a wonderful coordination the whole day. We all appreciate you. So good evening, everyone. It is with immense pleasure and pride that I welcome all of you to the annual general body meeting of CAHO. It's a momentous occasion to reflect, realign, and reimagine our journey towards excellence in healthcare. And a very special welcome to our CAHO leadership team here, the governing council members, state and zonal leaders, wing chairs, forum members, and every dedicated CAHO member who has taken the time to be with us today. Your presence and participation are the driving force behind CAHO's progress and purpose. So this gathering is not just a statutory requirement, it is a celebration of collaboration. And over the past year, CAHO has continued to grow as a powerful movement, a vibrant network of hospitals, professionals, and partners committed to quality, safety, and continual learning. We have seen remarkable initiatives from capacity building programs, national and international summits, and cross-sector collaborations. And each one of you have played a role in this transformation. And for that, we thank you all. And as we convene today, let us also remind ourselves of the responsibility we carry. Healthcare is evolving faster than ever. Patients are more informed, systems are more complex, and expectations are higher. CAHO must continue to lead from the front through advocacy, education, innovation, and inclusive engagement. This AGM is our platform to look back with gratitude, take stock with honesty, and plan ahead with vision. So let us all use this opportunity to listen, share, and decide collectively and constructively. As Henry Ford has said, coming together is a beginning, keeping together is progress, and working together is a success. So on that note, I welcome all of you once again and look forward to a meaningful and inspiring session ahead. Thank you. And it's now my honor to invite Dr. Vijay Agarwal, the President of CAHO, the visionary leader, to deliver the opening remarks.
Good evening. Good evening, friends. I'm sure that you have experienced what a CAHO event can do to you. And I'm right from morning till night, till this evening, we have all, I think, remained glued to one thing or the other in the entire day. Friends, it's my proud privilege to address you and to welcome you into this annual general meeting. I can say that this whole year has been very fulfilling, very rewarding. The manifestation of what we do throughout the year gets reflected into the events when we meet at Cahocon, or we met earlier at Cahotec or at Cahocon or at Diagnosticon. So all these events are the melting pots of all the ideas, and all of us together, we are trying to take this movement. We recently, just now before this meeting, we had a very fruitful meeting with our International Advisory Committee and guests. And even they were quite overwhelmed by what Caho has been doing. And in fact, the same advice from them was slow down, probably slow down, but we don't know. I think the agenda before us is very huge. The agenda before us is very serious. I don't think that we can rejoice into this glory of a very successful event, because our glory will lie when we will see our healthcare institutions providing safer care. And towards that, we are extremely proud that what you saw in the last 1 hour, you saw almost like a parade of people. And you might have thought that it's like a routine award distribution, but it was not. Ladies and gentlemen, this was a outcome of very serious exercises that have been going on, whether to stimulate institutions for the best CSSD practices. And they have been demonstrating that going through that exercise has resulted into a much better CSSD controls and all that. And similarly, all the other programs have been all very, very serious academic exercises. And we are so proud to see that the people coming from tier 2, tier 3 towns and receiving these awards. Receiving these awards means that their institutions are participating, their institutions are coming forward. I can tell you one thing, that the time has come that these hospitals from tier 2, tier 3 towns are going to show to our corporate hospitals what is the way to embrace quality and what is the way to embrace patient safety. So we are very proud of this movement which is reaching out to the grassroots. Friends, we have come out with our annual general meeting. I'll request Dr. Lalu Joseph to probably give a synopsis of it. There won't be much time to probably the read of whole of it, no way. But there is a report that will be given to you, circulated to you. All I can say is that we are in reasonable kind of health on all fronts. I must say that in this year, the notable thing is that must compliment also our Caho International branch that was just created last year. And we have made progress. We have had an event in Sri Lanka. We have had an event in Nepal. And next month, we are going to make an event in Abu Dhabi. I can say that to some extent, probably Caho has arrived. We last just few weeks back, there was a ministerial conference of WHO and ADB in Philippines, Manila, where Caho got a representation to speak about our views on the issue of how do we promote patient safety. And I can say that definitely that was, similarly, I can say that our voice probably is going to be heard by the policymakers, etc. Hopefully, we are all in this journey together. I think we need your indulgence, we need your cooperation.
to take this movement forward. Very soon, we need more leaders. Already there are there, but I think we need people who need to put us now into oblivion. At least I am the one who needs to go into an oblivion in the sense that I will be there, but we want people now to come forward and take on the battle at the national level, at the zonal level. You're all doing, but I think we need much more. What we can say is, dil mange more. My heart desires more, and I am very, very overwhelmed with the kind of response, the kind of love and affection that is being showered upon Caho. It is being showered upon the movement of, I'm really touched that how patient safety has become an issue. How to move beyond accreditation has become an issue. And I think definitely we are on a path when we are going to make accreditation a meaningful exercise from just wo 5 din. I think so. Thank you very much, and over to Lalu Joseph to go further.
Thank you, Dr. Vijay sir, for your inspiring words. Your vision and passion continues to guide Caho's journey, and we look forward to translating that vision into meaningful action together. And now it gives me immense joy to invite someone who truly embodies the spirit of Caho, our Secretary General, Dr. Lalu Joseph. Her energy is infectious, her commitment unmatched, and we all know if Lalu is on it, it's getting done. So over to you, Lalu, to present the Caho's annual report.
Thank you so much. I don't think we have time at all. This is obviously a statutory requirement. We have been having regular meetings with our governing committee, and it gives me immense pleasure, privilege to present to you a gist of the activities that we have done. Unfortunately, we do not have time. I've prepared a very detailed report. I will get them circulated to you very shortly. But quickly, let me in the next 2-3 minutes take you through some of the activities. Our governing committee meetings have been happening very, very regularly. So the effectiveness of a committee, I think you can look at it. Look at January month, and we've had 102 people out of the 147 governing committee members present in the meeting. This is real impact. Let's give ourselves a big round of applause. And every month we have been having our governing committee meetings, and it's been extremely useful presenting what we've been doing. I'm not getting into a lot of details. The professionals trained so far is 37,000 plus. Again, I wish to thank all the faculty who give their time, efforts, energy to put together training program and be available as and when the Caho Secretariat calls them for training. As on date, we have 72 training programs running. Ladies and gentlemen, I think we have certainly become an academy. So credit goes to all of you. Give yourselves a big round of applause for what you have achieved. The 3 divisions have been functioning very well. At this moment, I wish to thank our dear chairperson of the Caho Healthcare Division, Father Johnson. Please raise, let's give him a big round of applause. Father, yes. Thank you for leading the healthcare division. Our own Dr. Anuradha Pichumani, thank you so much for the quality professionals division. Anu, please raise. And Dr. Aparna Jairam. I think this is one vertical that has seen tremendous growth this year. All laboratory professionals here wish to really place on record our appreciation and gratitude to all of you. Do we have Dr. Ravi Kumar, Dr. Aparna, Dr. Vinita Kotari? Yes, Dr. Aparna, please come forward. Let's give her a big round of applause. Dr. Ravi Kumar, where is sir? He's missing. Thank you so much. Wonderful. And we had 2 rounds of CEO bootcamp. This is something that we thought we must start to connect with our CEOs. Thanks to our dear friend and the West Zone Chairperson, Dr. Parag Rindani, for taking it to the next level of excellence. Imagine today, we had 475 CEOs of hospitals. At one time, we were thinking this organization is only for quality managers, the junior level people on the ground. Thanks to the healthcare division and all of you for making this go to the boardroom. So some of the other statistics, and I think we really need to place on record our appreciation to the research and journal committee of CAHO. Professor Satish, Dr. Chinmay, Dr. Pratish, are you around? And Dr. Ibanish. Big round of applause to them. We have a very formal research committee today and the journal we launched this morning. Some of the updates from the North Zone. North Zone is headed by Dr. Atul Kapoor, Dr. Shweta Prabhakar. Shweta, please. Yes. We had several state conferences, several webinars conducted by Dr. Shweta and team. The West Bengal's, I'm not getting into, Jeet Patwari for the East Zone. Do we have Jeet here? Okay. The West Zone again, Dr. Parag Rindani. Let's give him a big round of applause. And the South Zone, Mr. Ranjit Krishnan. Mr. Ranjit, are you here? All right. Have I missed out any zone? The Central Zone, Dr. Atul Kapoor. Lot of activities have taken place with the leadership of all our zonal chairpersons. Let me invite all the state chairpersons to kindly rise. All the state chairpersons. Let's give them a big round of applause. A very, very active group. They've had state conferences. They've really activated the stage so well that we are very, very proud of you. I wish to take this opportunity to announce the new state chairperson of Tripura, Dr. Vishal Goyal. May I maybe invite him on stage and introduce him to the governing committee. Dr. Vishal, please come forward. Let's give him a big round of applause, encouragement, and invite him into the governing committee of CAHO, the state of Tripura, Dr. Vishal. The CAHO International Forum, as Dr. Agarwal mentioned, has been very, very active. The CAHO International Advisory Committee is one, and the International Forum, headed by Mr. Samir Mehta, his very vibrant team of Uma Shankar, Chakravarti. Where are you all? I don't see. Yeah, there's Sam, please. Let's give them a big round of applause. Where are you all? Where is Chakravarti? Sam, where is your team? Brilliant. Now, there are several forums. The Healthcare Engineers Forum is one that has seriously taken us to the next level of excellence. Do we have Vinod and the Healthcare Engineers Forum, please? Yes, let's give him a big round of applause. Chokalingam, Manju there, Jennifer, Prem, Arul, big team. It's an army, I must say, that we decided that we'll divide them into 3 wings. The clinical engineers, healthcare and maintenance engineers, and also the planning engineers. Thank you so much for what you have done. The Clinical Dietetics Forum, the very powerful ladies, are you here with us? Yes, they are there. Let's give a big round of applause for the amazing job they have done. Several webinars. They ran a workshop, pre-conference workshop with over 200 participants. The Ayush Forum. Do we have Dr. Shweta? Ayush Forum? All right. Do we have Gayatri? Yes, please. The Ayush Forum, our mentor is here. Thank you so much. Do we have members from the Pharmacy Forum? Manisha Paul and Brito, are you around? Okay, we have several collaborations now with the pharma, particularly with the Sun Pharma. One webinar that we hosted had 4,000 participants, pharmacists across the country. Big time, it's really heartening to hear how people come forward and join these forums. We have the Global Rehab Forum. Dr. Saril and Saluman, please come for, where are they? Saril, Saluman? Okay. Sustainability Forum, our power-packed Kirti D'Souza and Karan. Let's give a big round of applause. They have developed a tool to certify conferences as sustainable events. Kirti, please. You really need many more. And this is going to be a one-time activity of CAHO. It's going to be certifying conferences that are green conferences. Have I left out any other forum? Our new forum, the the supply chain forum. Do we have the representatives here? Okay, the technology forum is the new kid on the block. Dr. Manish, please come forward. He's taken the responsibility to take us to the next level of excellence. This is the need of the hour. Dr. Manish, please come forward. Let's give him a big round of applause for the initiatives that he has undertaken. Tomorrow we'll be launching. There is going to be a roundtable. We are going to be having CTOs from 13 hospitals coming and joining us. A big round of applause to our own Professor Ravindran Jagasoti for the International Advisory Committee. And I request all the members of the International Advisory Committee to kindly rise. Dr. Shinnu Shiro, Mr. Andrew, Nisha, thank you so much for the value addition to CAHO. Thank you. Let's give them a big round of applause, please. On behalf of the Governing Committee of CAHO, I wish to place on a record our appreciation to the Organizing Committee of Cahocon 2025. Let's give a big round of applause to Dr. Anupam Sibal, Dr. Yashpal Bhatia here, Dr. Sanjeev Singh, please. Sir. Dr. Upasana Arora, and all the committee leads for taking us to the next level of excellence here. Delhi certainly has been amazing. Thank you so much for that. Now there are a lot of things to project, promote. Let me take this opportunity also to thank the contributions of all our patrons, and I invite them to the stage. Dr. Girdhar Gyani, Dr. Pavan Kapoor, Sir Nagendra Sami, sir, please come. We miss Dr. M.I. Saadullah and Dr. Alexander Thomas. Please come on to the stage. Dr. Tupil, sir, not here. Please. And a big round of applause to our CAHO Student Engagement Committee. This again, Dr. Amita Marla and team, please. And we now have a medical student engagement wing, Dr. Sunil Mundkur and Dr. Javahar Pillai. We have the MHA Hospital Administration wing, and we also have the Allied Health Professionals wing, along with the Nursing Professionals wing. Let's give them a big round of applause. So, all this is just not possible without the CAHO Secretariat. We have really become big as a result of the kind of work done by the CAHO Secretariat. Can I invite the CAHO Secretariat team to please rise? Let's give them a standing ovation. I think all of us really need to thank them for the amazing work that these young boys and girls deliver. I don't know where they are. Can I invite them onto the stage, please? The CAHO Secretariat team. Sakshi, Meenakshi, Preeti, Sonali, Ebanish. Where are you all? Rabina, Preeta, Prakash, Ebanish, Anita. Have I missed out anybody? Pramod, Shalu, Preeta, Nisha. Prakash is hiding. Come, Rabina. Oh, yeah. Who's there? Yeah, my eyes are come, da, Ranjana, Bobisha, please come. Come. Where's Abdul? Prakash, Abdul, Let's give them a big round of applause, please. Tireless efforts by the Cajon Secretariat. We are very, very, very proud of you all. Thank you. And we've had lots and lots of technology implementation. Our LMS is active. Our social media is extremely active. Thanks to, do we have the social sculpt here with us? Our social media team, IB's, our technology partner, lots and lots of people working together to put everything together. Thanks to everybody. And let me take this opportunity to invite Dr. Nareen Segal, the financial advisor plus the purse of Cajon, to tell you the financial stability of Cajon. Sir, please come. We just want to hear from him whether we are okay or not.
Good evening. I think nobody is interested in finance at the moment. There is a party which is going to happen and, nobody, See, if you ask my journey, 1 year back when I entered Cajon, it was like tsunami. Not only the number of activities, but also the figures. And every day, so many messages. Okay, what has happened to this receipt? Has this payment come? Where has this gone? No details. And then I get a call from Dr. Vijay. Naren, we need to do something. We are doing everything, but somehow things are not falling in place. I said, sir, I will try. I am not a person who is a financial wizard or anything. I don't think I can dare, but yes, I have an idea. My finance person, he's very good. He helps me around. I don't need to do anything. I will get him along if you allow me. He said, yes, why not? So we had a meeting together, and there in the meeting itself, I mean, even I was surprised of his abilities more than what I knew about him. And he suggested some changes, and over a period of next 3-4 months, I think we made those changes and a lot of difference happened. This is one thing which we solved. Second was FCRA account, because it is such a pain, I tell you. We are still not, we have not been able to succeed, but we are really running after this. If we are able to achieve that, I am sure next time the help which we can get from some of the overseas friends and industry will be a great help for this. In any case, when I see the figures of and compare the figures of 22-23 and 23-24, I think we had a turnover of at least 70% more than the previous year. And let me assure you, this is not a forum to give you small figures, but our financial health is very healthy. And I wish and I need support of all of you, because this money is not coming from big places. This is from all of you. So this should continue.
Ladies and gentlemen, I want you to give a very special applause for this gentleman who happens to be the first true finance secretary of this organization. Right? Thank you.
Thank you so much, sir. I think it is the love of this organization and the potential which I see, how much of learning is there, that it makes my journey beautiful. Thank you.
Thank you. Let's give him a big round of applause. We know we are in safe hands. Sir has really brought in a lot of systems in place.
I have another good news to kind of share with you, that Dr. Kiran Bedi will be coming tomorrow, and Dr. Narottam Puri will be interviewing him. We had earlier, now she just came back probably from her trip and has communicated her desire that she will come. So we'll be very happy that tomorrow afternoon, we will have the pleasure of one icon in our country, Dr. Narottam Puri himself. In fact, we had made a program that he was going to be interviewed by Dr. Pawan Kapoor for his science and art of radio and TV commentary. But now we will take that opportunity some other time. And Dr. Narottam Puri will be interviewing Kiran Bedi, and we'll hear her speak and give her pearls of wisdom to us. Thank you.
So let me end again by thanking all of you. Big thanks to also our Patients for Patient Safety Forum. They are doing amazing job, and the commitment with which Mr. Somital and Madam Nadira Chaturvedi. Som sir, please rise, please. Yeah. Big round of applause to Som sir. And also, it's so heartening to see the organizing committee members of all our previous conferences who have come all the way from Hyderabad, from Kerala. I think, please, if we can give them a good round of applause, that clearly shows that they are all connected to Caho. We truly appreciate you for taking your time. The forum is now open. Any questions from your side, we are happy to share with you. The financial report, the audited balance sheet will be shared with you. And also the annual report will be sent to you very shortly. Any questions from any of the members? Floor is open. Our emails go to 70,000 people through Salesforce and Pardot. That is the growth of the organization today. Any questions, please? If there are no questions, there's something wrong. Yes, I'm going to end it now. Let me now call Dr. Elizabeth David. It's her birthday. She's part of our family. Let's wish her a very, very happy birthday. Dr. Elizabeth. Dr. Elizabeth. Where is she? I thought she's around. Okay. So thank you. Thank you so much. So requesting all of you to kindly join for our photograph. All the governing committee members along with the patrons, please. Please come forward. Request all the forums to please join. The forum members, the governing committee members, patrons, please join.
For Devashri, come, you have to announce what's coming. For those who are really hungry, there is some food. For those who are desperate for a photograph with our Caho privileged folks, there are opportunities in the front. Please sponsor us next year. Only condition. Announce what is coming.
Well, we'll take 15 minutes to reorganize ourselves, and there are loads of surprises for the evening. Loads and loads and loads. Need the chairs. Everybody's busy.